ना डॉक्टर नवीन, अरे आओ ना, आ गया। Well, good afternoon, friends. हम ये यथार्थ मेडिकॉन 2.0 हम इस सेकेंड ईयर में हैं, तो हम इसको शुरुआत करने जा रहे हैं। It really gives me immense pleasure and pride to welcome you all for this Yatharth Medicon 2.0. This is our flagship continuing medical education program. And on behalf of organizing committee and Yatharth group of hospitals, I extend my warm welcome to all the delegates, the faculty members and guests who have joined us today. Building upon the success of the inaugural Medicon, which we did last year, Medicon 2.0 reflects our continued commitment to academic excellence, clinical innovation and collaborative learning. The field of medicine is evolving at an unprecedented pace, and so as the healthcare professionals, it is our responsibility to stay abreast of the emerging trends, technology and best practices of medical care. This CME serves as a vibrant platform to exchange the ideas, share the experience and learn from some of the finest minds in our industry of healthcare. We are privileged to have with us eminent panel of speakers and experts who have graciously accepted our invitation to enlighten us with their knowledge and experience. And I can assure you that they are experts in their field, whether it is the respiratory medicine, whether it is the cardiology, the gastroenterology, endocrinology, or sexology. Their insight will no doubt enrich our understanding and help us translate new learning into better patient care. I would also like to take a moment to acknowledge the tireless efforts of our organizing team, our hospital staff, support staff who have worked with great dedication to make this event possible. As we begin today's session, I encourage upon everyone to participate actively, interact freely, and make the most of the academic feast. Let us make Yatharth Medicon 2.0 not just a meeting of minds, but a celebration of medical learning and collaboration. Once again, I welcome to all, and I wish you an intellectually stimulating and enjoyable experience where we will be having a gala night after the extensive deliberation of scientific medical science which our experts will be doing. With this, I again welcome you all, and I expect that it will be a very good interactive session with everyone. To start with a first session, I would like to invite first the chairpersons, Dr. Vipul Mishra, to please come on the dais. Dr. Sandeep Sahai, our Director of Department of Medicine at Greater Noida, Dr. Rahul Punj, And if Dr. Rajesh Mohan if he is there, okay, at least our 3 chairpersons are here. They will be chairing the session. And I want to start this session with a bang. You know, I want to start this session with none other than Dr. Deepak Talwar. Dr. Deepak Talwar, of course, the chairpersons will introduce, but if you see Dr. Deepak Talwar, you will realize आपको कबीर दास जी का दोहा ध्यान आ जाएगा कि देखन में छोटे लगे घाव करें गंभीर. He is such a good orator and knowledgeable person and a very known faculty, not only nationally but internationally also. Over to our chairpersons.
Good afternoon everyone and welcome to this first session. It gives me great pleasure to introduce the speaker who has been my teacher, my mentor, and not just to me, to I think now thousands of students. He is one man who has been instrumental in establishing the department of and the specialty of pulmonary medicine and respiratory critical care medicine at Metro Hospital, Noida. I will not say much because I start speaking about him and his accomplishments and his publications. It will take like hours and this conference will be over. So I know you all know him very well, and without any further ado, sir, please.
Thank you, Vipul. And nobody can say no to Dr. Soni when he calls you, you know. And today it was a very difficult day for me to come, but I think there is one person who will never hear no from anyone actually. I think he is the one of them. And he just refused to listen to no, and I said, okay, I will be here. And he asked me to talk about ILD, what clinicians should know. I think a very important aspect. And I was just talking to Vipul that Vipul has been, I think, the first consultant who worked with me. And I think the journey is already covered 25 years. So I think Vipul is very, very, very senior. I will say that. Very, very senior. And he has spent, I think, the maximum number of years with us. And I think he knows respiratory medicine more than actually me now. I will say that. And I was very fond of teaching him all the times we were discussing that. ILD was at the time when I think Vipul was about to leave, that we started with the MDD in interstitial lung diseases. That was way back in 2008, 2009. And finally published the ILD Registry India, which was published in the Blue Journal, American Journal of Respiratory and Critical Care Medicine in 2018. And that was the hallmark which gave us the idea of what the ILD looks like in India. It was totally different from what we see as ILD in the rest of the world, and it was a situation which was very grim and required intensive efforts from not only the pulmonologists but very importantly from the clinicians to make an early diagnosis to change the trajectory of the disease, which is so bad that the name itself means a death sentence. So moving on, the conceptualization of interstitial lung diseases, it is a disease of interstitium, and the job of interstitium is to let the oxygen from the air get into the bloodstream and provide to each and every organ of the body. But conventionally, interstitial lung disease also includes the diseases of terminal airways. So it's not only the interstitium, but the terminal airways are also a part of it. And that makes things very, very difficult and complex for us to comprehend in daily practice. So you can see that there are nearly 1,000 entities which are called as interstitial lung diseases under one big umbrella. And out of which nearly 2 to 3 are added as new entities every year. So we are like getting it more and more and more. And by name, we can call them 200 of them, 200 of them. So when a clinician sees a patient of interstitial lung disease, it is all clubbed together as one as ILD. 2, ILD is a very gloomy diagnosis, and 3, one of the relative would have googled it, that average survival after the diagnosis is 2.8 years, which is worse than lung cancer and even worse than any other disease because it has no treatment. So you are going to die anyways. So with that kind of a concept, when the patient walks in with an interstitial lung disease diagnosis, I think we need to realize it's a heterogeneous disease. All of them don't behave like that. Only one subgroup of this disease called idiopathic pulmonary fibrosis is the one in which people die very soon. And there is very little options for the treatment. But all other varieties have cause. So obviously if the lung is getting injured, then it has to be injured by something through the air or something through the blood. There is only 2 things which are going through the entirely lungs. So you have either exposure related or blood related causes of interstitial lung disease, and you can see some of the important ones have been mentioned here. And the most important in India is the hypersensitivity pneumonitis, which is related to exposure to organic dust. And we are talking about here fungi, we are talking about here the droppings from the pigeons and the feathers and the most common causes which are there. This accounts for 47% of interstitial lung disease in India. And that was the ILD registry India which opened the minds of the people, because rest of the world sees about 20%. We see practically every second patient coming to us as an interstitial lung disease is hypersensitivity pneumonitis. And then followed by CTD related, which is autoimmune diseases, which is our rheumatologist and physician friends who are looking after them. And then drug toxicity and so many other diseases which are not very common. But yes, one more is a sarcoid interstitial lung disease, for which of course we do a lot of work on that. So the main crux of this disease is that the diagnosis is delayed. Now this diagnosis is delayed not only in India, it is worldwide, everywhere. So nearly when the patient of ILD goes to any physician, the 1 out of 2 will miss that diagnosis at all, because symptoms are non-specific, dry cough, breathlessness, which are most common symptoms of airway disease, which is related to like COPD or asthma. So it generally requires, this is US data, 3 doctors to see before you suspect an ILD in an individual patient. So you need to go to 3 physicians and then you will think about it that there is something wrong and it may be ILD. And by that time, normally 2 years have already passed, and that honeymoon period of interstitial lung disease where it is more inflammatory, less fibrotic is already passed, and now the patient is frankly fibrotic. Because that's the way we used to diagnose tuberculosis, but now of course we have guidelines too, which will change this picture over a period of time. So what does this late diagnosis means? Obviously it translates to more morbidity and more mortality in this group of patients. So by the time they come to us, less than 50% will survive for 4 years. That's the bad part of the story. The reason being they are mostly fibrotic, and once the fibrosis is there, it only begets more fibrosis and it cannot be reversed. We all know these terminologies. They will never ever change. So in India, the situation is much worse. So if you see this data, which we again published long ago, which clearly showed that an average survival of a patient of interstitial lung disease in India of whatever cause is roughly about 4.5 years, 4.5 years from the diagnosis. Obviously this data was prior to nintedanib and pirfenidone, so things would have changed, and I would have expected now the data should show about 8 years of survival in some of them, not all of them. So how do we improve this disease trajectory? How can we make these people live longer as well as live better? So for that we need to diagnose it early. We need to diagnose it at the time when there is less fibrosis, more inflammation. Lungs can't get fibrosed out of blue. There has to be some injury, there has to be some inflammation, there has to be a dysregulated inflammation, and then finally leading to development of fibrosis and more fibrosis. So we need to diagnose it early. So if you look at the symptoms, dyspnea, cough are the same symptoms, but they just refuse to go away. So this is the most important thing. They also refuse to go away in COPD. So that's why the most likely diagnosis is COPD if they are smokers. But very important symptom here is a weight loss. So if you can see that the patient says that he has a dyspnea, he has a cough, and he has lost weight, that should immediately raise an alarm that something else is going on in this patient. And 5% of weight loss actually increases the mortality in interstitial lung diseases by 2.5 times, and they lose weight. They all lose weight, not only because of dyspnea, but also because of the excessive inflammatory and fibrotic responses going on into the lungs. Rest everything is almost same when it comes to clinical suspicion of an interstitial lung disease. Dyspnea and cough which refuses to go away and is causing shortness of breath. But the most important thing on the clinical examination is the general physical examination, which we will get the telltale signs of an autoimmune diseases. So this is a very important thing, because these patients don't go to rheumatologists because they don't have a rheumatological disease right now, but they have a respiratory issues. But if you examine them in the general physical examination, you can pick up all those things which are shown here, like heliotrope rash, salt and pepper skin, sclerodactyly, Raynaud's phenomena, excessive dental caries, which is a sign of Sjogren's syndrome, myositis, pains and aches and weakness of the bodies, Groton sign, keratoconjunctivitis, alopecia, head to toe. You need to really examine these patients head to toe. When it comes to examination of the respiratory system, now these days I don't think so people examine respiratory system anymore. Stethoscopes are not required. Most of the times the CT scans are available before actually you sneeze on the patient, because they are so freely available in our country. So you look for two things. One are, we all have been taught in our MBBS Velcro RAS, Velcro. So obviously this is like a Velcro sound which comes out, very high pitched sound. But remember that chest examination in ILD patient, diagnosed ILD patient, in 1/3 of them will be normal. You won't find anything at all. Anything at all, because there the disease may not be in the interstitium, it might be in the terminal airways. As I said, that is also interstitial lung disease. But yes, when you get this Velcro RAS, previously we were taught that it is idiopathic pulmonary fibrosis, but it only means fibrosis actually, it doesn't mean IPF. But yes, the another important sound is a squeak. It's a very high pitched squeak, the kind of sound which the guinea pigs make. And that's the sound, if you hear in the chest, you will never ever forget it, because that sound is coming from opening and popping up of the terminal airways, and it's a very high pitched sound, and it gives an indication that it's an interstitial lung disease which is involving the terminal airways. And if it's a female patient, then 1 in 2 chances are that this patient is going to be having hypersensitivity pneumonitis, which will be looking like asthma, but it is not asthma, because if you pick it up now, this patient will be living like 20 years. But if you miss him now, in 4 years, he will be left with only 2 years to live. So that's how important it is to pick up these kind of signs. They are helpful to us. We look at the lung functions, they are restricted, the TLC is reduced, the FVC is reduced, diffusion capacity is reduced, and those patients, when they are made to walk, they desaturate. And this is very important to see that you can have ILD with a normal lung functions also. So even if you get a normal PFT, it does not mean that the patient cannot have an interstitial lung disease. Then comes our chest X-ray. As I said that we don't auscultate patients these days, we also don't see chest X-rays these days, because our all postgraduates and my all juniors now are very happy to look at the CT scan straight away. But in ILD, there is a problem. 10% of them will show normal chest X-ray. And it's got a sensitivity and specificity, you can see, is something like nothing on which you can make a diagnosis. So you really need a CT scan out there. But yes, future is there. AI will come and the digital X-rays will be reported by them, and they will definitely be much better than the radiologist. If somebody is going to lose the job in next 10 years, it's going to be a radiologist, I'm telling you. because AI is definitely going to ruin as far as most of the reportings are concerned, because it has been already shown that it is better than what two individually separately sitting radiologists are able to do, because they are able to pick it up digitalized pixel by pixel whether it is normal or abnormal. So obviously we know that it is somewhere, we cannot say that it will not happen, it will happen. But even if the CT scan is done, you look at the CT scan, it is never reported as an interstitial lung disease. But what happens 1 year down the line? You have missed the bus completely. The patient shows you that I got a CT scan done 1 year ago and nobody told me I have ILD, and now you are telling me this is my lung, but I have an old CT scan, and then you see, oh God, we missed it, gosh. So that's why I'm saying that the AI will have a very good role out there, and we need to intervene at that point of time. Then it comes to that the CT scans are coming to us, and as a physician you will see that it is written UIP, IPF, that's all. 90% of the times that's what is written on your reports. Hey, it is nothing. It is nothing actually, because radiologists are also on the learning curve at the moment, because what they are trying to say is that they are seeing honeycombing. Now in these pictures you can clearly see how the honeycomb looks like. It is exactly like what we have seen in our childhood days. But every small little cyst is not a honeycomb cyst, and honeycombing only means late fibrosis. So everybody writes honeycombing, UIP, IPF. That's a standard protocol of all CT scan reports you will get, and it will tell you this is IPF, and IPF the patient will live for 2.8 years, and only treatment to give is either pirfenidone or nintedanib and go home and pray to God that, or collect more money so that you can undergo a lung transplant. So that's the only two options you give it to them. Pray to God or arrange for money to go for a lung transplant. That's wrong. This UIP pattern is more frequently seen in our hypersensitivity pneumonitis, CTD, that is autoimmune diseases related ILD, as well as sarcoid ILD, and they have much better prognosis than IPF. Why label a UIP as an IPF? We really need to work hard on it. So very importantly, in India, only 25% of patients of UIP ILD reported by the radiologist have IPF. Actually, they are, all of them others have some cause or the other. Then we need to understand that all ILDs, which is a heterogeneous disease, don't have a similar kind of a survival or an outlook. So they are not equally deadly. So you can see out their data here. Sarcoid ILD is the one which kills minimum number of people. So if somebody asks me that which ILD you want to have in future, if God decides to give it to you, I'll say please give it to me, sarcoid ILD, because I will lose only 6 years of my life because of ILD if I have sarcoid ILD. So if I am expected to survive 85 years, then I will be living for maybe 79 or 80 years. That's fairly fine. But if there are other diseases like IPF or hypersensitivity pneumonitis, for instance, hypersensitivity pneumonitis is expected survival 4.5 years, which is very, very poor, because last 2 years will be on oxygen, and they have nothing else to offer to these patients because the lungs have far more gone than you can. Otherwise, autoimmune diseases, ILDs, because we have so many options of using various modulators, immunomodulators and biologicals available to us to use in these kind of patients. So what is IPF? I think if this is the only thing physicians should remember, that if you are writing anybody IPF because your CT scan report has come as UIP IPF, this should be mostly a gentleman, a male person. Patient should be an ex-smoker, and very importantly, remember that this patient should be above the age of 60 to 65 years. Please do not write IPF to anybody who is less than 60 years, because that's how it is. And then they have all these classical things which are seen in any fibrotic ILDs. So this is the data from India which I was talking to you about, that we showed that 1 out of 2 patients are hypersensitivity pneumonitis, followed by connective tissue disorders, and idiopathic is like about 10% only. So the bad part of the news is that we miss the diagnosis, but the good part of the news is the bad kind of ILDs are less common in India. So that's what it makes us. So we need to do certain tests for them. As a physician, you can all order for baseline test, which is required for every newly diagnosed patient of ILD who brings in a CT scan report that I am having ILD. So you can see that the guidelines are very clear that you need to rule out autoimmune diseases. So RA, anti-CCP and an ANA, ENA is the one which is required in all cases, because occult CTD can be there in a patient who just presents with ILD, because CTD has not yet opened up his mouth yet. So you need to do this, and also you need to do for hypersensitivity pneumonitis, there is a panel which is called HP panel. So need to do that where fungi, birds, droppings and feathers and all are tested for the antibodies to see whether it is there. But this is the most important part, and this is the guideline, that no radiologist is good enough to make a diagnosis of what kind of ILD it is. No clinician is good enough to make a similar kind of diagnosis. So what happens is, if I am saying that this subtype of ILD to me looks like HP, 1 out of 2 times I will be wrong. If a radiologist writes the same thing, 1 out of 2 times even he is wrong. So if you are making a wrong diagnosis, you are actually trying to take away that honeymoon period of the patient where the things can improve, and you are actually giving them a very bad diagnosis with a very bad prognosis where nothing will be possible in a very short period of time. So they all have to sit together in what is called as a multidisciplinary discussion, and this team requires an expert radiologist, an expert pathologist, an expert rheumatologist and pulmonologist, and this is how it is done, where each case is presented and then an opinion is to be made that what is the kind of this disease which is causing interstitial lung disease. And if they don't have a high level of confidence, which is considered as 90%, because somebody's life is hanging on the noose, so you need to consider them for a lung biopsy. Lung biopsies are very, very uncommon in India. So now we have what is called as a cryobiopsy, which is an OPD procedure which is done in with the help of a bronchoscope and a cryobiopsy. So this is a cryobiopsy which is being done. You can see that it's a small procedure. It's not a huge procedure. It gets a big tissue, because you freeze the lung tissue and take it out, and since it is frozen, the only thing it can do is a bleeding when you pull it out. So you put a Fogarty catheter, so block it completely so that it does not bleed. So it's the procedure which gives you chances of bleeding, which can be managed, sometimes pneumothorax, which can be also managed, but most of the times it is able to give you a tissue which can give you the diagnosis as to what is the underlying cause of an interstitial lung disease. And that is the most important thing, because we know that there are treatable interstitial lung diseases, there are untreatable interstitial lung diseases, and there are a lot of diseases which don't need treatment, like the cystic lung diseases, in which you can get away even without treating them, because they will be okay for years together and nothing is going to happen to them. So you can see that the Fogarty has gone in, and they will just put the Fogarty and then put the cryoprobe and take everything out, and that's generally you take 2 to 3 good pieces out of it, and 2 different lobes are sampled for this, and the total procedure takes about 15 to 20 minutes. But of course it's not that there are no complications ever possible in this, but with repeated use the things improve much better. And this is in fact worldwide changing to surgical lung biopsies, which required opening up the chest, then thoracoscopic, and then VATS, and then finally the cryobiopsy which has come in. You can see that the balloon has been inflated, because the biopsy is balloon is checked, because it should not be that the balloon doesn't work there. There are already 3 people working together on this, and then they are putting in a probe to get there. The amount of tissue which comes from the lung is really significant, and it gives you an idea as to what can be done. So when it comes to the last part, which is the how to treat these patients. So obviously to treat the patient you need to understand what is the underlying cause, and can you eliminate the cause, or you really need to treat the cause. So the first part is subtyping of ILD, which includes in the diagnosis itself, and then it comes to the management, where drug therapy, you can see, is just a one cobblestone. In the entire path, you can see there are so many things which needs to be done for these patients of interstitial lung disease, and as they will progress over years of time, they'll require more and more elaborate procedures as well as options to make their life feel better. So you need to have a lot of educational support to them, you need to vaccinate them, you have to give them rehabilitation, you have to control their symptoms, manage their comorbidities, and at the end of the life, When nothing else is possible, you are left with only one thing, which is the palliative care for this group of patients. So with that, I would like to thank you all for patiently listening to me. But it is a complex topic, and it is a real difficult topic, it's a real difficult topic to understand. But remember, couple of messages only. All ILDs are not same. All ILDs don't kill equally. All ILDs cannot be treated similarly, and all ILDs are missed in the initial part of it. If we remember that, I'm sure we'll be able to do much better. Thank you very much.
Thank you, Dr. Deepak Talwar, for enlightening us about this complex problem, and which is, I feel, very common. Please take your seat so that we can invite the questions.
Yeah.
And now the house is open for question answers. And Dr. Sandeep Sai, I think you will moderate and go ahead with the question answer sessions there.
So thank you, Dr. Deepak Talwar. That was an excellent talk and quite an eye-opener in the sense that etiopathogenesis, the earlier we are able to come to a conclusion, the more the better or bad the prognosis, the long-term treatment. Not that we have too many options to treat these patients. So message especially goes out to all the internists, the pulmonary doctors, and even the GPs. Earlier we suspect, earlier we see, the referral. As far as that point about 3 physicians needing to comprehend and make a diagnosis, maybe we are just too overloaded with patients here in our scenario that it becomes very difficult to, but definitely we do take the pulmonologist's opinion and guidance. So, going on forward from this background, may I invite some questions from the audience, if you need any focused answer on this, and of course, we'll continue to have our discussion later on after these sessions are open. So, any questions from anybody?
Let me stimulate the persons there. Yes, Dr. Ashutosh Mohan. Would you like to ask something that how often do you see ILD and diagnose clinically in your clinic there?
We do see it very often, but mostly it is only after it has been diagnosed by the radiologist.
Yeah.
Like you said, very different to diagnose it clinically, and we often confuse it either with tuberculosis or with pneumonia. You rightly said, very different to diagnose clinically.
Is it?
So I know, I just wanted to ask that as a clinician sitting in the clinic, what would be the most suspicious point to go in for the one clinical feature that you say should give us that suspicion of ILD instead of asthma or for tuberculosis? I mean, fine, CT scan does come there, but as clinically, what would you say that would be one thing which should put you on that track?
I think one of the important points to remember would be that if CT scan is not done properly with an ILD protocol, even that is going to miss the diagnosis of ILD completely, and will give you a false assurance that it is not ILD. And then obviously the next CT scan will be done maybe a year or 2 years later. By then the disease is already florid. So the clinically as we see is that this disease symptoms will not go away. Whether the symptoms are dyspnea, cough or sputum production, they are persistent. And very importantly, the most frequently missed would be a hypersensitivity pneumonitis, because they present like asthma, they get steroids, they feel better, you stop the steroids, they come back maybe after a couple of months again, they again take steroids, they again feel better, because steroids is the primary treatment for the inflammatory part of the hypersensitivity pneumonitis.
So what I was hinting was that you mentioned at one place, how significant is the weight loss part of it?
Yeah. So this was reported in our registry also, that they lose weight because of the intense inflammation going on into the lung part. And if you find that the weight is losing and the patient's symptoms are not improving, then I think there is some red flag out there. But most of the times where we miss is the connective tissue disorder related ILDs, where the connective tissue disease is not yet diagnosed. So these are like occult CTDs, because there is no clear-cut sign of rheumatoid arthritis at the moment, but the rheumatoid factor and anti-CCPs are positive, or there is even a incipient systemic sclerosis, basically, where systemic sclerosis is known to be clinically manifest even up to 5 years after the ILD has been diagnosed. So I think lot of things are related to it, and exposures, where the person works. I think the history is very important, because exposures leading to ILD is a very large group of interstitial lung disease, and we know the kind of environment in which we work, and the kind of environment in which you know, our factories and others work. We need to be very careful about the occupational history of the patient. Of course, the otherwise hobbies are very important, like keeping pets at home. So all the history taking is, I think, very important for a patient who does not respond the way we want him to respond with the therapies which we give, which is obviously inhalers and bronchodilators and things like that.
Dr. Talwar, my question, that what are the other comorbidities or the other organs usually involved with ILD also, where probably the diagnosis or the clinical features may come little early rather than the lungs, like involvement of the liver, involvement of any other organ apart from rheumatoid arthritis and psoriasis, these are there?
So see, the general manifestations wise, the most important are CTD related, and they will be having a different ways of presentation, and you need to suspect from that. Otherwise, the most of the comorbidities comes because of the steroids and the side effects of the drugs which we are using. They ultimately develop diabetes, they develop hypertension, they develop osteoporosis, they develop cataracts, they develop all kind of side effects, because steroids is the most important treatment which is given to these patients, and for a pretty long time. So these patients accumulate these kind of things, and of course the heart related comorbidities come up when we talk about the diseases which cause interstitial lung disease as well as heart disease, where sarcoidosis also will come in, but autoimmune diseases again are very important.
Sir, at what stage would you tell us that we should send the patient for biopsy? At what stage would you recommend a biopsy? In the early stages or?
So see, if it's talking about that it's a late stage, not only the biopsy is going to have more hazards, but also biopsy is not possible at all. So if they have a very low diffusion capacity, they have very low lung functions, they are already on oxygen, then there's no point in doing biopsy, because then we have actually missed the train basically. So there's no point. Biopsy is done only when in MDD we are not able to make a high level confidence diagnosis of subtype of ILD. So every CT scan are subjected to the committee, which is the multidisciplinary team, and if they are not able to make a diagnosis, then biopsy can be done. But most of the times, the sad part of the story is, even if our MDT team recommends that a biopsy is required, we find that almost about 40% of the patients are not fit enough to undergo biopsy. So only 60%. Out of 60%, I would say just about maybe another 15 to 20% will accept to get biopsy done, because at that point of time, they don't feel that it is so significant that biopsy should be done. They don't realize that if it turns bad in 1 year time, there will be no window of opportunity to do anything. But it's very difficult for the people to even understand to get a biopsy done. So that's why the lung biopsies, which are like VATS biopsies or open lung biopsies, were extremely rare. In ILD registry India, if I remember correctly, there were only about 8 to 9 patients who had undergone a lung biopsy by VATS. So that's why the new cryobiopsy is added to it, to the diagnostic algorithm. But 10% of patients still do not get diagnosis even on a cryobiopsy. So we have to be very cautious in interpretation, as well as to raising the expectations of the patient who's undergoing a biopsy, that whether he will be able to get 100% or not. Because if he doesn't get 100% and he gets into, doesn't get that, then obviously he feels cheated. So like a counseling is required, and at that counseling you lose another 10 to 15% of patients, that if you still cannot be deciding your mind as to what is going on, then what's the point in biopsy? So that's fine.
Okay, yes, please.
Fantastic talk. Deepak, in your massive experience, as we clinicians, what we should think should be the risk factors in patients whom we have a strong suspicion of having ILD or could be going to ILD? Is it the age? Is it the smoking? Is it anything else which you could think of in you had a registry done? So you should be knowing, is it the weight loss? Is it what exactly are the risk factors which should raise our antenna to go to a diagnosis of ILD and warn them and prevent it or maybe correct it as early as possible?
So, see, the history is the most important thing actually. History is a clue to why this patient is not doing well. And the history taking itself takes nearly 2 to 2.5 hours. So, you know, the postgraduates are there employed for this purpose. So they will be very happy to going through each and every, but in clinical practice, it is very difficult to find out because most of the times, even patients don't correlate with that because they have been working there for a couple of years and they expect like asthma that I go today, I will get symptom, I know that I am allergic to it. But in ILD, it won't happen like that. It will take 2 years, 3 years, 4 years, 5 years to, and by then the association is not strong. So we need to understand that there are 300 or 200 the kind of exposures which can cause this interstitial lung disease, which are risk factors. So anybody working in, we know that now if the people are on the stone cutters, people who are working with asbestos, people who are farmers, people who are keeping the chickens and all other animals, husbandry which is being done. So these are all occupations which can cause these kind of things, where your index of suspicion can be raised by some findings in the chest, which may be some crackles and squeaks, which I said. Patient given routine inhalers not responding to that is again a bad signal that there's something else which need to be seen. Any amount of, you know, clubbing is a very late sign. So when it occurs only in 30% of patients. So if we look for clubbing, by then I think it is too late to actually get the diagnosis. We need to go through the history part more thoroughly to pick up the diagnosis early. And that is very exhaustive because almost every year 2-3 new types of exposures are added which can cause ILD. And drugs these days are very important. So any patient who's on a chemotherapeutic drugs, because previously we knew amiodarone and nitrofurantoin were the 2 most important drugs causing interstitial lung disease. Now amiodarone everybody knows, so they are very careful, so we don't see amiodarone induced interstitial lung disease. Nitrofurantoin is still one of the drugs which particularly the ladies with recurrent UTIs get nitrofurantoin for very long time. So that's another one drug. But the most important are the newer drugs which have come as a cancer in our chemotherapeutic areas. We have all these monoclonal antibodies which are there. All of them can cause acute hypersensitivity pneumonitis. They can also cause interstitial lung disease. And this is very important to diagnose it early because these are reversible at that point of time. And actually, before they become fibrotic, you can actually pick them early. And of course, because we really need to look into these newer drugs more carefully, which are used in our oncology practice.
Actually, I was coming to this point that tofacitinib is very frequently used even for rheumatoid arthritis or any autoimmune disease. Is it also, how do you place tofacitinib as far as the causative agent for ILD is concerned or any disease process?
So tofacitinib is primarily, you know, come for rheumatoid arthritis. Now we are using it in rheumatoid arthritis very well. But at the moment we have seen tofacitinib causing more infections in these patients who have underlying interstitial lung disease. And also we have found that sometimes when there is acute worsenings, we think that probably it has happened because of the drug. But we have not been able to establish it so far. And Randeep is there. I do not know if Randeep has seen tofacitinib induced interstitial lung disease.
Well, thank you very much. Yes, sure, go ahead.
Maybe it's too less time that it has been extensively used. So we'll, I think, come to know of it a little later.
Dr. Talwar, your talk has been a revelation to me. I'm a plain doctor. Colonel Gulati is my name. I'm a gynecologist actually. Never seen a case of sarcoidosis except heard of this. But I've got a simple question. I hope it's not stupid. I assume that tuberculosis is very common in India. In our developing countries, it is common. And how frequently is association with tuberculosis? Because the problem in my mind is that once the CT scan or something is done, fever, loss of weight, fever I didn't see that, but I didn't see the sign of fever here. Could be there, but clubbing around. And you find a cavity in the lung, which could indicate immediately 0 on, we are dealing with tuberculosis. My question is stupid and simple is, how much is association?
Okay.
These are two different diseases, I understand.
Okay. So as I said in the beginning itself, you know, that our data, the registry data showed that 17%, 17.8% of patients of interstitial lung disease do get anti-tubercular treatment on the basis of the chest X-ray or whatever the abnormality is concerned. But I think more relevant is your question that how many of them have tuberculosis along with interstitial lung disease, right? And most of the times what we see in practice is that when we give them steroids, we give them immunosuppressives, they have an underlying tubercular focus which flares up and they come up with tuberculosis. And we have to really struggle with steroids and immunosuppression with anti-tubercular treatment. And that 9 months, the patient's interstitial lung disease becomes worsened because we can't be very aggressive on immunotherapy. And it's a very bad combination. But it does happen. And it does happen much more frequently in India as the rest of the world. So anytime there is a deterioration in an ILD patient, tuberculosis has to be considered. And I do not have the exact numbers, but yes, it is a big problem because at that point of time, the fibrosis will become more. And we can't be very aggressive on this anti-inflammatory immunomodulatory drugs, and we have to treat with tuberculosis. They are already on number of other drugs like antifibrotic. So even tolerating an anti-tubercular drug is not going to be easy for them. So it becomes a very complex and a messy situation.
Just one more.
Dr. Guleria, would you like to put a comment there, Dr. Andeep Guleria? Please give mic.
Yeah, here it is.
Take this mic because I have a collar mic.
No, sure.
So I think this is a problem, especially when you're looking at cases with sarcoid. I'll discuss this partly in my talk itself, so I think I'll leave it at that.
Okay. Right. Yes.
So any more questions from anybody?
Acha, bolo sir.
Yes, you heard correctly. Yes, it is used like it's used.
Having UTI or some vaginitis, we say furanten.
Yes, this is a very, very commonly offender drug. It causes an acute hypersensitivity response, and if we do not identify that, then it goes on to develop an interstitial lung disease, and which is fibrotic.
Thank you very much, sir.
Thank you, Dr. Gulati. Thank you very much. Okay. So, ladies and gentlemen, we had a lovely talk on ILD, and concluding remarks for this session would be especially for our PGs in the hospital in our group, and to other GPs who are attending here, is that ILD, keep your eyes and ears open. You could be dealing with an ILD. Now, since we are dealing more with COPDs and tuberculosis and these chronic lung disorders, the history taking becomes the most relevant aspect, followed by diagnostics. And diagnostics tomorrow, why tomorrow? I say AI has already taken over in many of the parts of the country and in the Western countries where radiologists are in scarcity. So which is going to give us better reporting. And lastly, there is no single test to define ILD. You have to consider everything, the history, the X-ray, the CT scan, the sputum tests, the hypersensitivity panels. Sarcoidosis is more rampant than we suspect. And here in this case, just like to point out one thing, that association with HLA haplotypes are seen in many of the cases of sarcoidosis which are still under investigation. There is no single marker for any of these tests. So keeping everything in totality and broad discussion with your peers helps us to come to a conclusion, and right time referral to centers where they can proceed with lung biopsies if required at the right time. So thank you, sir. Thank you so much for your excellent talk.
Let us give a big hand to the speaker. And I would like to invite now Dr. Pradeep Sethi, please. Dr. Pradeep Sethi, sir, to please give a honor to the speaker as well as to the chairpersons. आओ जी सर, सामने आओ. Thank you very much. Dr. Var, thank you very much for enlightening us. It was a pleasure. Thank you. Let us move on to the next talk. The next talk will be on cardiology, and to chair the session, I would like to invite Dr. Pankaj Ranjan. Dr. Pankaj Ranjan, he is DM Cardiology and Interventional Cardiologist in Yatharth Super Speciality Hospital, Greater Noida as well as Noida. Dr. Dipankar Vats. Dr. Dipankar Vats is again an very enterprising interventional cardiologist in Yatharth Super Speciality Hospital, Greater Noida. Dr. V.B. Jindal. Dr. V.B. Jindal, he is a very dynamic person of API Ghaziabad branch, and he is coming all the way from Mussoorie after receiving a fellowship of UP Diabetic Association. And Dr. Akshay Purohit. Dr. Akshay Purohit, is he there? Okay. So these three chairpersons, and the speaker is none other than Dr. Jaypee Sahni. Dr. Sahni, he'll be speaking on the lipids, and it's all over to the chairpersons now to please invite the speaker and introduce him. Thank you very much.
Good afternoon, friends. It is indeed a pleasure to invite a learned person like Professor Dr. Jaypee Sahni for this talk. This is talk on clinical practice guideline for management of dyslipidemia. So please, I will request Dr. Jaypee Sahni to come to the dais and proceed.
Good afternoon, and I'm thankful to Dr. Soni and the organizer for giving me this invitation, and respected chairperson and dear friends. I'm going to discuss with you the first Indian guidelines on the management of dyslipidemia, which we published last year in 9th of April in Indian Heart Journal. Before that, we have only had the consensus opinion and expert opinion by our colleagues from various society, but we did not have our own guideline, because to prepare a guideline you need to have a data of your own country, and that was lacking for a few years. But now we took almost 4 years to prepare this manuscript based on the data from our country, how we are managing our lipids, and what is the genetics, what is the clinical trial where we have participated, what is the epidemiology of the lipids. So all those things we took almost 3.5 to 4 years to prepare this manuscript. And we know that the most important risk factor for cardiovascular disease is lipids. Why I said so? Because the final common pathway, it is the LDL or non-HDL cholesterol which enters into the formation of atheroma, and who pushes it is hypertension, diabetes, smoking and stress. But the final pathway is because of the HDL or non-HDL cholesterol which enters. And it is a true or actually silent risk factor. Hypertension and diabetes have some risk, some symptoms, whereas lipids have got no symptom. So with this background, I will say this is a publication which we did in Indian Heart Journal last year, along with my 22 cardiologists. We worked for almost 3.5 years. So first question came, why we need the guideline for our country separate? So far globally, everyone is using the European Society of Cardiology guideline 2019, which is the best guideline so far, and it did not yet change. Our base is also on that, but we made certain differences, certain more suggestions from. So what was the reason behind it? One, the factor was, most important was, that we get disease 10 years earlier. 50% of people are getting disease less than 50 years of age. 15% are getting below 40 years of age, which is 3 times more than the Western world. A second important factor was that we acquired the risk factors of hypertension, lipids or diabetes earlier compared to the rest of the world. We have certain risk factors which are very peculiar to our country, and they are, for example, the atherogenic dyslipidemia, high triglyceride, low HDL cholesterol, metabolic syndrome or central obesity, almost more than 2.5 times more than the Western world. And thirdly, in tobacco, the tobacco chewing and BD smoking is again a peculiar problem of our country. So these are the risk factors which are acquiring earlier, and we have a peculiar risk factor. And then we looked into the data of our country, into the genetic causes of the cardiovascular diseases and particularly lipids. And what we found, familial hypercholesterolemia present much more common in our country compared to rest of the world. It is grossly underdiagnosed and undertreated condition. And second important risk factor, the genetic factor of lipid is high lipoprotein A, above 50 milligram. Again, a grossly neglected area. We do not look for that. And finally, the factor which played a role in genesis of our guideline was the lifestyle modification. And we found that the sedentary lifestyle is very highly prevalent in our country. In 195 countries survey, we are 12th from below. And when we look into the diet part, again the cooking method, the dietary patterns are again problem, because we consume a lot of carbohydrate food, which should not be more than 50%. On average, our food has 70% of the carbohydrate. Probably many people are vegetarian in our country. So these were the reasons why we needed a guideline from our country. So let me give you the epidemiology, and this is the paper from the ICMR India by Dr. Mohan. He published this paper in 2023 based on the 1,13,000 patients from both the urban and rural area, and he found that hypertension is present in 35% of patients, diabetes in 11.5% patients, and the dyslipidemia in 81% of the patient, which is basically because of high TG, low HDL and high cholesterol. And when we look into the different states, we found for high cholesterol and high LDL cholesterol and non-HDL cholesterol, there is an interstate and inter-regional variability. Also to some extent difference between the urban and rural area. So roughly 50% of the Indian population have got hypercholesterolemia. Look at this. Look at the hypertriglyceridemia and low HDL cholesterol. Whole country is red, highly prevalent. There is not much of difference between the interstate or inter-regional variability even in urban or rural area. So central obesity is behaving almost similar to high TG and low HDL cholesterol. Now let me, since the guideline is very long, I will only restrict myself to key points which probably are required for the clinicians to learn. So for that, what we suggested that any patient who comes to you in clinic for any risk factor, look for lipid. Since we do not have our own risk calculator like Framingham risk score or score system of Europe, we did not apply any risk calculator for our country. It is still not there. So what we suggested, there are certain differences compared to the European Society guideline. They divide into extremely high risk group, very high risk group, high risk group, low risk group. And we suggested targeting LDL is not enough. You have to target non-HDL cholesterol because our triglyceride levels are very high in the country, and non-HDL is nothing, total cholesterol minus the HDL cholesterol. So if you just target LDL, you will probably be missing a lot of patients. So this was the first point. An extremely high risk population are the one, those who get recurrent coronary artery events within 2 years in same territory, or a person of MI getting a stroke or peripheral vascular disease. What we added in our guideline was a patient of young heart attack, less than 55 men, less than 60 women, having familial hypercholesterolemia and also high level of lipoprotein a. This is again an extremely high risk population which gets recurrent events very, very commonly. So we suggested to keep the LDL cholesterol in this population to below 40 or non-HDL, which is 30 milligram more than the LDL cholesterol, keep it below 70. The very high risk population is the one who is suffering from cardiovascular disease or who has got on CT angiogram more than 2 arteries, more than 50% lesion, diabetic more than 20 years, or familial hypercholesterolemia with cardiovascular disease, keep the level below 55 for LDL, below 85 for non-HDL. And high risk population, here we did not differ with the European guideline. But high risk population, we added something more. What we suggested was, the guidelines earlier said, diabetic patient with more than 10 years duration or diabetic with one of the risk factors. Here we added hypertension with one of the risk factors because this is our own data from our country. So what are those risk factors? The central obesity, family history of ASCVD, tobacco, diabetes or dyslipidemia. Any one of the risk factors is there with diabetes or with hypertension, then keep the LDL cholesterol below 70, not 100, what was the traditional teaching. So it looks like practically most of the patient of diabetes and hypertension will have to keep their LDL below 70, otherwise they will get disease earlier. Because the commonest risk factor which was associated with hypertension and diabetes was central obesity, very, very high in our society. Low risk population, no risk factor, probably keep it below 100. For general population, keep it below 100. The second area which I want to discuss with you about the management of heart attack or acute coronary syndrome. Now here we suggested the patient enters into the nursing home or hospital should get their non-fasting lipid profile. They should get all the blood tests but also get non-fasting lipid profile at that stage, whatever time of the day patient comes. And hit them hard and hit them early is the concept. That means in this population, if we have to stabilize the plaque within 3 months, if we do not stabilize the plaque at 3 months, there is a recurrence of coronary events up to the tune of 10% in ACS population. So that's what the concept came, and for that we suggested to give 40 milligram of rosuvastatin and or 80 milligram atorvastatin along with ezetimibe. A combination or early combination therapy should be given with the idea that we will able to reach below 55 target as early as possible and get the second lipid profile not at 6 weeks or 2 months or 3 months, get at 4 weeks only after the initial lipid estimation in the hospital. Why 4 weeks? I will just tell you. And if the levels are still above 55, then give bempedoic acid and wait for another 4 weeks. If still not below 55, now we have got a drug called inclisiran. Earlier we were using Repatha, or what we say injection Evlucamab, which has to be given 26 injection a year, and now inclisiran is available. We have to give 2 injection a year. It is it is as effective as Repatha or Evlucamab, but it causes less of LDL variability and it is half the cost. So that is what the recommendation has come, that we should give. So why we say early combination treatment? Because this was based on the study. We will show the if patient of ACS we give alone high dose of statin, then around 70 to 70% patient will, 65 to 70% patient will achieve below 55. But if you add combination of drug, then around 85 to 90% will able to achieve the LDL below 55 as early as possible. And why 4 weeks? Why not 6 to 8 weeks? Because we did a study in the country, we generated the data for that. Any patient with acute coronary syndrome who comes to us, we did the lipid profile at day 0, 7, 14, 28 and 42. And what we found, the peak action of statin comes at 4 weeks. After 4 weeks, there was no further reduction of LDL cholesterol. So we thought if you want to hit hard and hit early and reach the plaque stabilization, we should do at 4 weeks. Don't wait for 6 to 8 weeks. And secondly, what we found that in our country, the problem came, when we look into the adherence to therapy, the data came from 500 patients, which is a very small number. What we generated with my younger colleague, Dr. Ashwini, we generated the data of single center, of course, around 3,800 patients. And they started with high dose of statin. Down the line at 1 year, we found only 25 to 30% patients were on high dose of statin. Most of the patients were on moderate doses or small doses of statin. So we look into the reason for that. Was it the side effect of the drug? Or was it the cost of the drug? Or it is the media? The common answer which came, they say their doctor has reduced the drug. जैसे हम तो फॉलोअप में गए, डॉक्टर साहब ने बोला आपका तो लेस देन 55 आ गया है, नो 40 मिलियन से हमसे 20 कर लीजिए. नेक्स्ट टाइम गए 20 का 10 कर दिया. And when at the end of 1 year we found all of them were above 55 and they had recurrent coronary events. So they blamed physician. Most of the data which we came from our hospital, they blame physician, they reduced their drug. So we thought what to do for such situation. Shall we de-escalate the dose if you reach LDL below 55 at 3 months or 2 weeks or 2 months? So the suggestion came from the expert was that if a patient has statin associated side effects like myalgia, yes, you can reduce the dose. And second group was the one, because we know statin also causes new onset of diabetes, and we have got central obesity, high atherogenic dyslipidemia. This group of population are more prone for new onset of diabetes with the help of with the dose related statin. So we thought if patient is on high dose of statin and his initial HbA1c was pre-diabetic state, and after 3 months HbA1c shows a rising trend, probably you have a logistic reason for you that you can reduce the dose from 40 to 20 or 80 to 40. But then repeat your lipid profile again after 4 weeks. If the levels goes above 55, add bempedoic acid. We do not interfere with sugar levels. So that's what we suggested in our guideline to make it more practical. And then we also discussed about the algorithm from chronic coronary syndrome which no guideline had. We thought that this is the common group. When it comes to you with atherosclerotic cardiovascular disease in clinic is stable patient. Again, we are not in hurry to reduce his LDL, but the guideline said you have to keep it below 55. So we suggested instead of giving 40 Rosuva, give 20 Rosuva and 40 Atorva, but add agitamide so that you reach the goal early, you reach the goal safely. Because what we have learned, from 20 rosuvastatin, if you increase to 40, then the reduction of LDL is only 6 to 8%. But if you add 10 milligram of agitamide to 20 milligram of rosuvastatin, then you reduce by 15%, number one. Number two, because the doses of statin are low, your chances of myalgia is less. Number three, since the doses are low, the chances of new onset of diabetes is also low. So it becomes more effective to use combination treatment acting at liver and intestine. You are reaching the goal safely, you are reaching the goal effectively also. So that was the guideline we suggested, and we also very strongly recommended the non-fasting lipid profile is the way to go. There is no need of having fasting lipid profile unless and until patient is suffering from hypertriglyceridemia, pancreatitis or levels above 400 where you need to give them, ask them to go for fasting lipid profile. Otherwise the good data and all the guidelines in the world now believe there is no need of fasting lipid profile. That will take care of early morning unnecessarily rushes in the laboratories, and it becomes more convenient for the patient. When we started this based on the guideline 7 years ago, in Gangaram hospital, our number of lipid profile increased by 28% because it becomes very convenient to get, and everyone will be able to know its LDL. Now, second part of another practical problem which we face is, shall we treat high triglyceride levels or not? This is a big problem. So what we say that the global data shows those who are suffering from atherosclerotic cardiovascular disease and their LDLs are below 55, yet 25% of the people have high triglyceride, that means above 150 milligram. And in our country the data is 40 to 50%, is not a small data. And we have learned now that if your triglyceride levels are high up to 400 milligram, your chances of cardiovascular disease increases even if your LDL cholesterol at goal, because it is the remnant cholesterol which is present in triglyceride which is playing a role in producing further atherosclerosis. So what we suggested, that if you are having triglyceride above 150, don't look on LDL, look at non-HDL, which is nothing but total cholesterol minus the HDL cholesterol. It is generally 30 milligram more than the LDL cholesterol, because this contains the remnant cholesterol, which is nothing but VLDL cholesterol, LDL cholesterol and small kind of microns. And this is a figure which gives you the answer for that, why it is important to treat triglyceride. Because triglyceride has got two parts. One is the blue part, which is what we say innocent part or inert part, or what we say Punjabi foca part, which has got no value in atherosclerosis. And the yellow part, which is the remnant cholesterol. which directly enters into the atheroma formation, and this is very important. We should know that this remnant cholesterol is much more atherogenic than LDL cholesterol because do not need any oxidation. And the blue part is safe. It do not cause any atherosclerosis, but it can participate in pancreatitis. So our guidelines suggested that any patient who comes to you with high triglyceride and he's got no diabetes and he's got no atherosclerotic cardiovascular disease, then lifestyle modification is good enough. There is no need of fenofibrate. So please do not give prescription of fenofibrate to this population. The reduction of weight, reduce carbohydrate diet, reduce alcohol, smoking, everything works very well. But if a patient has diabetes or suffering from atherosclerotic cardiovascular disease and his triglyceride is between 150 to 500, here aim is to prevent cardiovascular disease because it contains remnant cholesterol. Now in that situation, we have to give statin and non-statin drug like HMI. I mean, in spite of that, if your non-HDL cholesterol is not getting controlled, then there is a role of fish oil, a specific fish oil, icosapent. Within the fish oil, we have got two parts, EPA and DHA. We do not want DHA. DHA is pro-inflammatory. We want only EPA part. So the only EPA part of the fish oil is useful to reduce non-HDL cholesterol and ApoB. This will reduce further heart attack. The DHA, which is the common fish oil available in the counter, and children, because of affection they are sending to parents in India, is of no value. They do not cause any reduction of cardiovascular events. But if your triglyceride is above 500, 1000 or 1500, 2000, those who can cause pancreatitis. So here aim is to reduce pancreatitis. For triglyceride between 155 to 499, there is no role of fenofibrate, because this is the commonest medical prescription error in clinical practice. Do not use fenofibrate in this situation. But yes, if your triglyceride is above 500 or 1000 or 1500 milligram, there is a great role of fenofibrate, because it reduces the number of triglycerides very rapidly, but that is the only blue part. And the why blue part? Because there is a large particle of triglyceride which can cause pancreatitis. The third commonest cause of pancreatitis after the gallstone, alcohol, and this plugs the pancreatic vessel, probably it is in the vicinity of the liver. And for that, fenofibrate has got a role to play. The other drug which can be used along with fish oil is a saroglitazole, which we put in our guideline, because this is a drug which has no endpoint data available, but found that this drug in diabetic patient whose TG is controlled, whose sugar is controlled, yet he has got high TG, we can use saroglitazole. The other group is MAFLD population, those who got high SGLT-PT, having high TG, saroglitazole can be given. But those who have got very, very high triglyceride, we want to really reduce pancreatitis in this population. There is a drug available called volanesorsen and also vinucamab, which is not available in the movement in the country. They are injectable drug working in different area, but they reduce triglyceride by almost 90 or 80%. So this is the way we should treat the triglyceride in clinical practice. For atherosclerosis prevention, for pancreatitis prevention, role of fenofibrate is only for pancreatic prevention, not for cardiovascular prevention. That's why all the fenofibrate trials have failed to reduce cardiovascular event. It reduces the blue part, do not reduces the yellow part of the triglyceride. Then coming to the genetic dyslipidemia is not uncommon. I will briefly go into do because of the lack of time, but I must say that the familial hypercholesterolemia in young heart attack population is very high in our country. And we know that they got Nobel Prize almost 40 years ago, Dr. Goldstein and Dr. Brown, for discovering the receptor of LDL on the liver and saying that this is the mechanism of familial hypercholesterolemia. Fortunately, homozygous variety is very rare, 1 in 10 lakhs, but 1 in 1 million. But the disease comes within first or second decade, and most of the children, they don't survive. Heterozygous familial hypercholesterolemia is quite common. 1 in 250 to 131, they get disease in 4th or 5th decade, and grossly underdiagnosed and undertreated entity, because the genetic test is the gold standard, but it is not available clinically. We are fortunate in Gangaram to have with us, but I think the clinical diagnosis, or what we say phenotype diagnosis, can be done by just simply looking at the Dutch Lipid Clinical Network criteria. It is very simple criteria. Heart attack, less than 55 men, less than 60 women, you get 2 points. Family history in same age group, you get 1 point. You have to spend some time for family, because the reason is the family history of cardiovascular disease, stroke, sudden death should be also asked. Sometimes we only ask heart attack and it gives you less point. 1 point from there. Look at the LDL cholesterol. If you have above 150, you get 1 point, above 190, you get 3 points. And then in clinical examination, every heart attack patient, when he comes to you, who is a young heart attack, less than 55 men or less than 60 women, please do not forget to lift his upper eyelid. You may find an arcus, a grayish deposit of cholesterol on the upper part of the cornea. If you get this sign in younger population, you get 4 points for that. So this is how we can diagnose clinically. We can go into that. That I will give you, because lack of time I can't say. This is the adjustment factor which we use, because if patients are already on statin and we have to know the statin naive LDL cholesterol, then there is an adjustment factor for each statin. Like for example, my patient who was having on 20 milligram Atorva, LDL was 110, then adjustment factor for 20 milligram is to multiply with 1.8, which comes to 198. 198 means 3 score. So this is how this is done. So the cascade screening is the main importance of familial hypercholesterolemia. What I say, you can diagnose the index case, but you have to look for family member, brother, sister and the children. Go for non-fasting lipid profile. If the level is above 135 for a child and above 150 for adult, think he is a carrier. So by diagnosing a case of FH, we do not identify a case, but a family at risk. That is very important. This is our own data, the only data of the country, or I will say Southeast Asia at the moment. 1400 patients of young MI, we found 15% of people they have FH, and we found another very interesting finding, that when we look into the associated risk factor of diabetes, smoking and hypertension, we found the cholesterol levels were very high in this definite and probable group using Dutch lipid clinical criteria, but associated risk factor were much less. So what we learned, that if any young heart attack patient comes to you and he has no history of smoking and he is not having diabetes, think it is FH if his LDL cholesterol is above 130. So this is also another learning which we had, and this is the algorithm we suggested, that we have to keep it below 55. Most of the patients will be requiring 3 drugs to, or even injectable drugs to reach the goal, but the treatment of FH is not complete till we have done the cascade screening and picked up the asymptomatic carrier from the family, and we can prevent future cardiovascular disease. I've got many children now, 14 children, the youngest one is 4 years, who is on statin to reduce the cardiovascular disease. Last time we discussed about the LPA, is not uncommon, 25% Indian population, 15 to 20 in Western world, above 50 milligram is considered to be the high level. It is associated with high incidence of myocardial infarction, aortic valve disease, stroke and cardiovascular mortality, proven by all the registries and also by the epidemiological data. Our own study, which is the only study now, it is 1500 patients of heart attack, looking at the LPA, the only study at the moment from the country. We found it is much higher in younger population. Above 50 is considered to be abnormal now, and it is related to severity of the disease, and in patient of familial hypercholesterolemia is very, very high. Unfortunately, at the moment there is no therapy for that, and all the drugs, they do not reduce the LDL except inclisiran and olpasiran. Pelacarsen is the only drug which is shown to now reduces by 80%, but under investigation by 2026 will get the result. Regarding the dietary management, we have given a small chapter, but what we suggested was, the most important information was that sugar is more dangerous than saturated fat for heart attack. This is for general population, not suffering from cardiovascular disease, because what we learned, if you take small amount of butter or ghee or makhan or anything, or a small amount of mutton, then you increase your LDL cholesterol, but you also increase your HDL cholesterol. The ratio between LDL and HDL remains same. But if you take sugar, more of carbohydrate food, more sweet and sugary beverages, you increase your triglyceride level, you reduce your HDL cholesterol, LDL remaining same. So the ratio between HDL and LDL grows and the LDL size becomes smaller. It causes more atherosclerosis than ghee or butter for general population. Sugar is more important. That is one of the reasons why in our country probably we get more problem. For young people, we suggested first lipid profile should be done at 18 years, And this is the last slide which I'm going to show because I know I'm running out of time. While preparing this document, we found a very interesting finding. That one of the important risk factors for heart attack or recurrence of heart attack is our laboratory. The reference ranges of the laboratory, we have 8 lakh laboratories so far registered, only 2400 NABL accredited. And what we found, the LDL level, for example, or non-HD level, the ranges were from 70 to 140, 100 or something. Every laboratory in the country has different levels. So I will give you just one example of one of my patients. Very rich man is now in Dubai, but he had PTCA. So he said, I'm coming to India, Dr. Saab, what investigation should I? I said, you get lipid and get back to me with LPA. He got it, but he never came to me. He met me in one party and I asked him, why did you come? He said, no, I have got report, I have done from your only hospital. Meri report to normal hai. Main kaha report dikhaiye. So when he showed the LDL 90 because it is written less than 100 for normal population. So I said, look what we have written below that. Look for estimated risk and lipid goals. Standard lipid profile testing should have this too. So what we suggested that if you are suffering from CAD, you had PTC in the past, your risk is very high. And for very high, the level is 55. So that should be the level we should be. And you are happy with 90 and he within 3 months had another heart attack. So that shows this is one of the important risk factors in our country. So non-compliance to therapy is a big problem where doctors are playing a major role. Number second, non-uniform reporting of the lipid profile is again a very important part of causing a recurrence of the cardiovascular disease. And for that we are working hard now to make it uniform for all the laboratories in the country. So in conclusion, dear friends, what we have made this document specific on Indian population, based on Indian population, but there was certain area, there was a lacunae, and for that we took the expert opinion of my colleagues, and not much different from European guideline. What we suggested, you should keep your cholesterol as low as possible, as early as possible, lower the better, which told you the goals for that. Longer the better, as early as possible and for a longer period of time, because Mendelian hypothesis has shown that if you keep it low earlier in life, your lifespan will go by you may reach 100 years very early. What we added in our guideline was together the better. That means that don't only give statin, but also give non-statin drug. Not only look for LDL, look for non-HDL also, because if you miss non-HDL target, then you are going to get recurrent coronary events. So this consensus guideline cannot replace the individual clinical judgment which every clinician should know. Thank you. Just to give key takeaway, prevalence of dyslipidemia is high, particularly atherogenic dyslipidemia. Screening should start at 18 years. Non-fasting lipid is good enough. Uniform lipid references in lab should be there. Lipid goals should be for general population less than 100, diabetic and hypertensive patient with respect to less than 70, for heart attack patient or stroke less than 55, for extremely high risk population with genetic diseases keep it below 40. For patient of triglyceride above 150, look for non-HDL cholesterol. Lifestyle medical treatment as statin definitely and non-statin are very important. Early combination treatment is the way to treat all the patients of cardiovascular disease, and now we believe for primary prophylaxis, like for a patient with diabetes, no heart cardiovascular disease, he should be also given statin and non-statin azithromycin combination acting on intestine at liver to reduce the cardiovascular disease more effectively, reaching the goal more effectively and safely. And always look for genetic causes, particularly when the patient has young heart attack, ask for family history of similar disease, probably will be able to save a many population in the world. I'm thankful to my colleagues, those who have participated with me in this. Thank you. I'm sorry for my extra time.
Thank you very much. Thank you very much, Dr. Sani. I would like to ask the questions. How many of you think that the information was very, very important and new? Please raise your hands. See, the evidence is there. Thank you very much. Punjabi में जो कहते हैं तुसी छा गए. आओ sir, please come. Please come for the question answers. Now I'll hand over the mic to the chairpersons to initiate the question answers and the comments. Dr. Pankaj Ranjan, first you.
Sir, it was very nice talk. I think every one of us learned. Two more interesting thing you said, that besides LDL, we normally look for LDL. we should look also for non-HDL cholesterol. That's one thing. And second thing, in all patients of acute coronary syndrome, we should start statin along with ezetimibe. That's a really good message. I think that should have gone to the audience.
I will, since we have some time, I will give you another example of non-HDL. You see, I had a patient, these are two patients last 3 months, those who had stenting in major artery and the other artery was 40% blocked. So we did not do any stenting because we thought medically we'll manage. And within 1 year, he had another event. That artery 40% progressed to 90% and had ACS. And his LDL was always 40, 42, 45. So he asked me, Doctor Sahab, आप तो मुझे बोलते 55 से नीचे रखना है, तो मेरा तो normal था, तो मेरे को फिर से कैसे heart attack हो गया? So we started looking at his lipid profiles. The mistake was ours. We forget to look into the non-HDL cholesterol because the reason in all the 3 lipid profile of both the patient, we found their triglyceride level were high, 250 or 300. And their non-HDL, what it should have been less than 85 was 100 or 110. So what we should have done to added ezetimibe or bempedoic acid to reduce the cholesterol level further to prevent this progression of disease. So that shows that remnant cholesterol, if you're not trying to manage them, it is going to increase the disease. And that is much more problem in our country compared to the rest of the world.
Yes. Dr. Dipankar, your views.
Sir, for the lipoprotein A, what are the, are you using evolocumab, that is Repatha or inclisiran at present, as no targeted therapy is available?
Yes. So you see, as I said that in LPA, because short of time didn't go into that, what we say that LPA should be done once in a lifetime. It should not be repeated. You do not change. It does not make any difference. Unless the patients got hypothyroid or CKD, or women in menopause, they have a slightly increase, or during pregnancy it increases. But otherwise do not change, lifestyle do not change that. So once in a lifetime should be done. It is a risk enhancer, or we say amplifier. Like 2 people having LDL of 100, one who has got LPA above 50 milligram, then this 100 will behave like 130. So it is an amplifier. That is important. Now coming to the management strategy, the statin, non-statin drug, bempedoic acid do not change LPA at all. And if a patient comes to you in clinical practice and you have given a very high dose of statin and you are finding the response to statin not adequate, think that he has got high LPA. You can ask for the test to be done. Now, second thing, the drug, which specific question you asked, the Repatha, or what we say evolocumab, and inclisiran, which is now available in our country, this drug reduces the LPA level by 20 to 25%. And subgroup analysis of all the trials of 4-year trial and Odyssey trial did show that that subgroup whose LDL was well controlled, but they have high LPA, they found that if by using this drug in that subgroup, by reducing even 20% reduction of LPA, there was some reduction of events. But the guidelines do not recommend as of yet to give this drug to reduce LPA because they say it is not enough. So we are looking for injection pelacarsen, which will be available by end of 2026, and Horizon trial is going on. And that drug reduces LPA by 80% with a view that this is a strong risk marker for future cardiovascular disease. Reducing LPA will be a way to take care of residual cardiovascular disease after LDL and non-HDL.
Thank you.
Thank you, sir.
Thank you very much.
Sir, looking into the fact that we have such compliance problem, apart from the cost, why don't we use inclisiran early?
You see, the guidelines so far,
because you get a much better compliance.
I'm coming to that question. Maybe take little time to answer this. But what I say that the inclisiran drug has been tried so far in secondary prophylaxis and heterozygous familial hypercholesterolemia, and found very good results, very good reduction in the LDL cholesterol. Hard endpoint data of inclisiran is still going on in Orion 4 trial, and Victorian P trial, trials results are not yet available. What we learned, by which method, whatever method you use, statin or non-statin drug, if you reduce LDL cholesterol, there will be reduction of cardiovascular event. So your point of say that why not use in the beginning for that? I think the cost is a major factor, no doubt in that. If you say cost is not a major factor, I've got now 43 patients with me, those are on inclisiran. 3 my patients, those who are familial hypercholesterolemia, and they were not tolerating statin, so I have to give them. Initially they were taking Repatha, but now shifted them to inclisiran because of the reason I told you. Now what happened, when you look into the the cascade screening of FH population. All three my patients, they have two more family members, those who have got high cholesterol level, thereby suggesting that they are carrier of FH. And we wanted to start them also on statin. So as I said, my youngest child is 4 years and 3 months now on statin at the moment. So this boy, one of my patient, who couldn't tolerate statin. So he said, Dr. Saab, I am asymptomatic. I have got no cardiovascular disease. Guidelines from DCGA say only to be given a secondary prophylaxis. Why can't I take like my mom? She is taking now inclisiran. Why can't I take that? So I said, okay. Then we discussed the matter with the European area and USA. And now people say it will work like a vaccine. Because you can give this drug as once a year injection. Because if you get 2 injections a year, then you reduce by 50% of the LDL cholesterol, and sustained reduction is there. But if you give 1 injection a year after initial 2 injections, then the reduction is 20%. So if somebody at the age of 30 years, his LDL is 120 for example, his chance of developing cardiovascular disease will be around 70 years or so. If you start taking 1 injection a year at the age of 30, he will live up to 100 years. So this is a fact, no doubt in that. In future, probably this is the way we are going to manage this lipidemia. But at the moment, the indication is only statin intolerance. Number 2, those who are unable to reach the target goal in spite of maximum tolerated doses of statin and non-statin drug. And third one is the one, those who are already on evolocumab injection, because the cost is high, you have to give 26 injection, and the LDL variability is very, very high. And we have these days have learned now the heart rate variability, blood pressure variability, the sugar variability, and now LDL variability is also a very important risk factor. And for that reason, we now suggest to give inclisiran. So there are 3 indications. For primary prophylaxis, people are taking off label, and we are suggesting them to go ahead.
Dr. Jumani, last question from your side.
Sir, I just need a small comment on statins. One is statins induced diabetes. Why? Second, statins induced hypogonadism. Why?
Why? Okay. So the lot of research which went into that, they suggested that there is, the statin has on beta cell, on the pancreas and beta cell, the sensitivity, the release of the beta cell insulin levels become challenging in the, and it is dose related. The 10 milligram may cause 3%, 20 milligram may cause 8%, but 40 milligram may cause 9% increase in diabetes in clinical practice. And this is more on those population, those who are pre-diabetic. The hypogonadism part has been challenged now because the future clinical trial did not favor that, because when we are giving children statin, those who are carrier, like my last patient, I say 4-year-old, his father had MI at the age of 38, uncle died at 36, grandfather died at 47. The only child, 4-year-old, the wife told me, Dr. Saab, iska LDL कराओ, genetic testing करते हैं. LDL कराया 239, genetic testing was ApoB positive. So I said, we have no choice but to give him statin. So she agreed. We started him on statin. Now we have a good data which is published 2 years ago in New England Journal of Medicine on the safety and the efficacy of statin in children. This 25 years of follow-up is there. There we had a problem whether this child's puberty will be at risk or not if you put them on statin. Because the cholesterol is important for the sex hormone, for so many areas, even brain cells. People used to say children will be, their cognitive function will also be delayed because of that. But it didn't happen. 25 years of follow-up showed the children, those who are on statin versus those who are not on statin, did not make any difference. In one of the sub-study groups showed that they were better. Their even brain function was better, their sexual growth, their puberty, everything was better. So hypogonadism probably doesn't look like that it is a real reason for that. But certainly myalgia and diabetes.
Thank you. Thank you very much. Thank you very much. Please give a big hand to the speaker. And now I would like to invite please come to honor the speaker as well as the chairpersons. Sanskar is a very, very dynamic person who is of our house, who is of Yatharth family. Sanskar karega.
That is the Sanskar इनको all the chairpersons.
ग्रुप फोटो सर प्लीज सर आओ सर बाहर ही सब बैठना अभी तो बड़ा सामान आइए सर हमारी इस ऑर्गेनाइजेशन का जो है यंगेस्ट पिलर है देखो सर
Thank you very much, Dr. Sani, and thank you very much to all the delegates also for a very active participation. Well, the next talk is going to be on sarcoidosis, and none other than Dr. Randeep Guleria is going to give this talk. I would like to invite the chairpersons for this, Dr. Ashutosh Mohan, to please come on the dais. Dr. Soumya Mittal, the neurologist. Dr. Ashutosh Mohan is a senior physician from Ghaziabad. Dr. Soumya Mittal, he is a neurologist with our hospital, Yatharth Super Speciality Hospital, Greater Noida. Dr. Jayant Thakuria. Dr. Jayant Thakuria, he is the pulmonologist there in Faridabad with Yatharth group of hospitals. And of course I would like to invite Dr. Praveen Vashne to please come on the dais for sharing this session. Dr. Praveen Vashne is also a senior physician from Aligarh. Well, अब यारों दिल थाम के बैठो कि हमारी बारी आई. डॉक्टर रणदीप गुलेरिया विल बी स्पीकिंग ऑन सार्कोइडोसिस. मैं एक बात कहूँगा कि अगर आप डॉक्टर रणदीप गुलेरिया को नहीं पहचानते तो शायद आपके घर में टीवी नहीं है. हाउ डू यू रिलेट दैट? बिकॉज ही इज द वन फेस ऑफ द मेडिकल फ्रेटर्निटी हु इज मोस्ट ऑफन सीन in the TVs and shows, and after COVID or during the COVID, probably every day, every program, every channel was showing Dr. Randeep Guleria to be there. And now is the turn for chairpersons to please introduce the speaker and invite. Thank you.
I would request Dr. Randeep Guleria to give his talk. I think as Dr. Soni has said, we should not waste time in introducing Dr. Randeep Guleria because there would be hardly anyone who doesn't know him and he needs no introduction. We would rather have this time to listen to him. Dr. Randeep Guleria, please.
Thank you very much. At the onset, I'd like to take this opportunity to really thank Dr. Soni and the organizers for inviting me. And I'm going to be talking on the diagnostic challenges that we have as far as sarcoidosis is concerned in a country like India. So the first challenge that we face is that sarcoidosis is still considered an uncommon disease. As a matter of fact, when I was a resident, we were told that sarcoidosis actually does not exist in India and all granulomatous disorders are tuberculosis. Even when you thought that this was a classical picture of sarcoidosis, you did a biopsy, the pathologist would label it consistent with tuberculosis. I think we've come a long way from there, and if you look at the ILD registry, sarcoidosis is found in patients who had just interstitial lung disease in around 8% of cases. Similarly, if you look at data from PGI, which also looked at interstitial lung disease, they had sarcoidosis in almost 37% of the patients with ILD, a huge number. So the registry from India has two databases, one from PGI Chandigarh and one from the registry which was published in the Blue Journal, varies from about 8 to 10, 40%. If you look at the ILD registry, sarcoidosis is found in patients who had just interstitial lung disease in around 8% of cases. Similarly, if you look at data from PGI, which also looked at interstitial lung disease, they had sarcoidosis in almost 37% of the patients with ILD, a huge number. So the registry from India has two databases, one from PGI Chandigarh and one from the registry which was published in the Blue Journal, varies from about 8 to 10, 40%. If you look at data which is there for a long time, there have been case reports since 1979 of small series of cases of sarcoid which have been reported, both stage 1 to stage 4 being seen in various studies. And this is something which becomes more and more relevant. When we looked at our data many years ago, more than 20 years ago, from our clinic, we had almost 200 patients of sarcoidosis, predominantly from North India, and they were familial sarcoid also. We had 7 families which had features of sarcoidosis, either it was 2 brothers or a mother or a son, and therefore sarcoidosis in the familial form also tends to occur in our country. More recently, we looked at data which was there from the All India Institute of Medical Sciences, and this looked at 327 patients who were seen as far as sarcoidosis were concerned. And here again you find that the number is not small. And when you look at the age, it's usually around the 40s. And what you find is that there is equal distribution as far as males and females are concerned. But coming back to the same history, that if you start looking at history of tuberculosis, almost 30% of these patients were initially diagnosed to have tuberculosis and had received anti-tubercular treatment. So we still have this issue of tuberculosis versus sarcoid, and I'll come to that in the later part of my talk. So the first challenge that we have is sarcoidosis is considered uncommon, but I'd like to really say that it's a myth. Sarcoidosis, if you look for it, is not uncommon, and it's something that we need to keep in mind. The second challenge that we have is sarcoidosis is a systemic disease. It may have pulmonary manifestation, but by and large it's a disease which involves all systems of the body, and therefore it's very important for clinicians, for internists, for specialists to have a high index of suspicion as far as sarcoid is concerned. So sarcoidosis can involve the eye. You can have extensive eye involvement right from the conjunctiva, lacrimal glands, all the way up to the retina. There can be neurosarcoidosis, and this is sometimes a big diagnostic dilemma that we have as far as neurosarcoid is concerned. Of course, the simplest form is the Bell's palsy that you see as far as sarcoid is concerned in terms of neurosarcoid. But there can be other forms. There can be bilateral parotid gland enlargement, lung involvement, musculoskeletal involvement also tends to be very common, and then you can have involvement of the liver, the spleen, and as far as the heart is also concerned. So almost all major organs of the body are involved as far as sarcoidosis is concerned, and that is sometimes missed, and we don't look for all of these involvement. And it's important that we look at sarcoidosis not only from the organ that we're looking at, but from the patient that we're looking at, what is the systemic involvement of sarcoidosis. So I'll give you some pictures of our patients of sarcoid. This is a lady who is a lawyer. She had come to us with an old scar that she had just below her chin, and just below her lips and just at the chin. And this scar suddenly started showing elevation, that it started becoming itchy, it became nodular. This was a classical features that you see in sarcoid, that old scars suddenly flare up, and this is known as scar sarcoid. Similarly, erythema nodosum. One feels that because of our skin being dark, we don't tend to see that much of erythema nodosum. But if you start looking at the shin of your patients, you will find that erythema nodosum does occur in our country. These are 2 of our patients. One of them on the left is actually a staff nurse presenting with recurrent cough, shortness of breath, fever, and these nodular lesions which were present at the shin. And if you were able to combine all of them, you would think of sarcoidosis as a possibility. You can have other lesions. You can have hyperpigmented lesions as you can see in this picture, or you can have a diffuse rash which can also occur in patients with sarcoid. This is another lady of ours who actually had these lesions, which were scaly lesions on the face and on the legs, and unfortunately these lesions would always come back when I tapered off the steroids, and she would want to continue steroids for a long time because of cosmetic reasons, because she could not really have this scar on her face. But it's important to keep that in mind also. And I always tell my residents that look at the back of the neck, because very often you find that there are scars there, and you find these classical scars. They have 2 advantages. One, it gives you a high index of suspicion of sarcoid, but at the same time you have a site where you can biopsy, and if you are able to biopsy it and show non-gazetting granuloma along with the clinical picture, you are more confident in making a diagnosis. So you can have a large number of skin lesions as far as sarcoid is concerned: papules, plaques, nodules, alopecia, lichen planus, ulcerative lesions, and annular lesions. And these have been well reported in the literature, and it's something that we need to keep in mind and start looking for. Second is eye involvement. You must always look for ocular involvement. almost 15 to 28% of patients with sarcoid will have ocular involvement. You can have anterior uveitis, there can be eyelid involvement, lacrimal gland involvement, and conjunctival involvement. Corneal involvement, angle of the lens can be also, eye can also involve into glaucoma, and then you can have various other involvements. Again, if you were to look for these patients, you will find it, and therefore it should be mandatory that all patients that you suspect have sarcoid, a detailed eye examination can be done. You can see posterior segment involvement, and that is something that you need to keep in mind. The other involvement is that I'll try and sort of highlight in the form of a case. This is a 60-year-old individual who was admitted. He was actually the father of a resident in anesthesiology who was admitted with complete heart block in cardiology. He was diagnosed to have 6 sinus syndrome, and actually he was admitted for a pacemaker insertion. A routine X-ray showed some interstitial opacities, and actually the cardiologist asked us to have a look and said, why don't you have a look at this patient, because the X-ray is not looking good. Lung function showed a restricted effect with diffusion impairment, and we made a clinical diagnosis of sarcoidosis, advised to have a bronchoscopy, a transbronchial lung biopsy. The father and the son were not willing because they had just got an admission done for just pacemaker insertion. He presented 1 year later with hemoptysis, shortness of breath, and a consolidation with features of interstitial lung disease, and this time a biopsy was done. A transbronchial lung biopsy showed non-necrotizing granuloma, and along with the pacemaker he was started on steroids, and he's doing well. He actually came from Orissa. This is his X-ray of the scout film at that point in time. You can see the pacemaker, and in the CT also you can see the artifact of the pacemaker wires. But if you look at his lungs, you'll see there are multiple nodular shadows, and this patient does not have sclerodegenerative complete heart block. This heart block is a secondary complication of sarcoidosis which needs to be considered and treated. And this is the CT of the same patient showing this dense consolidation that he had developed. Another picture of the same patient showing the nodular involvement. So cardiac sarcoidosis is another thing that we feel is uncommon in our country, but if you look for it, you will find it, and that's why it's important. It occurs in about 5% cases. The data that we had suggested around 10%, and 70% cases demonstrate cardiac involvement at autopsy, so it's not really picked up, and it can be asymptomatic. You can have conduction abnormalities, patient can present with heart failure, sudden cardiac death, and there can be valvular and pericardial involvement. Many years ago, we published a series of 3 cases who presented to us in a very short span of time with cardiac sarcoid, and these patients, one of these patients actually presented with ventricular tachycardia. We had to be given DC shock for conversion in the emergency, subsequently was admitted, and on evaluation turned out to be sarcoid. We subsequently started looking at this, and we looked at about 100 patients who had no cardiac complaints. They had come with diagnosis of sarcoidosis, predominantly pulmonary, and we started evaluating them for any cardiac involvement. And we found that almost 10% of them had underlying cardiac sarcoid in the form of arrhythmias, in form of LV dysfunction, and also features on cardiac MRI which shows that they had features of sarcoidosis. So again, if you start looking for extra pulmonary involvement, you will find that there can be features of cardiac sarcoid also. If you look at the data that we had of 327 patients, you will see that almost 49, that is almost 50% of patients also had extra pulmonary involvement. So sarcoidosis does tend to have respiratory or pulmonary involvement, but significant number of them, almost half of them, will have extra pulmonary involvement. This could be involvement of the liver, the spleen, the musculoskeletal system, the eye, or it could be involvement of other organs like the heart, or you could have neurosarcoidosis. Coming to the third challenge, and I think this is also a very important challenge, that there is really no definite diagnostic test. Sarcoidosis is predominantly a diagnosis of exclusion, and that becomes a very difficult thing. Sarcoidosis, initially we used to have a Quime test which was like the Montu test, but that reagent is not available, and therefore the diagnosis of sarcoidosis is based on a compatible clinico-rheological laboratory features, a histopathology showing non-gaze ring granuloma, and most of the guidelines say that rule out other causes of granulomatous disorder. And when we come to a country like India or the developing world, tuberculosis becomes much more of a cause, and that is something that we need to keep in mind. The manifestation of sarcoidosis can be very variable. It can be from an acute presentation like the Lofgren syndrome, which can have erythema nodosum, fever, hyaluroretinopathy presenting acutely, the Hertford syndrome, which can have bilateral parotid enlargement, breathlessness, fever, and skin lesions, or you can have very subtle subacute presentation with fatigue, fever, night sweats, And then of course pulmonary involvement can lead to cough, shortness of breath, but extrapulmonary involvement can also be there, which unless you look for it, you can miss that. In the laboratory test, if you really critically look at the CBC, most of these patients will have some degree of leukopenia. ESR would be elevated. Must always look for hypercalcemia and hypercalciuria, because that is also something that happens in sarcoidosis, and we have patients who this has not been done and they've gone on to develop chronic kidney disease because of hypercalcemia and hypercalciuria. You can look at elevated ACE levels and soluble IL-2 receptors also. ACE levels are actually something that people do a lot, but remember they are elevated only in 25 to 75% of untreated patients. They have a poor specificity, and tissue levels of ACE usually tend to be high, but they are not usually useful as far as monitoring of the disease activity is concerned. The diagnosis that we really look for or really rely on is radiology, and that really gives us a diagnosis. You have this classical bilateral hyaline adenopathy. This led to the traditional scattering classification of sarcoid, but this was on X-ray. If you look at the scattering classification and then you look at the CT scan of your patients, almost 20% of a patient you thought had only hilar adenopathy or stage 1 sarcoid will actually turn out to have stage 2 sarcoid with also lung involvement. So you could have bilateral hilar adenopathy, which is in our series around 32%. You could have bilateral hilar adenopathy and lung involvement in around 44%, and stage 3 would be only lung involvement, or stage 4, which is end stage lung disease or fibrotic disease, which can occur in some patients also if the diagnosis is not made. But what is really important is the CT scan. You have hilar and mediastinal adenopathy. The glands are homogeneous, do not show any necrosis. They can be reticular opacities, nodular opacities, reticular nodular opacities. Classically, there are subpleural and peribronchovascular and tend to be more in the upper lobes. So these are the type of opacities that you see in sarcoid. I have already shown you the patient on the right. If you look at the patient on the left, you can see this dense subpleural shadows, and you can see that these fine nodules which are peribronchovascular, they tend to go around the blood vessels. This is a classical feature that you would see in sarcoidosis, which will give you an idea that this is sarcoid, and you should suspect sarcoid. But you can have a very wide presentation, and I am just giving you one of a group of patients that I have. These are some patients that are important because I think they came with a different diagnosis. The patient on the left hand upper corner actually came with a diagnosis of CA lung, because he had nodular shadows, but there was a dense mass-like shadow which was present. This patient came from Nainital, and a biopsy showed non-Gazing granuloma, and she is still doing very well, although the shadow continues to persist. The patient in the upper middle hand had actually pleural effusion. You can still see there is features of pleural effusion. She actually had she's given ATT for 9 months. She had a thoracoscopic biopsy, showed granuloma. She was diagnosed with MDR tuberculosis, started on treatment for MDR tuberculosis. But if you look at the lung, you will see that lung has multiple nodular shadows. And therefore, we thought that this is not tuberculosis. We did a transbronchial lung biopsy, which showed non-Gazing granulomas, started her on steroids, and her actual picture vanished. Her pleural effusion disappeared, her lung nodules disappeared, and she actually is doing very well. And therefore, unless you really suspect sarcoid, you will go down the path of TB and MDR TB. The patient on the right, the topmost right, again came with a diagnosis of metastasis, was having sarcoid. On the left lower side is a patient who actually had monoarticular arthritis, had a synovial biopsy which showed granulomas, again received ATT for 1 year, started having breathlessness, came with these nodular shadows, and again had a feature of sarcoid. In the lower middle part, you have this patient who had a collapse and was because of the node causing compression, and on the lower pass you have what is at times known as alveolar sarcoid. So if you look at the CT pictures, it can be very varied, but classical subpleural peribronchovascular nodularity really helps you in making a diagnosis. If you look at the data that we have from our series, you'll see that most of the patients are actually stage 1 or stage 2 sarcoid. Very few of them actually are stage 4. The other important thing is bronchoscopy. Sometimes doing a bronchoscopy, you can make out that this patient has sarcoid because you see a nodularity, granularity in the bronchial tree, which tells you that this is more likely to be sarcoid. Long time back when he looked at our patients, and this was a group of about 190 patients, just doing a simple plain bronchoscopy and a transbronchial lung biopsy gave us a diagnosis in 136 patients. Adding a bronchial biopsy from the secondary carina gave additional diagnosis in 15 patients, So overall yield was around 77%. 5 patients actually had a VATS biopsy. One because of the fact that the lavage showed some atypical cells and there was an endobronchial lesion. Unfortunately, this patient had a lobectomy, but the diagnosis subsequently came as sarcoid, so it was actually not required. Skin biopsy gave us a diagnosis in 31 patients, and I said that's why it's important to do a skin biopsy. Things have changed now with the advent of endobronchial ultrasound and rapid on-site evaluation, that you can do it in the bronchoscopy room, look at the slide and see whether it is positive or not. And data that we had subsequently published which showed that EBUS TBNA also has a high yield. You can have a yield going up to almost 90%. And this was also seen as far as the 327 patient data that was collated at AIMS showed that if you did a bronchoscopy, either EBUS TBNA or EUS BFNA, you had a yield of more than 90%. So sarcoidosis diagnosis can be made by now doing a lot of procedures which are simple to do, and they can help you in making a diagnosis of sarcoid. Many years ago, we also looked at the PET scan. This is a paper we published many years ago where we looked at the utility of PET scan for the diagnosis of sarcoid and seeing the response to treatment. And you can see that the PET scan really lights up to show multiple glands. In this patient, that you can see the PET scan showed uptake not only in the lungs but also in the periportal glands, also in the inguinal region, and this showed that the disease was, in most of these patients you find the disease as activity in other areas beyond the lung. This is another patient, and you can see this extensive uptake in the lung itself, but you can see this uptake in the spleen also and uptake in the periportal glands, and therefore PET gives you an extent of disease also as far as the patient is concerned. We repeated a scan in some of these patients to see how can these be used to predict response to treatment. So this is a patient who had a good response to treatment. You can see the significant decrease in the uptake as far as follow-up is concerned, as far as sarcoid is concerned, as compared to this patient who had no response despite treatment with steroids. The PET shows that the glands have actually become more, and it's showing that the disease is still very, very active. So sometimes in a patient who's not responding, or you have a diagnostic dilemma or a therapeutic response you're not sure of, a PET scan may also be useful. The fourth and most important challenge which I feel that we face in our country is differentiating tuberculosis from sarcoidosis, and this is something which is the biggest challenge that we as clinicians face in day-to-day practice. Is this TB? Is this sarcoid? You do a EBUS TBNA, you get a granuloma, MON2 is negative, patient has fever, loss of weight, appetite. Should you start giving anti-tubercular treatment or should you start giving steroids? So tuberculosis and sarcoid both are granulomatous diseases. Some people argue that they are two sides of the same coin. Persistently, sarcoidosis could be basically a persistently poor degradable antigen and a host response, and the antigen could be a tubercular antigen, and that's why it's argued that mycobacterium bacteria could also be a etiology as far as sarcoid is concerned. A lot of studies done from our center and from PGI Chandigarh, which try to look at this. Could tuberculosis, could it be that TB is a sort of sarcoid is in response to the tubercular antigen? As a matter of fact, one study in PGI gave patients with sarcoidosis anti-tubercular drugs along with steroids, but did not show it to be of any benefit. So if you look at the epidemiological, molecular, microbiological, clinical, histological, and immunological parameters, very, very similar, and this becomes very challenging to differentiate between the two. We published a communication many years ago trying to say that sarcoidosis tuberculosis still remains an unresolved issue. We tried to do some studies where we looked at T-cell signature cytokines as a part of a thesis of a PhD student, and did find that if you look at the blood samples and look at cytokine levels in pulmonary tuberculosis versus pulmonary sarcoid, TNF-alpha, IL-17, IL-9 tend to be significantly higher in PTB patients as compared to pulmonary sarcoid patients, but I think you need more studies to be able to really show that this is of much use. But sometimes you can have both diseases and sometimes it causes a problem, and I'll give you another case to really highlight what I'm trying to say. This is a patient I saw many, many years ago. He came from Bihar, he presented with fever, swelling on the right side of the chest. He had a fluctuant lump on the lateral chest wall. I saw it in the OPD, it was fluctuating, it was like a cold abscess. I put in a needle, I got frank pus, and it was AFB positive. Started him on ATT. This is the time when he used to give 2 drugs in continuation phase rather than 3 drugs that we give now, and he improved and the lump disappeared. This is the CT of this patient, and if you see carefully, you will see that there is, I hope this works. So if you see the CT scan of this patient, you can see there is destruction of the ribs, he has osteomyelitis, and you can see there is swelling out here, which is the cold abscess which this patient had. Now at this point in time, I thought the lung window was normal, but if you are very critical and look at the lung window, you would feel that there is some nodularity which is present as far as the lung is concerned. This is the lung windows, and you can see there are mediastinal glands also as far as this patient is concerned. So he was started on ATT. He came for follow-up to stop treatment after 1 year. He got lost to follow-up. He went back to Bihar. He said he was a bank manager. He was not getting leave, but he continued his anti-tubercular treatment and came after 1 year. He had a fresh CT done, and he was told by the radiologist that his disease has deteriorated. He has now developed MDR tuberculosis, and actually he was asked to start MDR tuberculosis. But when he came to me, he had no lump present. There was no tenderness there, but he was having dry cough and mild dyspnea on exertion. This is the CT of this patient now, and you can see that now what has happened is that those nodular shadows have flared up. The hilum has become prominent, but there are multiple nodular shadows, and now we did a transbronchial lung biopsy in this patient, and he showed non-gazetting granulomas. So he probably had a combination of the two, and there are some people who use the term sarcotuberculosis, that sometimes both of these diseases may be present. This patient subsequently showed good response to steroids, but did have significant restrictive lung disease. So we did publish a paper many years ago where we tried to say that there are challenges as far as sarcoidosis is concerned in tubercular endemic regions like India, and there is therefore a need that we really try and see what we can do as far as this is concerned. I think what we tried to do was, how do you tease out the differences between sarcoid and tuberculosis? So if you look at sarcoidosis, constitutional symptoms tend to be mild. Tuberculosis patients have more symptoms. Cough usually is dry. In patients with sarcoidosis, patients with tuberculosis usually have a productive cough. Hemoptysis is much more common. Montu or tuberculin test is something which we consider very, very important. Sarcoidosis patients have what we call cutaneous energy. So they tend to have lymphopenia, and they have more lymphocytes in the lung, in the organs, and because of that, you will have a Montu which is usually negative. Sarcoidosis patients, you will have patients who will have positive Montu. They develop sarcoidosis, the Montu becomes negative because they have cutaneous energy. So if you have a strongly positive Montu, it goes more in favor of tuberculosis and less in favor of sarcoidosis. So Montu test is usually negative as far as these patients are concerned. And if you were to look at the IGRA, the quantiferon gamma release assay, that would be positive. So quantiferon doesn't go hand in hand with tuberculin test. ACE level is more commonly elevated in tuberculosis. Hypercalcemia and hypercalciuria favors the diagnosis of sarcoid. Similarly, if you look at nodal involvement, extrathoracic lymph nodes relatively less common as far as sarcoid is concerned. The nodes tend to be more homogeneous, whereas in tuberculosis they are asymmetric. You don't see this bilateral hilar adenopathy. Central hypodensity or necrosis on the nodes on CT scan is not usually seen. Cavitation is rare in sarcoidosis. Nodules are classically peribronchial or subpleural, as I showed to you, and biopsy usually shows non-gazetting granulomas, unlike what you see as far as tuberculosis is concerned, where you have gazetting necrosis, intense inflammation, and ill-formed granulomas. So I'll conclude by saying that sarcoidosis is not an uncommon disease in India. You have to have a high index of suspicion. It has a varied presentation from asymptomatic patients who just come on a medical checkup and you have hilar adenopathy and they are diagnosed to have sarcoid, but they are totally asymptomatic. We see such patients, and sometimes we have a problem because you have to give a certificate that they are fit to do duties and they don't have tuberculosis. Or it can have life-threatening presentation like the patient I mentioned who had ventricular tachycardia. It can involve any symptom. It's a multi-speciality disease, and I think that is something we need to keep in mind. As internists, it's important for you to keep that in mind. Even if when you suspect sarcoidosis, examine your patient thoroughly. You may find certain clues on your systemic examination which may tell you that this patient has sarcoid. The use of CT, HRCT, bronchoscopy, EBUS has increased our diagnostic yield, has made us more aware that sarcoidosis is not uncommon, and we're able to diagnose it more. However, challenges in differentiating sarcoidosis from tuberculosis still remain in our country, and that's where clinical acumen is required. And like I mentioned, Montu is a good surrogate marker to help distinguish tuberculosis from sarcoidosis. If that at times it may help you in certain situations. Thank you very much.
Thank you for enlightening us about that disease, which is more common than we anticipate. I would request you to please join the panel here, and now the house is open for any questions. Yes, you can go ahead.
Hello. So, I have a case right now of sarcoidosis presenting with all manifestation of lung manifestation, but he presented with fever, and whenever he presented fever, he was given steroid. Patient's fever subsided, then steroid been tapered off. Again, after 2-3 years, again in relapse, again fever comes, again given steroid. So I just want to know, like that patient has a high ANA positive also, ANA titer positive. Like, can we go for immunosuppression, then followed by biologicals in those cases?
So I haven't covered the treatment part as far as sarcoid is concerned, but the tendency now is to give low dose steroids, and there is a paper in the NEGM which has looked at methotrexate as the first line treatment rather than steroids, and showing that methotrexate is equally effective, and therefore you could give drugs like methotrexate as an alternate, and especially if the patient is requiring repeated courses of steroids. And then there is of course the use of biologicals. Infliximab is also something that is given for patients who are not responding or who have sarcoid which is resistant to the first line treatment. But if he is having recurrent sarcoid, or he is having relapse of sarcoid, I think you should consider non-steroidal drugs like methotrexate.
Thank you, sir.
Any other question? Yes, Dr. V.B. Jindal, you had some question there?
There is a practical problem. When to stop? जैसे सरकार का reference होती है बहुत सारे कहीं. When to stop steroid or any?
So sarcoidosis, the two important issues: when to treat and when to stop treatment. So I think the important issue is that all patients with sarcoidosis don't need treatment. You have a patient who has bilateral hyalinopathy, who is asymptomatic, or who has no vital organ involvement. Sometimes it's just to give symptomatic treatment and he will go into spontaneous remission. So many patients with sarcoidosis who come really don't need any treatment. As a matter of fact, there is some data which suggests that if you give such patients steroids, they have a higher chance of relapse later on. You should allow the body itself to be able to go into spontaneous remission. If you have significant constitutional symptoms which are affecting quality of life, or if you have major organ involvement, if you have lung involvement and lung function is deteriorating, if you have cardiac sarcoid, if there is neurosarcoid, eye involvement, which is not responding to topical treatment, then one should give steroids. Current recommendation is that low dose steroids, 20 milligram of prednisolone is good enough rather than giving high dose which used to give 40 to 60 milligrams. And you give it for 4 to 6 weeks and then taper it off quickly to a low maintenance dose, which you should give for around 6 to 9 months. If you give it for that duration, the chances of relapse become less. Those patients who tend to have a relapse, then the treatment of choice becomes drugs like methotrexate. And like I said, there is now a move towards trying to see whether we can give methotrexate upfront. In those patients who you have to treat for sarcoid, why don't we give methotrexate and not give steroids? And this paper which is published this year in NEGM showed that the response was equally good if you give methotrexate in the beginning and not steroids, and with lesser side effects. One drug that we tend to use often when there is more of musculocutaneous involvement and have found useful is hydroxychloroquine. So we tend to use hydroxychloroquine also a lot. When we started looking at sarcoid more than 20 years ago, we did a study also where we compared hydroxychloroquine with steroids in patients with stage 1, stage 2 sarcoid, and showed that it was effective. And therefore, off and on we do give hydroxychloroquine in some of our patients also, trying to get away with steroids as because of the side effects.
Can we use a combination of?
Yes, so that is the important issue, and there is a study which is also being done in PGI where they want to start with short course of steroids for a very short duration and then give methotrexate. The reason I'll explain to you, methotrexate effects takes a longer time to come. Steroid effect occurs immediately. So the issue, the philosophy is, can you start steroids for a short duration for a good response, and then taper off steroids quickly and then continue methotrexate for a longer time for the response to be there and lesser side effects. So ultimately I think this is where we will reach. we may give a short burst of steroids for patients' improvement and then continue methotrexate on a weekly basis for a longer period. But we need more data on this.
Yes, Dr. Sandeep.
So thank you very much. Hello.
It's working.
Hello.
Yes.
So thank you very much for that enlightening talk. In my series of patients of sarcoidosis which I have treated, normally what I would go by is give them steroids, prednisolone, a moderate dose of 1 to 2 milligram per kg body weight for about a month, and then over 2 to 3 months I have tapered them off, followed with a steroid sparing agent like methotrexate or even azathioprine for that matter in many of the patients, and continued for about 1 to 1.5 years, and we have seen a lot of resolution of the lesions, mostly cases of mediastinal lymphadenopathy. Secondly, to that specific scenario that Dr. Jayanto you said, sarcoid patient and ANA positive. Well, autoimmune disorders are known to coexist. So when we have a ANA positive state, obviously it becomes very mandatory to go in for the ENA profile and subclassify the type of rheumatological disorder that this patient may be having. Because in both cases, the response to steroids and methotrexate would happen. But then we would still not be knowing what other connective tissue disorder does he have. So I think a detailed diagnosis of the connective tissue disorders by the ENA profile and all is mandatory. Thank you very much.
So one question is like methotrexate also have a side effect of a lung involvement. So is it methotrexate or azathioprine which is better in that point of view? Sir?
So there was a lot of initial scare that methotrexate over a period of time can lead to interstitial lung disease. But there is now more and more data which suggests that probably it's not that common. It's a very rare manifestation. And therefore even rheumatologists would suggest that methotrexate should not be withdrawn. You can continue to give methotrexate even in the presence of ILD if it's required. And in patients with rheumatoid arthritis who have rheumatoid arthritis associated ILD or rheumatoid lung, if methotrexate is required, we usually continue it now and don't stop it. So initially there was a lot of fear that you could have methotrexate induced lung injury, but I think there's more of a fear rather than actual what we see in day-to-day practice.
Any other question from anywhere? Okay, thank you. Thank you very much for a very enlightening talk. Let us give a big hand. And now I would like to request our Director of Yatharth Hospital, Dr. Manju Tyagi, please come and honor the speaker as well as मैडम ये चेयरपर्सन को भी देना है Thank you very much for this session, and the next session is again going to be very interesting, and everyone is looking forward to listen to this talk. And for this session, I would like to invite the chairpersons, Dr. Manish Kak. Dr. Manish Kak He is a senior gastroenterologist, DM gastroenterologist from Ghaziabad. Dr. Kiran Soni, she is a nutritionist. Dr. Naveen, he is again a very senior person and entrepreneur who has got a chain of Naveen hospitals all over this area. And of course, I would like to invite Dr. Ashwani Kansal also to please join here for the session. This session is again going to be very interesting, where we would like to know that how does the fat flows through the body, and it is now the chairpersons to please introduce the speaker and invite. Thank you.
So it's my privilege and honor to introduce Dr. Anil Arora. He is a director Institute of Liver and Gastroenterology and Pancreatic Biliary Sciences Hospital, Sir Gangaram Hospital, Old Rajendra Nagar, New Delhi. His key achievements and the contributions are Fellowship of Royal Challenge of Physicians and Fellowship of Royal Challenge of Physicians of London, experience in treating chronic hepatitis B and C infections, hepatocellular carcinoma, and stem cell therapy. He is heading the third space endoscopy program with experience of more than 500 procedures. He is a chief architect in formalizing the Indian guidance for management of hepatitis B, immunosuppression, and HBV, liver disease in pregnancy, kidney and liver diseases. So his topic is journey of fat in the body. Welcome, sir.
Before we start, I tell you one thing. I have heard Dr. Anil Arora a few times, and whenever he speaks, it's really mesmerizing. And I'm sure that you are going to enjoy his talks a lot. Dr. Anil Arora, please.
Thank you, sir. Thank you for the elaborate introduction. At the outset, I am grateful to the API chapter for giving me this opportunity. I am coming to the dais after the celebrated talk by the big wigs of Delhi and NCR, Dr. Randeep, Dr. Talwar and Dr. Sani. But after those high-tech talks, I am just going to take you back to the mundane body and the desolate food which we are going to eat soon. I am sure Dr. Soni has arranged a delicious dinner, but what happens to that fat and the carbohydrate in the dinner? I'll just take you through the journey of the fat in the body. Is the fat, which Dr. Sani very well said, is not as bad as the carbohydrates. So between the two, how do we choose the lesser of the two evils? I'm going to tell you about it. So is fat good or bad? Is it your friend or enemy? That is what I'm going to delineate. But then what is fat? As a commoner, as a non-medico, do we know what fat is? Fat by default is a word that has several meanings in biology. It can be a tissue, it can be a cell type, or it can be a class of molecules. So you can have a simple molecule which is making fat. When these molecules coalesce together, they form tissue, and finally the fat might reside in the cell itself. But then what is fat by default? It is a simple way of knowing this is that you have a carbohydrate moiety, a product of glucose metabolism called glycerol. When this gets in consonance with three fatty acids, so you have three fatty acids which get attached to the carbon moiety called glycerol, then this becomes triacyl glycerol. So you remove water from each of these three fatty acids, then you tend to develop this molecule called triglyceride, which is also referred to as TAG. Dr. Sani did tell us why the triglycerides are bad. So what is triglycerides? Basically a glycerol moiety which has three fatty acids attached to it. This is called TAG. For all practical purposes, TAG in colloquial language would mean fat for us as human beings. So triacylglycerol is what we call fat. So basically you have this again to reiterate. So this is the glycerol side chain, and you have 3 different fatty acids which are attached to it, and this whole complex is called TAG, triacylglycerol or fat. So what are fatty acids? I said there are 3 fatty acids attached to a glycerol moiety. Fatty acids are straight hydrocarbon chain organic acid. These are acids. The number of the carbon atoms in the chain is variable from 4 to 24. Because fatty acids are synthesized by extending the chain of 2 carbon atoms at a time. If you go back to your knowledge of biochemistry in Harper and Collins textbook, the fatty acid synthesis by default involves addition of 2 carbon moieties at the same time. So you always will have fatty acid will be even in number 16, 18, 14, 12, etc. But the most common fatty acids which are a part of the fat basically have fatty acids and the carbon moieties which are in the number of 16 to 18. So these are the central carbon molecules and which has associated hydrogen in it. So this is a fatty acid. We also are pretty aware of the fact that the patient will come and tell us, and Dr. Sani had been repeatedly insisting, take saturated fat, and do not take saturated fat, take unsaturated fat, and there is so much of halla and bulla about bad effects of the saturated fat. What is the difference between the two? Now the difference is that in a saturated fat, all the carbon atoms have a concomitant hydrogen which is attached to it. So this is a palmitic acid, 16 carbon saturated fatty acid. There is no more hydrogen which this molecule can gulp to. There is no more hydrogen which you can stuff into this. So this is a saturated fat. At times there is one place where you can push in a hydrogen molecule. This is a monounsaturated fatty acid or MUFA. Then there may be a fatty acid in which there are multiple areas in the carbon where you can just jet in the hydrogen atom. That is a PUFA or polyunsaturated fatty acids. I am sure almost daily patient will come and ask you which oil is better, why should I avoid a saturated fat, what is a MUFA and what is a PUFA. So a carbon chain which is saturated with hydrogen is a saturated fatty acid. A carbon chain in which you can just shove in one hydrogen atom is a monounsaturated fatty acid, and when you have multiple hydrogen which can be jettisoned into the carbon chain, that is called polyunsaturated fatty acid. So one chain is monounsaturated if you can attach 2 chains of hydrogen. So that is the basic difference between the 3. If you have a saturated fat, that means you have a straight carbon atom in which, say, straight carbon chain in which hydrogen atoms are jetting in. So the total complex becomes straight, laminated and becomes solid. So by default, if you see something solid at room temperature like butter, so it is a saturated fat. Whereas if the fat is not saturated, that means these chains are not aligned linearly, then you will have a fat which is liquid at body temperature, at a room temperature. So that is an unsaturated fatty acid. So how do you distinguish between a saturated and unsaturated fatty acid at room temperature is the fact that saturated fat acid by default will have straight chains and will be solid, whereas unsaturated fatty acid, because they have bent chains, will also tend to be in the form of liquids. Moreover, the liquid melting point also is always high. Why is it that we are talking of fat? Dr. Soni had 2 lectures, one in cardiology, one in gastroenterology on fats. Are they important to us? Are they our enemy or friend? Let's try to delineate it. Now, most lipids are in fact a predominant component of the food. Dr. Sani told us that why Asians are having higher tendency for cardiovascular events and coronary artery diseases, that we as Indians and Asians tend to develop a higher rate of MACE events or cardiovascular event. That is because we have a central obesity and we tend to take a lot of carbohydrates. But fat is an important predominant component of the food. In fact, 40% of our own diet has to contain fat, which is an important component because you cannot live without it. It is an important component of the cell membrane. Cell membrane is made up of cholesterol and a biphospholipid layer. And the only way we survive today is because we have an intact cellular membrane. We have grown as human beings after evolution from a single cell like amoeba. But the basic tenacity of us sustaining life is the maintenance of the integrity of the cell. If we disrupt the integrity of the cell, we will die. And 60% of our resting energy in the body or basal metabolic rate is used only in maintaining the integrity of the cellular membrane by this enzyme called potassium ATPase. So 60% of our body energy is important in just maintaining the cell. Just imagine how important is maintaining the integrity of a single cell. So of which phospholipids are an important component. And then all of us know that most of the hormones, including steroid hormone or growth hormones, have fat as their major component, which comes from the cholesterol. Cholesterol is made from the fat. So what about dietary sources of the fat? So you have saturated fatty acid, you have unsaturated fat, and you have something called trans fat. I'll give you the difference between the two. Let's see what happens to the fat when we consume in the body. See, imagine this gentleman having a pizza or a burger with a lot of fat. As the food goes inside the esophagus, it travels quickly from the stomach into the intestine. As the fat is not soluble, so it needs the help of bile to produce this mucilage, which will tend to break the fat globules into smaller particles. These smaller fat particles are fatty acids. They get absorbed into the intestinal epithelial cells. And even though glucose and amino acids are transferred directly into the blood cells, fat is transferred by the lacteals into the aegis channel and from there into the portal circulation. So the fat which is absorbed is from the GI tract, first goes into the muscle and into the adipose tissue to supply fat before coming back into the systemic circulation and liver. Whereas glucose and proteins are absorbed directly into the portal circulation. So the basic aim of absorption of the fat is to supply fat, which is so important for maintaining the cell integrity and giving the component of cellular membrane to the muscle and adipose tissue before it comes back into the liver. So this is what happens. Once you have consumed your food, it goes into the stomach, and from the stomach it transgresses into the duodenum, where with the help of bile acid, it is picked up. It goes first into the chylous tract, it goes into the chylus cisterna, supplies fat into the fatty tissue and muscle, depending upon the circumstances, before the remnant fat, which Dr. Sani was referring to again and again, comes back into the liver. So this axis is so important in maintaining the integrity of the cell membrane. Let's see, once the fat has got into the body, what is the fate of the absorbed fat? Three things can happen. You may be deficient of energy, and it is a source of energy. Mind you, the reason why we have evolved as human beings is because we have a tendency to store our carbohydrate and protein as fats. Anything which you eat, Dr. Sani said carbohydrates are bad. The reason they are bad is because if you are storing, taking carbohydrates, after a limit, carbohydrates cannot be stored into the body. They have to be stored necessarily as fat. This is something which human beings have learned from the birds. Transatlantic bird will travel for 6 months at a stretch from a North Pole to South Pole without any food. They don't have an intermediate station or a hotel to rest in between. So they have a tendency to store fat in their liver. This storage of the fat gives you a constant source of energy, because without energy you cannot survive. So if you are in absorbing fat, it may be used as a source of energy through beta oxidation, and all of you know how this beta oxidation gives you energy. If you take extra fat or extra carbohydrate, it is stored in the adipose tissue. That is what results in the obesity or central obesity or less activity. And finally, as I said, it is useful also for maintaining the structural protein. Let's see the fat which we have absorbed. This is something which was, even a news for me. If you look at the chemical composition of a fat molecule, one molecule of TAG, so it has 55 carbons, 104 hydrogen and 6 oxygen. And when the body metabolizes this fat with the help of aerobic respiration, it produces hydrogen and carbon dioxide. Can you imagine 84% of the triglyceride mass is destined to become carbon dioxide. Nobody thinks of this, nobody talks of this in terms of the contribution to the pollution. We talk of stubble burning, we talk of all these crackers in the Diwali and the pollution by the vehicular traffic, but this is an important composition which human beings are contributing to presence of carbon dioxide in the body. So that is something which is an important cause of air pollution, which is frequently looked down upon. Is fat important for us? The answer is big yes. Now if we were to only take carbohydrate as a source of energy, we have no fat or protein in the diet, we will be able to store only 500 gram of carbohydrates in the form of glycogen in the liver. Now we know 1 gram of carbohydrates gives you 4 calories. So if you have 500 gram of carbohydrate as a total energy source, you will be having only 2000 calories. That means if from childhood we had been only taking carbohydrates and had a store of 500 gram, if we are not eating for 1 day, we'll die within 1 day. But we know people like Anna Hazare and others, they fast for about almost 30 days at a stretch. So how do they survive without food? So God also has given protein as a part of the diet, in which we store protein as muscles. Typically, an adult will have around 6 kg of muscular mass. 1 gram of protein gives you 4 calories. So if you have 6 kg, so you will have 4,000 calories. So if you are dependent only on protein for survival, you will be able to survive for 12 days. But look at this adipose tissue, which is typically in a normal adult about 12 kg. And adipose tissue fat gives you 9 calories per kg, per gram, compared to 4 of carbohydrate and protein. That is the basic biochemical knowledge. So you are having about 1,10,000 calories and you may be able to survive for 60 days without eating anything at all. So that is the beauty of evolution of the human beings, by our tendency to store fat. But this we have learned over millions of years ago to store fat. But at that time, we were doing manual labor, we were actively working, but now our genes are the same. They tend to store the fat, but our activity has gone down. We have moved over from labor's work to a white collar job. Our activity has decreased and our total meal content has gone up. That is what has resulted in obesity and this metabolic syndrome. So if we store fat in the adipose tissue, so where do we store it? So we will keep storing it in the subcutaneous tissue. That means on the buttocks, on the thighs, on the armpits. But when that capacity to store in the subcutaneous tissue gets exhausted, this fat gets deposited into the visceral adipose tissue. That means around the pancreas, around the liver, around the heart and blood vessels. That is where it starts giving you the trouble. So far as you have a tendency to keep pooling the fat in the subcutaneous tissue, you will have a jolly well outcome in the life. But the moment the shift over occurs from the subcutaneous tissue and the visceral tissues, it starts giving you the trouble. And it is also important, fat, for maintaining the structural component of the body. It maintains a healthy skin and hair. It maintains a right body temperature. It gives you smooth functioning of the cells. It is so important for cushioning of the vital organs like heart, like kidneys. They are all surrounded by the fatty tissue. Otherwise, it will keep moving. These organs will keep moving and get distracted. It is very important component. Dr. Sani again mentioned about EPA and DHA as a particular type of fat which may be useful in fish oil. So this is important for maintaining the integrity of the neuronal system in the retina and the brain. Fat, all of us know, is important for absorption of the fat soluble vitamins. It is an immune booster and it is a shock absorber for the bones, because if you do not have fat, you will have more tendency to fat. So it is a very good friend of yours so far as you know how to handle it. But then how is it that suddenly you shift over from a friend to an enemy? It's like our relationship between US and India keeps changing frequently. Or you are a friend on one day, then you suddenly become foe and the tariffs go up. That is because now you are moving on to lesser work at place, you are consuming more calories, and you look at the all data. Dr. Sani said 30% of the population is fat. If you look at Indian data, by 2040, 50% of the obesity in the world will be prevalent, and we might have the dubious distinction of becoming We at the moment are the third most obese country in the world, and by 2050 we may be the most obese country in the whole world. Why is it that diet is the problem? Because now, because of the competitive market of the marketing strategies, now we are giving higher proportions and higher amount of pizzas and burger, bigger per pizzas, buy one get one free, all these schemes. And over a period, if you see what has happened in the diet, that overall, if you see from 2015 versus 1975, we have a 20% increase in the total dietary consumption in the Indian scenario. And if you see this area, this was an article from Times of India, that over the last 30 years, our consumption of the diet has increased by 120%. Even though our manual labor has plummeted down, our calories have been going up. So I have told you, once you do not want to store it as energy, once you have deposited, stored in the subcutaneous tissue, and still if you continue to imbibe more fat, it will be getting stored in the aberrant tissues. That is something which starts giving you the trouble. That is where we as doctor come into the play, as physician, gastroenterologist, cardiologist, and almost everybody. So there is a concept of behavioral problem in patients who are obese. So if you are taking excessive nutrients in the food, you will tend to develop obesity. Once you have obesity, you are likely to have insulin resistance. Once you have insulin resistance, you have a fatty liver. The moment you have a fatty liver, which is present in about 40% of the Indian population, that gives you a chain of cascades of the events like diabetes, hypertension, stroke, malignancies, and whatnot. So how does it develop? So there is people say there is a problem in the brain. There is something called adipostat. You would have heard of a thermostat or a barostat. Thermostat gives you the temperature in the AC. Similarly, there is something called adipostat in the brain, which tends to maintain a particular degree of your fat or weight in the body. So look at this gentleman, this chubby guy. If he keeps eating a lot of these chocolates and candies, so that will lead to rapid absorption of the monosaccharides into the blood. So it will lead to hyperglycemia. So this high glucose is taken up by the insulin into the fatty tissue, which releases a substance called leptin. This leptin, which is released from the adipose tissue in response to the incoming glucose, tells the brain that enough is enough, stop eating. So that is the basic fluid feedback mechanism made by the body. So that was the normal person who is doing this. Look at this chubby guy. Now in this gentleman, who is this boy who keeps on chewing these candies, when you are taking in these candies, there is nothing wrong with the intestinal tract. Glucose will go into the blood, adipose tissue will get stimulated, produce insulin, but leptin. But there is something wrong at the level of the brain, that this leptin is not able to tell the brain that there is enough glucose in the blood. So brain still thinks, because it has not received a signal, brain still thinks it's hungry and keeps on asking more and more. So there is a hypothalamic problem in patients who are obesity. And once you have fat in the liver, mind you, major part of it again is related to insulin resistance and overactivity. Diet does not play much role in development of fat in the liver. In fact, insulin resistance is something which is very important for causation of this. Obesity can cause fatty liver. In fact, if you see, modest weight loss of 5 to 10% will lead to reduction of the fat in the liver, and weight gain of 10% by overfeeding with fast food and sedentary lifestyle can increase your fat. So there is a direct relationship between what you eat and what you deposit in the liver. So let's see, if you keep on eating lot of fat, lot of carbohydrate, what happens in the body. So as you eat your food, you have a glucose which goes into the blood, and then from the blood, the fatty acids are pushed with insulin to store it as fat, because all carbohydrates in the body can only be stored as fat in the body, not as glycogen, because there is a limit to which the glycogen can store. That is the reason God has given us a lot of subcutaneous tissue to store the fat. Now as the fat is entering the adipocytes, gradually and slowly, in the normal course of the event, this is an adipocyte, it has a mitochondria and it has a droplet cell. In addition, there are other cellular structures in this. As you keep eating, you see this fat globule is expanding. So it is pushing the mitochondria to the side, and it is changing the macrophage from type 1 to type 2. So you have pro-inflammatory cytokines which develop in the fatty tissue. So as fatty tissue is stuffed with more and more of adipose tissue, it gets ischemic and produces pro-inflammatory cytokines. So these pro-inflammatory cytokines, I am sure you know very well as TNF-alpha and IL-6. This is what leads to development of insulin resistance and deposition of the fat in the liver, which is a source of all the problems which will occur subsequently. How does it occur is that in the normal course of the event, you have an insulin which when acts on the insulin receptors in the body leads to tyrosine phosphorylation and opens up the GLUT4 channels so that the glucose in the blood enters the particular cell for consumption of energy. In patients who have insulin resistance, which occurs because of the ischemia in the adipose tissue, this tyrosine is replaced by serine. So the insulin which was pushing the glucose into the adipose site does not act. So insulin resistance is what is giving you all the problem. And it occurs both because of the overconsumption of the food and because of the ischemia in the adipose tissue. So once you have insulin resistance, you will have cascade of events. So with fat globules, you will initially mitochondria which were normal, they now become swollen and rounded, and you have inflammation in the liver. And once you have inflammation in the liver, you tend to develop hyperinsulinemia, hyperglycemia, and pro-inflammatory cytokines, resulting in formation of diabetes. So occurrence of the diabetes may be occurring at the level of the liver. Once you have diabetes coupled with fatty liver, you will have atherogenic dyslipidemia, which Dr. Sani was referring to. So not only is that releasing a lot of pro-inflammatory cytokines into the circulation, it is not only affecting the cardiovascular system, but it also affecting the kidney, as well as once you have a hyperinsulinemia, because now insulin receptor cannot open up the GLUT4 receptor to let the glucose enter the cell. So you have hyperinsulinemia. Hyperinsulinemia will also aggravate your mitogenic signals, leading to GI cancer. A diabetic is 8 times more to develop 18 times different malignancies because of the presence of the insulin resistance, which is very important. So fatty liver causing insulin resistance is also important in development of hypothyroidism, polycystic ovarian syndrome, osteoporosis and hypogonadism, and PCOS. And you will be surprised to know that 20% of the young Indian women have PCOS. Problem again lies in the hyperinsulinemia, which occurs because of the ischemia in the ischemia which tends to occur in the adipose tissue. So what is excess fat, which was a friend of ours till now? What does this excess fat do now? It will produce non-alcoholic fatty liver disease. It will produce obesity because you are depositing so much in the subcutaneous tissue. It will trigger the development of diabetes because you are producing insulin resistance because of the changeover from tyrosine to serine. And because of the pro-inflammatory cytokine, it will trigger hypertension, coronary artery disease, atherogenic dyslipidemia, coronary artery disease, malignancies, and endocrinopathy. So same fat which till recently was your good friend turns into your foe. So to conclude, ladies and gentlemen, fat is an energy-rich nutrient which is digested and absorbed by a tightly regulated process. Though invaluable in maintaining health, dietary excesses may lead to a plethora of problems with the potential to affect almost every organ system in the body. The initiation of the fatty liver and insulin resistance, that is the reason most of these patients will come to a physician or a gastroenterologist that they have a fatty liver. It is for us to see the cascade of the event which is unfolding beneath that. They are very crucial initial steps in the disease cascade and need to be addressed timely and aggressively. So a friend like fat, which was maintaining your skin, maintaining your body temperature, was important for functioning of your body system, was giving you the cushioning of the organs, was important in maintaining the neuronal system in the brain and retina, was important for absorption of fat soluble vitamins, and was boosting your immunity, suddenly turns foe when you have excess fat by causing fatty liver disease, obesity, dyslipidemia, metabolic syndrome, and the bad effects on the heart, liver, kidney, and whatnot. So how do we deal with this fat? I think that question I leave to Dr. N.K. Soni, that if this movement called Men After Me Too movement, as much as you would love to kiss this young lady, beware away of this Me Too movement also. Thank you.
Thank you. Thank you. Thank you so very much for very enlightening as well as very frightening talk. that what we are going to eat tonight, we have to remember these two talks by Dr. Sani and Dr. Arora, and then you should try to fill your plate in the night, and then you will enjoy that. Well, now I would request Dr. Arora to please join the panel, and will ask the panelists to please moderate this session.
Thank you. Thank you. That was a really excellent lecture by Professor Arora. I have been listening to his lectures in our gastro conferences as usual. Excellent talk. So a couple of points. Number one is that this leptin, of course it is for hunger, but when we see people, those who take sugar and sweet foods, they are full actually, but still they take these foods. So probably I think some reward system, which is a dopamine related problem in the brain, just like alcohol, which gives the person the urge to eat food, the sugary food, because leptin has given fullness, but that reward dopamine function is still working. So I think that is another pathway that probably triggers this. That was one point. Another is that coming to your first or second slide, patients ask us, sir, which ghee, which oil? So what is your recommendation? How much ghee, if at all it is allowed, and which oil a person is allowed? Out of PUFA, MUFA, we have olives and we have sunflower. So this is a practical day-to-day question.
Yeah, coming on to your first question of the reward center in the brain. This basic urge to have satiety or hunger is extremely complex. It is a peculiar event which tends to happen only in the higher animals like human beings. I think this is a topic which will request Dr. Soni to have another 45 minutes talk or 1 hour discussion on the complete programming of the brain. But suffice it to say that there is something called hedonic hunger, emotional hunger, and a metabolic hunger. That is something which we need to understand. Now, emotional hunger is anybody who is stressed out, is tense, and has a fight with a family member. You tend to overeat and go to sleep, because sleep gives you rest and takes you away from the stress. Then there is something called metabolic hunger, which is true. That means you have been working since morning, you haven't had anything, you have done a laborious work, and you feel hungry. That is a true hunger. And there is something called hedonic hunger, which Dr. Manish was referring to, which gives you a pleasure. It's like you like ras malai or you have sona halwa. It tastes you so much that you think, okay, chalo do aur kha lo, phir sair kar lenge. Sair to kabhi hogi nahi, but do andar chale gaye. That is called hedonic hunger, which has something to do with wiring in the brain, which is very poorly understood. If we have to go with one lesson today, I think eat only when you need to eat. What happens is Dr. Soni would have arranged a dinner at 8 p.m. Every one of us will go. And mind you, 9 out of the 10 of us will not be hungry. But still we go and pick up the dinner plate and go for dinner. So that is a hedonic hunger. So let's stick to the metabolic hunger if you want to remain healthy. Second question is about different type of oils and saturated versus unsaturated fat. There is no doubt that if you have to take unsaturated fat, primarily the vegetable based oils. Anything which is saturated is more likely to be toxic not only to the liver, but is also more likely to be toxic to the endothelium and predisposes to development of coronary artery disease. So vegetable oil in moderate quantities better than saturated fat in general.
Very informative talk. I would like to ask, comment on this, that there is a line between that fat is a friend and the fat has become enemy, and that is mainly the physical activity part, portion control, and the circadian rhythm. So your comments on circadian rhythm, sir.
Yeah, I'll agree. You see, if you look at the different types of diet which are prescribed, you have keto diet, low calorie, ultra low calorie, and intermittent fasting. But what ultimately boils to is a concept called KICO, calorie in and calorie out. One thing I'll recommend to you is weigh yourself daily. Every time you go to take a bath, with minimum clothes on, just weigh yourself. If you think you are half kg or 1 kg higher after Dr. Soni's dinner, tend to decrease the intake next day. What happens is people do not weigh themselves for about 2 or 4 weeks, and then you suddenly realize that 4 kilo बढ़ गया. 4 kilo will not get over over the night. It will occur with the passage of time. So have a habit of restricting your calories intake. I sincerely believe, irrespective of what you eat, because there is a very little scientific evidence of prescribing one diet versus other. What matters is the total calories which you take. That has to be commensurate with the basal metabolic rate. Because as I said, in the adipocyte in the brain, if you take an extra low calorie diet to become thinner and lose weight faster, body tends to decrease your basal metabolic rate. So that means you are eating less, you are spending less, you come back to the same stat. So the adipostat in the brain tends to again raise your bar and tend to increase your weight. So just restrict the calories and maintain your weight. That is the best advice. Exercise is important. The difference between exercise and diet is very important. I'm happy, ma'am, you have raised this issue. Exercise will make you metabolically fit. That means your chance of having diabetes, hypertension, or coronary artery disease will be less. But you will never lose weight because of exercise. So at times, exercise may be a dampener for you. People will say कि डॉक्टर साहब आप तो कह रहे थे आधा घंटा एक्सरसाइज करो, मैं तो 1 घंटा करता हूँ और मेरा तो कुछ वेट कम नहीं हुआ. Exercise will never make you lose weight. Exercise will only make you metabolically fit. You will not have to go to Dr. Sani or Dr. Soni for treatment. If you have good blood pressure, normal blood pressure, coronary artery disease, or you don't have hypertension or CKD. So if you want to be healthy, do exercise. If you want to have no liver and insulin resistance, eat less. So at the end of the day, exercise and eat less is the mantra.
But then, sir, and she asked about the circadian rhythm. The time of eating, is that also important? And what about the dinner time? And then what? Dr. Jumani does not eat anything in the dinner. He avoids dinner altogether. So only soup. Yeah. So that is also important. And when should we eat dinner? That too is smaller portion, but then when?
Yeah. You see, there is something called circadian rhythm, which by scientific means is also called biological clock. Every single cell in the body has its own intrinsic inherent metabolic clock, which decides that at what particular time of the day and night it does not see the glistening light coming from these bulbs. It occurs from within at a particular given point of time that there is day or night outside. So the various digestive hormones, various digestive juices which are to be secreted, where various metabolic activities which are needed for digestion of fat, storage of the fat, oxidation of the fat are tuned in such a way that body needs a rest of about 16 hours, about 8 to 8 hours a day minimum to regenerate these processes. And even though people say that, oh, you take an early dinner and sleep at 6 a.m. Problem is, person like Dr. Sani who reaches in the clinic at 7 p.m. If you ask him to have a dinner at 7 p.m., I think his patient will murder him that you had called up at 5 p.m. and you are having your own dinner. So practically speaking, this is not possible, but the earlier the better, because if you stick to the circadian rhythm of the body, you will be better off. But for practical purpose, it's not easy to stick to those principles.
One way is to increase your window, decrease the eating window. So you have a dinner at 7 p.m. and have your breakfast at 10 a.m. or 11 a.m. So your eating window has to be less. So you eat food from 10 a.m. to 7 p.m. Okay. Don't eat like 10 to 10. So that eating window has to be less. And another thing is if a person does not have dinner, but he has not been calorie conscious during the day, anyway that is going to be neutralized. So be calorie conscious also, and then you skip the dinner, then the benefit will come, plus some exercise.
That is why the concept of TER has come, that time related eating, TRE. So
fact,
TRE is important.
This concept of so-called intermittent fasting has originated from the requirements of the body, in which you need to give rest to the circadian rhythm to regenerate its processes. But then in busy clinic and routine practice, it may not always be possible. So far as you are able to contain your total calories and have your step count of say about 10,000 steps a day, that is sufficient to maintain your weight. And 9 out of the 10 times, I think you will be able to do well.
Well, any other question? Yes, yes, sir.
I think I'm doubled up.
Yes, we can hear you.
Thank you for revising up. Hello? Yeah. Dr. Arora, thank you very much for clarifying physiology and pathophysiology. More about the keto diet, which I want to ask you very precise. It advocates a low carbohydrate and a moderate protein and high fat. You can eat I think what I have read from Jason Foger and all those people, that you can eat a kilo of fat, you can't grow fat on that. You will be munching as many calories, you can't get fat. Though difficult to sustain. Please clarify. Number 2 question, very precise. The new drugs that come for diabetes, GLP-1, something, Jaypee.
Yes.
I don't even know the full form.
Yes.
But I'm being given those drugs. Will they have an effect on reducing the heart disease and the chronic inflammation in the body? It has probably prolonged life. Only 2 questions.
Yeah, first question is regarding the keto diet. Keto diet, the basic concept was that you change the metabolic milieu from metabolism of glucose to metabolism of fat, which can serve equally good purpose for providing you energy. But problem is adherence to the keto diet and the risk of lot of fat is presenting as ketoacidosis in some given patient. So adherence, taste and sticking to that diet is something which is important, and various studies have shown that if you do intermittent fasting or you restrict total calories, keto diet may not be good. If you see all the diet, the best scientific evidence is with the Mediterranean diet, which is the best. The reason is Mediterranean diet gives you a lot of green leafy vegetables, salads, nuts and fish oil, and it restricts the carbohydrate. That is a precise thing. So ultimately if it boils down to restricting carbohydrate, that will give you an answer. Second, your second question of new upcoming drugs. I think it is a totally new tsunami of medicine which have come, and there is a sudden resurgence of the interest. These are called incretins. This is a new concept of GI hormones which tend to stabilize your metabolic milieu, try to take control of your diabetes as well as weight. Till now, as physicians, whatever your drugs you have been giving for treatment of diabetes have either been increasing the weight like insulin, sulfonylureas or metaglinides, or they have been, or pioglitazone, or they have been weight neutral like gliptins. Now this is the first wonder drug which is reducing weight and controlling diabetes. So these are called incretins, of which the classical examples have been semaglutide and a new combination called tirzepatide. Now these two drugs, in addition to increasing the insulin in response to the glucose and taking control of the diabetes, have pleiotropic effects. In fact, there have been, Dr. Sani can support me on that, there has been data to show that if you give semaglutide in patient who had history of coronary artery disease or major adverse cardiovascular events, there is a 30% reduction of cardiac events if you give semaglutide compared to other drugs like insulin or sulfonylurea. In one. Second is, there has been also a role in trying to have a neuroprotection in patients who are elderly and are likely to develop Alzheimer's disease or Parkinson's disease. They are also known to be protecting the kidneys by decreasing proteinuria, and in addition they are also useful in a subset of the patient in which you have a heart failure with a preserved ejection fraction. This new concept are coming into being, and these new drugs like Mounjaro from Eli Lilly or semaglutide from Novo Nordics, they are going to be the future of treatment, because these are the only drugs which control your diabetes and decrease weight. Your conventional drugs like insulin, pioglitazone and metformin will jack up the weight. That is the difference.
I think there's additional benefit on liver fibrosis also. So it improves fatty liver, and maybe some amount of fibrosis reversal also has been found.
Any other questions? Yes, Dr. Mohan, Dr. Ashutosh Mohan. Anything? Would you like? You are satisfied that you are not staying for the dinner then?
I have one suggestion.
Yes.
Should we cancel your today's dinner?
Only those with hardening hunger should stay on.
No, we would like everyone to stay for the dinner at the musical night, because after this exhaustive scientific session, 2 lectures are still left, and then you should relax and you should unwind yourself also, and you should enjoy the dinner as well as the musical evening. Well, yes, Dr. Kuturia has got one question.
So, like Medicon diet, you have said is beneficial for all kind of diseases. It's an anti-inflammatory diet. So, I think we should promote or make people aware of the Mediterranean diet. It have everything. If the patient wants to have alcohol, he can have red wine. If the patient wants to have non-veg, he can have like fish, chicken. So, like making people aware of the Mediterranean diet will be much beneficial than, like.
Actually, we in Gangaram Hospital for the first time in Asia have started a concept called fatty liver clinic. Fatty liver, as I said, is just a window to catch hold of a patient of plethora of problems with metabolic syndrome. Over there, we have been trying to look at the positive components of the Mediterranean diet and try to indigenize it by trying to have different type of North Indian Mediterranean diet, East Indian Mediterranean diet, South Indian Mediterranean diet and Western Indian Mediterranean diet. We are still in the process of giving benefits of Mediterranean diet, which primarily involves a lot of green leafy vegetables, less carbohydrates, less of poultry item and more of fish oil. These are the 4 components which we are trying to indigenize. Because if we just tell this patient to take red wine, so how the patient may run away. This is not a Western setup. This is the diet which has come from the Italian setup. We are using those useful components and trying to indigenize it.
Well, thank you very much for a very enlightening session, and of course I think that we should have taken some clue of how to eat, what to eat, how much to eat, and particularly when to eat. That is very, very important. Well, thank you very much. Please give a big hand to our speaker. And now I will request Dr. Hamidi to please, he is a senior surgeon of our hospital, to please honor the speaker as well as the chairpersons.
आइए आगे आइए यहाँ आइए सर, बीच में आओ, आप नजर आने चाहिए सर, आओ आप लोग आओ, हाँ अभी बाकी सब लोग बाकी सबको भी दो सर।
we are coming to a session which is related to endocrinology and gynecology. Well, the topic is gestational diabetes, GDM, the tricky situation to handle. Well, for this, the speaker has just landed here on this planet, Dr. Pankaj Agarwal. वहाँ पर अपनी वो slide sheet वहाँ दो. For this session, for the chairpersons, I would like to invite Dr. Shivani Chauhan, if she is here. Dr. Shivani Chauhan. Okay. Dr. Shivani Kushwaha, she is there. Okay. She has to come for chairing this session. Dr. Farah will come to chair this session. Dr. Prahlad Chawla from Ghaziabad, he will be also chairing this session. So this session is related to gestational diabetes, a tricky situation to handle. I am not allowing Dr. Pankaj Agarwal to plead to take even a gulp of water or even to take a breath. But he will right away start his talk, and the session, of course, I hand over to chairpersons to introduce the speaker, Prahlad. Yes.
Thank you, Dr. Soni, for inviting us for this wonderful conference. I am enjoying since beginning. It's a wonderful way of presenting any activity like this. So, Dr. Pankaj Agarwal is from Ghaziabad. He is running hormone care and endocrine centers at Ghaziabad. He has many things to his credits, but the important thing, he is founder of MCH, Medical Concept in Hindi. So most likely we will start session in Hindi also. So in many talks, you always talk in Hindi. So we'll welcome you.
धन्यवाद डॉक्टर प्रहलाद और धन्यवाद डॉक्टर सोनी यथार्थ हॉस्पिटल इस सम्मान के लिए कि मुझे यहाँ बुलाया आपने और इस बेहतरीन गैदरिंग में आप सबके समक्ष अभी कुछ विचार अपने रखेंगे जेस्टेशनल डायबिटीज़ के विषय में। मित्रों, ये मेडिकल कॉन्सेप्ट्स इन हिंदी यह एक ज्ञान यज्ञ है जिसमें आज हमारे साथ आप लोग भी अपनी अपनी आहुति देंगे कि किस प्रकार से हम अपनी मेडिकल एजुकेशन को हम सरल और सहज भाषा में एक दूसरे से इसकी चर्चा कर सकें और इसको साझा कर सकें। ये हमारी कुछ पुस्तकें हैं जिनको एपिकॉन के नेशनल मंचों पे स्थान मिला और ये हमारे सर्टिफिकेट कोर्सेज हैं जो हम लोग इसके अंतर्गत करते हैं, जो कि इंडियन कॉलेज ऑफ फिजिशियन से और इंद्रशील यूनिवर्सिटी गुजरात के साथ में एसोसिएटेड हैं। इच्छुक लोग हमारी पुस्तकें यहाँ उपलब्ध रहेंगी और जो इसमें कोर्सेज को ज्वाइन करना चाहें वो ज्वाइन कर सकते हैं। जेस्टेशनल डायबिटीज़ के टॉपिक को हमने आप लोगों से बिना पूछे थोड़ा सा परिवर्तित कर दिया, डायबिटीज़ इन प्रेगनेंसी। और इसमें हम कोई भी वो बात नहीं करेंगे जो अमूमन हम लोग चर्चाओं में करते रहते हैं। जो मिसिंग पॉइंट हैं हम उनको डिस्कस कर लेना चाहेंगे क्योंकि समय कम है, जो हमारी क्लिनिक में हमारे काम आने हैं, जो हमारी कंसेप्ट बिल्डिंग में मदद करने हैं। अच्छा, मोनोलॉग नहीं है, डायलॉग है। यह कुछ समस्याएं हैं जो हम आपसे साझा कर रहे हैं। बड़ी सिंपल सी चीज़ है, 6 वीक्स जेस्टेशन में और OGTT कराने पे 190 ब्लड ग्लूकोज आती है। डायग्नोसिस? यस, डायग्नोसिस? डायग्नोसिस? यार कोई बोल ही नहीं रहा तो फिर मेरा समय इसी में चला जाएगा। जी सर। या डायबिटीज़ या जेस्टेशन डायबिटीज़, देखिए यही चीज़ जब 26 वीक्स प्रेगनेंसी में हो और यही चीज़ जो मेरा प्रश्न था 6 वीक्स प्रेगनेंसी में हो, क्या इन दोनों में कोई अंतर है? और यह अंतर हमको समझना है। कभी कभी जो हम ऊपर लेबल कर देते हैं वो लेवल हमारे साथ चलता रहता है और बिना उसकी गंभीरता की विवेचना किए हुए। इन दोनों में अंतर है, इनकी डायग्नोसिस में भी अंतर है, इनके मैनेजमेंट में भी अंतर है और इनके कॉन्सिक्वेंसेस, इनकी क्लिनिकल सिग्निफिकेंस में भी अंतर है। जो फर्स्ट ट्राइमेस्टर में मालूम हो रहा है वह काफ़ी संभावना है कि प्री एग्जिस्टिंग डायबिटीज़ हो, चाहे वह महिला को मालूम हो चाहे ना हो, चाहे पहली बार अभी मालूम पड़ी हो, प्री एग्जिस्टिंग डायबिटीज़ होने की संभावना ज़्यादा है, क्योंकि जेस्टेशनल डायबिटीज़ मुख्य रूप से प्रेगनेंसी के लेटर हाफ में 5-6 मंथ्स के आसपास प्रकट होती है, क्योंकि उस वक्त जो हमारे प्रेगनेंसी रिलेटेड हार्मोन्स होते हैं वो ऑल हार्मोन्स इन द बॉडी आर एंटी इंसुलिन इन नेचर। एक बड़ी सीधी सी बात है। तो जैसे जैसे प्लेसेंटल हार्मोन्स बढ़ते हैं वो जीडीएम कराते हैं, लेकिन अगर फर्स्ट ट्राइमेस्टर में हो रही है तो वह जीडीएम नहीं है, उसमें काफ़ी संभावना है कि प्री एग्जिस्टिंग डायबिटीज़ हो। और उसमें बहुत इंपॉर्टेंट है दोनों के कॉन्सिक्वेंसेस। प्री एग्जिस्टिंग डायबिटीज़ जो है वह कंजेनाइटल एनोमली कर सकती है, जबकि जो सेकंड थर्ड ट्राइमेस्टर में होने में वाली डायबिटीज़ है वो कंजेनाइटल एनोमली नहीं करती, उसके उतने ग्रेव कॉन्सिक्वेंसेस नहीं है, वह मैक्रोसोमिया करती है मेजरली, और वो मैक्रोसोमिया के साथ में मेटाबॉलिक कॉम्प्लिकेशन करती है। जुवानी साहब को बहुत बहुत धन्यवाद, आपने आज मेरी रक्षा की। क्योंकि आप सेशन चलाते रहे तो मैं कम से कम यहाँ तक आने का मुझे समय मिल गया। आज बेहद रश था, बेहद, हर चौराहे पे हर लाइट पे 3 से 4 गुना समय लगा है। तो वास्तव में इन दोनों कंडीशंस के बीच में बहुत अंतर है, फर्स्ट ट्राइमेस्टर में होने वाली प्रॉब्लम और सेकेंड थर्ड ट्राइमेस्टर में होने वाली प्रॉब्लम। वास्तव में जो फर्स्ट ट्राइमेस्टर में हो रही प्री एग्जिस्टिंग डायबिटीज़ वह ज़्यादा सीवियर है, उसके लिए हमें ज़्यादा पोटेंट मेडिसिन की आवश्यकता है, उसके लिए हमें ज़्यादा इंसुलिन की आवश्यकता है, उसके साथ कोमॉर्बिडिटीज़ ज़्यादा जुड़ी होती हैं, उसके साथ में कॉम्प्लिकेशन रेट ज़्यादा होते हैं। और इस कारण से अगर हमको इन दोनों के बीच में डिफ्रेंशिएट करना है तो पेशेंट के फर्स्ट प्रेजेंटेशन पे ही, फर्स्ट ट्राइमेस्टर में ही जब हम HbA1c कराते हैं तब हम ये चीज़ देख पाते हैं कि वो HbA1c अगर फर्स्ट ट्राइमेस्टर में हाई है, इसका मतलब प्री जेस्टेशनल डायबिटीज़ है, जो कि ज़्यादा सीरियस कंडीशन है बनिस्बत की सेकेंड ट्राइमेस्टर में होने वाली यह जेस्टेशनल डायबिटीज़ के। तो मैनेजमेंट में अंतर क्या है दोनों के? मैनेजमेंट में अंतर यह है कि जीडीएम एक माइल्डर प्रॉब्लम है, काफ़ी केसेस में वो केवल लाइफस्टाइल मॉडिफिकेशन से ठीक हो सकती है। यदि इससे काम न चला तो उसे थोड़े मेडिसिनल सपोर्ट की ज़रूरत है। उनमें से काफ़ी पेशेंट्स मेटफॉर्मिन से ठीक हो जाते हैं और कुछ को आवश्यकता पड़ती है। 2 मेडिसिन और हैं जो हम क्लासिकली प्रेगनेंसी में अप्रूव्ड, और जो मेडिसिन है वो है इंसुलिन। 2 ओरल हाइपोग्लाइसेमिक एजेंट्स हम यूज़ कर सकते हैं, मेटफॉर्मिन और ग्लिमिनक्लामाइड। ग्लिमिनक्लामाइड को विषय में मैं आपसे कहूँगा कि इसे मन से निकाल दीजिए, क्योंकि यह एक केवल जुगाड़ है। मेटफॉर्मिन और इंसुलिन 2 को याद रखिए। अगर प्री एग्जिस्टिंग डायबिटीज़ है तो 2 संभावनाएं हैं, महिला को पहले से ज्ञात हो कि उसे डायबिटीज़ थी या नहीं थी, अगर वो थी तो वो उसके लिए दवाएं ले रही होगी, जैसे ही वो आपके पास आएगी हम पुरानी मेडिसिन को बंद करेंगे। जब पेशेंट की मेडिसिन बंद करेंगे तो डायबिटीज़ और फ्लेयर अप होगी, उसे बहुत अच्छी खासी डोजेज ऑफ इंसुलिन की आवश्यकता पड़ेगी। तो ऐसे केसेस में हमें सीवियर हाइपरग्लाइसीमिया होगा, हमें अधिक पोटेंट मेडिसिन विशेष रूप से इंसुलिन की आवश्यकता पड़ेगी। केवल लाइफ स्टाइल मॉडिफिकेशन से और केवल मेटफॉर्मिन से अधिकांश केसेस का काम नहीं चलेगा। स्क्रीनिंग अगर हमें करनी हो, पहले से ना मालूम हो, तो हम कैसे करते हैं? बहुत सारे क्राइटेरियाज हैं। केवल एक की बात करें, भारत में भारतीय क्राइटेरिया की, जो डिप्सी ने कहा है, जैसे हम नॉन प्रेग्नेंट मेल फीमेल में करते हैं 75 ग्राम ग्लूकोज देने के 2 घंटे बाद। बस सारे कन्फ्यूजन्स हटाएं। अब हमारे सामने 4 महिलाएं हैं, अब इनका आंसर मुझे आपसे चाहिए। 1, 2, 3, 4, इनमें 4 महिलाओं को जब 75 ग्राम ग्लूकोज देने के बाद टेस्ट किया गया तो ये वैल्यूज आई। फर्स्ट की डायग्नोसिस, क्लियर कट डायबिटीज। ओके, सेकंड की, अगर ये प्रेग्नेंट ना होते तो हम कह देते फर्स्ट को डायबिटीज, सेकंड को इम्पेयर्ड ग्लूकोज टॉलरेंस, थर्ड को नॉर्मल, फोर्थ को नॉर्मल। अब ये प्रेग्नेंट फीमेल है तो फर्स्ट इज ओवर डायबिटीज, ओके, सेकंड, ओके, सोचते हैं, थर्ड नॉर्मल, फोर्थ, अगर थर्ड और फोर्थ दोनों नॉर्मल है तो मैंने क्यों रखे, दोनों को एक ही रखता है, इसका मतलब कुछ पेंच है। तो वो पेंच है कि जो इम्पेयर्ड ग्लूकोज टॉलरेंस, जैसे हम लोग नॉन प्रेग्नेंट स्टेट्स में कहते हैं, वो थर्ड और फोर्थ में डिफरेंस है। फर्स्ट इज डायबिटीज, सेकेंड इज जीडीएम। अगर 140 को क्रॉस कर रहा है आफ्टर 75 ग्राम ऑफ ग्लूकोज, वह जीडीएम हुआ, पहली बार मालूम पड़ रही है। थर्ड, अगर वो 140 से कम है लेकिन 120 से ज़्यादा है, जैसे हम नॉन प्रेग्नेंट पर्सन्स में हम लेते हैं 140-200 और 140-200 के बीच में इम्पेयर्ड ग्लूकोज टॉलरेंस, वैसे ही प्रेगनेंसी में लेते हैं 120 और 140 के बीच में। 120 भी एबनॉर्मल है, तो 120-130 के बीच में जो वैल्यू है वह इम्पेयर्ड ग्लूकोज टॉलरेंस के इक्विवेलेंट है, जिसको हम कैसे कहते हैं यहाँ पे जेस्टेशनल ग्लूकोज इंटॉलरेंस, और जो 120 से कम है वो फ्रैंक नॉर्मल। तो वास्तव में प्रेगनेंसी वो कंडीशन है जहाँ थोड़ा सा हाइपरग्लाइसीमिया भी बहुत ज़्यादा सीरियस होता है, और ये हमने सीखा हापो स्टडी से। हाइपरग्लाइसीमिया एंड एडवर्स प्रेगनेंसी आउटकम, देखा गया कि जैसे जैसे ग्लूकोज नॉर्मल रेंज में भी बढ़ता जा रहा है, प्रेगनेंसी के आउटकम खराब होते जाते हैं। तो इसलिए माइनर डिग्री ऑफ हाइपरग्लाइसीमिया जो हमको अदरवाइज नॉर्मल लगता है, यहाँ पर वह भी गड़बड़ है, उसको भी हमें सीरियसली लेना है। इसलिए मॉनिटरिंग बहुत आवश्यक है, स्क्रीनिंग बहुत आवश्यक है। प्रत्येक महिला को प्रेगनेंसी में जब भी हमारे पास पहली बार आ रही है, हमें स्क्रीन करना है, चाहे आपके पास किसी भी पर्पज से आ रही हो। आप फिजिशियन हैं, आपको करना है, आप गायनी हैं, आपको तो करना ही करना है, आप सर्जन हैं, आप ऑर्थोपेडिशियन हैं, अगर कर सकें बहुत अच्छा है। जब मालूम पड़ गया तो मॉनिटरिंग करनी है। मॉनिटरिंग बहुत आवश्यक है क्योंकि यहाँ प्रतिदिन स्थिति बदल रही है। हम ब्लड ग्लूकोज से करें या CGMS से करें तब भी कर सकते हैं। हमारे टारगेट्स क्या हैं? टारगेट्स बहुत टाइट हैं, जो हमको थोड़ा सा बढ़ा हुआ लगता है, जिसको कि हम लोग अक्सर कहते हैं नहीं थोड़ा सा बढ़ा चलेगा ना, प्रेगनेंसी में नहीं चलेगा। प्रेगनेंसी में हमें टारगेट्स बहुत टाइट रखने हैं। फास्टिंग 95 से कम, 1 घंटे के बाद 140 से कम, और 2 घंटे के बाद 120 से कम। प्रेगनेंसी वो स्टेट है जहाँ पे 1 आवर पोस्ट प्रैंडियल भी जरूरी है। क्यों? कोई बता सकता है? 1 आवर पोस्ट प्रैंडियल प्रेगनेंसी में क्यों जरूरी है? क्योंकि यह मैक्सिमम हाइपरग्लाइसीमिक स्टेट है जो मैक्रोसोमिया उत्पन्न करती है। तो मैक्रोसोमिया से बचाने के लिए हमें माइनर डिग्री ऑफ हाइपरग्लाइसीमिया को भी नियंत्रण में रखना है। लाइफ स्टाइल मॉडिफिकेशन में 2-3 बातें बहुत ध्यान रखनी है, मैं बहुत ही रैपिडली इसको चलूँगा। कि जैसे ही प्रेगनेंसी होती है वैसे ही जो फीटस है वो फीटस कॉन्टीन्यूसली फीडिंग बॉर्डर है मदर के लिए, लगातार ग्लूकोज ले रहा है। इसके कारण से जब लेडी जरा भी लंबे समय तक खाली पेट रहती है, उसकी ग्लूकोज लेवल नीचे आने लग जाता है। तो फास्टिंग ग्लूकोज क्लासिकली प्रेग्नेंट फीमेल में कम होता है। पहले अगर डायबिटिक थी, पहले उसका 140 रहता था, तो प्रेगनेंसी होते ही वो 130-120 जाने लग जाएगा। लेकिन पोस्ट प्रैंडियल प्लेसेंटल हार्मोन्स के कारण से बढ़ता है। तो यह 2 फैक्टर्स हमें ध्यान रखने हैं कि हमें प्रेग्नेंट फीमेल को ज़्यादा देर तक खाली पेट नहीं रखना है। स्मॉल फ्रीक्वेंट मील्स इज द नोशन ड्यूरिंग डायबिटीज़, थोड़ा थोड़ा बार बार, जिसमें प्रोटीन, विटामिन, मिनरल, फाइबर इनकी मात्रा अच्छी हो, फैट इन पर्टिकुलर, और कार्बोहाइड्रेट्स में कॉम्प्लेक्स कार्बोहाइड्रेट खूब हो, रिफाइंड शुगर हमें अवॉइड करनी है, और फिजिकल एक्टिविटी। और यहाँ हम विशेष रूप से हम एल्डरलीज में हम कहते हैं खाने के बाद मत टहलिए। प्रेगनेंसी में हम कहते हैं खाने के बाद टहलिए, क्योंकि जब भोजन के बाद प्रेग्नेंट फीमेल टहलती है तो वह ग्लूकोज को कम कर रखने में, पोस्ट प्रैंडियल स्पाइक को कम करने में मदद करता है। स्ट्रेन्यूअस एक्टिविटी नहीं करनी, लेकिन टहलना हमारे लिए लाभदायक है। अब लाइफ स्टाइल मॉडिफिकेशन पे एक फीमेल चल रही है, उसको हम मेडिसिन कब स्टार्ट करें? जब हम देखें कि हमारी 2 वैल्यूज़ इसको क्रॉस करने लग जाए। हम कई दिनों का चार्ट बना रहे हैं तो 1/3 वैल्यू अगर हमारी इन टारगेट ना हो, प्लीज़ उसको फार्माकोथेरेपी स्टार्ट करने के लिए प्रयत्न कीजिए, उसको टालिए मत कि प्रेगनेंसी है, ये नॉर्मल स्टेट नहीं है। तो हमको एंटी डायबिटिक एजेंट्स ये 3 हैं जो हम लोगों ने बात की, और इन 3 के विषय में हमें एक महत्वपूर्ण चीज़ जाननी है। इंसुलिन क्यों अप्रूव्ड है प्रेगनेंसी में? क्योंकि इंसुलिन प्लेसेंटा क्रॉस नहीं कर पाती। वो प्लेसेंटा जैसे ही क्रॉस करना चाहती है, प्लेसेंटा में जो इंसुलिनेज एंजाइम है वह उसको डिस्ट्रॉय करने लग जाता है। तो फीटस इज प्रोटेक्टेड फ्रॉम मैटरनल इंसुलिन, वरना जाके फीटल हाइपोग्लाइसीमिया करा सकती थी। ग्लिबिनक्रामाइड अलाउ की गई प्रेगनेंसी में, क्यों की गई? क्योंकि वह प्लेसेंटा क्रॉस नहीं कर पाती, केवल 3% उसका प्लेसेंटल पैसेज है। अच्छा, मेटफॉर्मिन के साथ बहुत लफड़ा है। मेटफॉर्मिन के ऊपर खूब चर्चा गायनी फोरम में होती है कि दे सकते हैं, नहीं दे सकते, कब दे सकते, कितना देना है। वह प्लेसेंटा क्रॉस करती है, और इसके साथ एक बड़ी महत्वपूर्ण बात है, वो प्लेसेंटा क्रॉस करती है। मेटफॉर्मिन हमारी बॉडी में मेटाबोलाइज नहीं होती, तो जो भी मेटफॉर्मिन ले रहा है वो विदाउट मेटाबॉलिज्म वह एज इट इज यूरिन में एक्सक्रीट होती है। तो जब वो प्लेसेंटा क्रॉस करके फीटस में पहुंची, फीटस के सर्कुलेशन में पहुंची, उसकी यूरिन से भी वो एक्सक्रीट हुई अनचेंज्ड, एमनियोटिक फ्लूइड में गई, एमनियोटिक फ्लूइड में मेटफॉर्मिन कलेक्ट हो गई, उसको बच्चे ने एंगल्फ किया और वो इस तरह से रीसर्कुलेट करती रहती है। तो देयर बाई इट कंसंट्रेट्स इन फीटल सर्कुलेशन। तो मेटफॉर्मिन, अब देखिए, अब ये वाली बातें शक उत्पन्न कर रही हैं कि मेटफॉर्मिन प्लेसेंटा क्रॉस कर रही है, फीटस तक पहुंच रही है, और फीटस में कंसंट्रेट हो रही, मैटरनल सर्कुलेशन से ज़्यादा उसकी कंसंट्रेशन है फीटस में। कहीं कुछ गड़बड़ तो नहीं, कहीं कुछ उत्पाद तो नहीं मचाएगी? तो अब हमें ये देखना है कि मेटफॉर्मिन के इफेक्ट फीटस पे क्या होते हैं। मैं इंसुलिन को अवॉइड करना चाहूँगा, चलेगा? ओके, क्योंकि वो बात फिर निकलेगी तो बहुत दूर तक जाएगी। एक कंट्रोवर्शियल टॉपिक मेटफॉर्मिन का ही ले लेते हैं। मेटफॉर्मिन जब फीटस में जाएगी तो उसके ऊपर ये हुआ कि कहीं कुछ गड़बड़ तो नहीं करेगी। तो सबसे पहला ट्रायल जो कि पाथ ब्रेकिंग ट्रायल था, मेटफॉर्मिन इन जेस्टेशनल डायबिटीज़, जीडीएम के पेशेंट्स में, माइल्डर डिग्री वाले डायबिटीज़ के पेशेंट में जिनको 2nd और 3rd ट्राइमेस्टर में डायबिटीज़ हो रही, उनमें जब मेटफॉर्मिन दी गई तो देखा गया मदर को नुकसान तो नहीं करती, फीटस को भी नुकसान नहीं करती, बल्कि कई आउटकम्स अच्छे देखे गए। तो कहा गया शायद मेटफॉर्मिन दी जा सकती है, ज़्यादा प्रेगनेंसी आउटकम भी ख़राब नहीं हुआ, फीटस पे भी कोई उसका इफेक्ट नहीं मिला। तो जब हमने इंसुलिन ग्रुप और मेटफॉर्मिन ग्रुप को कंपेयर किया तो सिमिलर से मिले, तो थोड़ा दिल को ठंडक पहुंची कि ओके, मेटफॉर्मिन इज नॉट सो बैड। अच्छा देखिए कितनी गलत बात है, पीसीओडी में आप मेटफॉर्मिन देते हैं, ठीक है, जब वो कंसीव करती लेडी तो क्या कहते हैं? बंद कर दो। आप कहते हैं उसको लेते रहो। कब तक लेते रहो? फर्स्ट ट्राइमेस्टर जरूर लो। फर्स्ट ट्राइमेस्टर लोगे तो मिसकैरेज की रेट कम हो जाएगी। क्या मतलब हुआ इसका? पीसीओएस का फीमेल जो है, क्या उसको डायबिटीज़ है? उसको डायबिटीज़ नहीं है। तो एक नॉन डायबिटिक फीमेल को एक डायबिटिक ड्रग, एंटी डायबिटिक ड्रग आप कह रहे हैं लेनी चाहिए, ओव्यूलेशन बढ़ाती है, कंसेप्शन बढ़ाती है, और प्रेगनेंसी होने के बाद लाइव फीटस, लाइव बर्थ के चांसेस बढ़ाती है, मिसकैरेज कम करती है। लेकिन डायबिटीज़ हो गई, नो 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 नो, प्रेगनेंसी में मेटफॉर्मिन इज नॉट अलाउड, इट कांट बी गिवन। यार कैसी बातें करते हैं हम लोग। क्यों करनी पड़ती हैं? क्योंकि वो नियम कानून नहीं है, अभी तक उस पर कोई ट्रायल नहीं हुआ था, हमारे पास कोई ऑथेंटिक रिपोर्ट्स नहीं थी, इसलिए वो कानून नहीं बना। लेकिन कॉमन सेंस तो लगाएं भाई, अगर पीसीओडी में वो टेरेटोजेनिसिटी नहीं कर रही तो डायबिटीज़ में कैसे करेगी? खैर, मिग ट्रायल में ये देखा हमने कि इट इज़ इक्वलेंट टू, रिजल्ट्स आर इक्वलेंट टू डायबिटीज़। चलिए अब दूसरी स्टडी देखते हैं। माइटी ट्रायल में क्या हुआ? मेटफॉर्मिन इन टाइप 2 डायबिटिक्स, वो डायबिटिक्स जिनको प्रेगनेंसी से पहले से डायबिटीज़ थी, वो फीमेल्स में जब हमने मेटफॉर्मिन दी तब हमें क्या मिला? बड़े अच्छे रिजल्ट्स ऑलमोस्ट इक्वल। जो प्रेगनेंसी में इंसुलिन देने पे मिल रहा है वही चीज़ हमको मेटफॉर्मिन देने में मिल रही है। यहाँ एक चीज़ देखने को मिली कि बच्चे का फीटस का वेट थोड़ा कम था। फीटस का वेट दूसरे जिनको इंसुलिन दी गई उनसे कम था। ये शायद मैंने कुछ गलत लिख दिया, लेसर वेट 20 ग्राम्स, 20 ग्राम्स का वजन नहीं, ठीक है, सॉरी 200 ग्राम्स उनका वेट कम मिला इन कंपैरिजन टू फीमेल्स जिनको इंसुलिन दी गई। तो टेरिटोजेंसिटी है नहीं, ऑर्गेनोजेनेसिस में इंटरफेयर कर नहीं रही। प्रॉब्लम कहाँ पे आएगी? प्रॉब्लम एक ही आई, मैक्रोसोमिया नहीं होने देती। मेटफॉर्मिन देने पे मैक्रोसोमिया के चांस कम होते हैं, लेकिन कुछ बच्चे माइक्रोसोमिक हो सकते हैं। थोड़ा सा वेट जो हमने देखा भी 200 ग्राम्स कम हो सकता है। तो कहीं ये डिलीटीरियस तो नहीं, बाकी पैरामीटर्स तो सारे अच्छे हैं। अब धीरे धीरे जब देखा गया कि काफ़ी चल सकते हैं और काफ़ी बच्चों में और कोई बाकी इफेक्ट्स नहीं आते, तो एक जोश बढ़ता गया। और कभी कभी हम लोग जोश में, अति उत्साह में हम कुछ ऐसे राय देने लग जाते हैं कि चलो नॉन डायबिटिक फीमेल में भी देते हैं। एक ओबीस फीमेल है और उसने कंसीव किया, कंसीव करने के बाद हम जानते हैं 12-13 किलो और बढ़ेगा, इसमें वेट गेन रोकने के लिए हम मेटफॉर्मिन देते हैं। चलो भैया, और जोश में हमने कुछ स्टडीज़ भी कर डाली। नॉन डायबिटिक ओबीस फीमेल में जब ये मेटफॉर्मिन दी गई तो थोड़ा सा ज़्यादा तो कर दिया, लेकिन हमने रिजल्ट क्या देखा कि मैटरनल वेट गेन कम रखती है, मैक्रोसोमिया के चांसेस कम रखती है, लेकिन आउटकम इम्प्रूव नहीं करती। ऐसा नहीं कि नॉन डायबिटिक फीमेल को मेटफॉर्मिन देके हम आउटकम अच्छे करा दें। तो कुछ पैरामीटर्स ठीक हो सकते हैं, आउटकम अच्छे नहीं थे। लेकिन अब दूसरा क्वेश्चन आया, बच्चे का क्या हुआ? जो हम देख रहे हैं कि मेटफॉर्मिन जा रही है और फीटस में कंसंट्रेट कर रही है, कहीं उसमें कोई साइड इफेक्ट नहीं? तो मिग स्टडी के जो बच्चे मेटफॉर्मिन जिनको जेस्टेशन डायबिटीज़ में दी गई थी, उन मदर्स के बच्चों को जब फॉलो किया गया तो देखा उनका सबकोटिनियस फैट कुछ कम है। तो बच्चे थोड़ा माइक्रोसोमिक भी थे, 200 ग्राम वजन कम था और बॉडी फैट भी उनमें कम मिला एट 2 ईयर्स। तो लगा यार ये तो अच्छा है, बच्चा भी हमारा आगे चल के थोड़ा शरीफ बना रहेगा, मोटा कम होगा। अब टाइप 2 डायबिटीज़ वाली जो स्टडी थी माइटी, उनके बच्चों को भी टेस्ट किया गया 2 साल पे, तो उनमें भी देखा गया कि एंथ्रोपोमेट्री करीब करीब ठीक थी, कोई दिक्कत नहीं थी। तो एक एश्योरेंस मिली कि जो ऑफ स्प्रिंग हैं उन मदर्स के जिन्होंने मेटफॉर्मिन ली है, तो मैं 2 साल तक कोई गड़बड़ नहीं आया। लेकिन फिर दिमाग में कीड़ा कुलबुलाया, आगे तो नहीं आएगा। अब जैसे जैसे समय बीतता गया, 7 to 9 ईयर्स ऑफ फॉलोअप हमारे मिग ट्रायल का हुआ। अब देखा गया इसमें कि जब बच्चे बड़े होते हैं, तो जब पैदा हुए तो 200 ग्राम वजन कम था, 2 साल तक उन्होंने मेंटेन किया। लेकिन 7-9 ईयर्स तक जिन बच्चों ने मेटफॉर्मिन नहीं ली थी, जिनकी मदर ने, और जिनकी मदर ने मेटफॉर्मिन ली थी, उनमें देखा गया कि बच्चों का वजन थोड़ा सा ज़्यादा है, तो शायद वो कैचअप ग्रोथ वाली टेंडेंसी आने लगी। तो 9 ईयर्स में ऐसे बच्चों में ये कैचअप ग्रोथ देखने को मिली, वो बच्चे थोड़ा ओवरवेट मिले। तो ये अब हमारे दिमाग में एक शंका है, जो अभी तक हमारा सबसे बड़ा लॉन्ग टर्म फॉलोअप है 5 to 10 ईयर्स में। इसमें देखा थोड़ा इन बच्चों का BMI वेस्ट हिप रेशियो और ओबेसिटी थोड़ी ज़्यादा है। तो हो सकता है लॉन्ग टर्म में, ये स्टडी चल रही है अभी, और इसमें देखा जाएगा 20 ईयर्स तक क्या होता है उन बच्चों का। लेकिन शायद मदर के लिए अच्छे थे, प्रेगनेंसी आउटकम के लिए अच्छे थे, मैक्रोसोमिया रोकने के लिए अच्छे थे, 2-3 साल तक के बच्चे के लिए अच्छे थे। लेकिन हो सकता है आगे चल के ये बच्चों में ओबेसिटी की टेंडेंसी बढ़ाए। तो ये तो थी आज तक की कथा कहानी मेटफॉर्मिन के प्रयोग के बारे में। अब फिर लौट के हम वहीं आ गए, यार देनी है कि नहीं देनी है, ये बताओ, मतलब की बात करो कि हम लिखें, लिखने पे हम सेफ हैं कि नहीं है। तो एडीए क्या कहती है कि इंसुलिन मोस्ट प्रेफर्ड मेडिसिन है, बट मेटफॉर्मिन कैन बी गिवन, कैन ये दी जा सकती है इंसुलिन के साथ भी और इंसुलिन के बिना भी। हाँ, ये जरूर याद रखना है कि 30 to 40% फेल्योर रेट है, कुछ स्टडीज़ में 46% तक भी कि मेटफॉर्मिन alone cannot control hyperglycemia during pregnancy and in up to 46% of cases additional insulin therapy may be required. अब आते हैं ऑब्स्टेट्रिशियंस ने कहा यार तुम लोगों की डायबिटीज़ वाली जो एसोसिएशन से अच्छी नहीं है, हमारी एसोसिएशन की बात बताओ, हम तो इसी में फंसेंगे। तो ACOG भी यही कहती है कि इट इज़ रीजनेबल एंड सेफ फर्स्ट लाइन फार्माकोलॉजिकल थेरेपी, फर्स्ट लाइन है ऑल्टरनेटिव टू इंसुलिन। लेकिन 2-3 बातों का ध्यान रखना है। ध्यान क्या रखना है कि पहली चीज़ इंसुलिन से सुपीरियर नहीं है, प्लेसेंटा को ट्रांसफर करती है तो फीटस में इफेक्ट डाल सकती है और फेल्योर रेट है। ये सब बातें आप बताइए, फीमेल को समझाइए, उसके बाद दीजिए। डिप्सी क्या कहती है जी? बस 1-2 स्लाइड की मोहलत मिलेगी। धन्यवाद। वाह, हौसला अफजाई के लिए और समय देने के लिए शुक्रिया। वैसे डॉक्टर सोनी अपनी इस जर्रानाबाजी के लिए मशहूर हैं। तो डिप्सी ने क्या कहा कि हम इसको दे सकते हैं जब इंसुलिन लेने को तैयार ना हो या इंसुलिन लेना संभव ना हो, और 12 वीक के बाद भी, ये बड़ा एश्योरिंग था कि 12 वीक के बाद भी हम इसे दे सकते हैं पेशेंट को समझाने के साथ। और अंत में भाई जिससे सबसे ज़्यादा डर लगता है हमारी गवर्नमेंट, कोल्ड का तो कुछ आना नहीं है रिकमेंडेशन, गवर्नमेंट हमारी क्या कहती है? तो मेटफॉर्मिन इज रिकमेंडेड फॉर यूज बियॉन्ड 20 वीक्स ऑफ प्रेगनेंसी। तो ये हमारी भारतीय सरकार का स्टेटमेंट है, मेटफॉर्मिन इज रिकमेंडेड नंबर 1, क्योंकि इसके पीछे काफ़ी सपोर्टिव डॉक्यूमेंट हैं, विशेष रूप से ओबीज इंडिविजुअल के लिए, ओबीज फीमेल के लिए, या वह फीमेल्स जिनको इंसुलिन की काफ़ी हाई डोजेस चल रही हैं, जिसके अपने कॉन्सिक्वेंसेस हैं। और यह बहुत सरल है, आसान है, इकोनॉमिकल है और सुरक्षित व्यवहारिक तरीका है। लेकिन फिर वही बात आ गई कि कुछ केसेस ऐसे हैं जिसमें ये अकेले काम नहीं कर पाती, तो हमें साथ में इंसुलिन लेना होगा। अब ये वाली जो स्लाइड है इसको 4-5 पॉइंट जरूर याद रखिए, क्योंकि यहाँ पे एक कैविएट लगा दिया गया कि यहाँ मेटफॉर्मिन सोच समझ के दें। कहाँ अगर कोई ऑर्गन डिस्फंक्शन है, अगर हेपेटो, रीनल, कार्डियो, रेस्पिरेटरी कुछ प्रॉब्लम है, तो मेटफॉर्मिन सोच समझ के दीजिए। हाइपरटेंसिव डिसऑर्डर, विशेष रूप से अगर लेडी प्रीक्लेम्शिया या क्लेम्शिया में जा रही है, तब चांसेस हमारे ऑक्सीडेटिव स्ट्रेस के, IUGR के ज़्यादा होते हैं, वहाँ नहीं देना। तो अगर लेडी को हाइपरटेंशन, प्रीक्लेम्सिया, एक्लेम्सिया है, IUGR की संभावना के कारण नहीं देना, वहाँ पे प्री टर्म डिलीवरी की भी संभावना हो सकती है, इस बात का ध्यान रखिए। तो एक बहुत रीअश्योरिंग है, ये हमारा अभी लेटेस्ट 2024 में गवर्नमेंट ऑफ इंडिया की तरफ से, मिनिस्ट्री की तरफ से ये गाइडलाइंस है कि मेटफॉर्मिन सुरक्षित है, दी जा सकती है, कहाँ नहीं देनी वह हम ध्यान रखें। और ये बहुत अच्छा ऑल्टरनेटिव है इंसुलिन का, माइल्डर केसेस के लिए, GDM केसेस के लिए। अगर टाइप 2 डायबिटीज़ के साथ प्री एग्जिस्टिंग प्रेगनेंसी है तो इंसुलिन की डोजेस को कम रखने के लिए और मैक्रोसोमिया को प्रिवेंट करने के लिए। फर्स्ट ट्राइमेस्टर में ये टेरोटोजेनिक नहीं होती, बल्कि लाइव बर्थ की संभावना बढ़ाने में मदद करती है, और उसके बाद भी यह सुरक्षित है और दी जा सकती है। मुझे लगा यह एक कंट्रोवर्शियल पार्ट है जिस पर मुझे ज़्यादा ध्यान देना चाहिए, बजाय कि हम वही बातें जो अक्सर होती हैं उनको रिपीट करते रहें। डिस्कशन के दौरान अगर आप लोग उसको रखना चाहेंगे तो मुझे प्रसन्नता होगी, ये कर सकते हैं। ये हमारी कुछ पुस्तकें हैं जो यहाँ उपलब्ध हैं, अगर कोई लोग चाहें इसको। प्रैक्टिकल बातें हैं, क्लिनिकल बातें हैं, सरल है पढ़ने में, समझने में, और क्लिनिकल केसेस के माध्यम से जो हमें करना चाहिए वो वही बात की है, और थ्योरेटिकल डिटेल्स इनमें हमने कुछ नहीं रखी है जी।
धन्यवाद डॉक्टर पंकज। जैसा कि मैंने बताया था कि इनका व्याख्यान हमेशा से ही अच्छा रहता है और हर बार कुछ ना कुछ नई जानकारी दे करके जाते हैं। बस वही कंट्रोवर्सी अभी भी शायद थोड़ा सा पता नहीं क्लियर हुई है लोगों को नहीं कि फर्स्ट ट्राइमेस्टर में देना है या नहीं देना है। PCOS को सोचते हैं तो देना है, लेकिन फर्स्ट ट्राइमेस्टर में मेटफॉर्मिन एज सच जितनी भी डायबिटीज़ एजेंसीज हैं वो मना करती हैं देने के लिए। तो मैसेज क्या लेकर के जाना है?
मैसेज मैं नहीं, मैसेज आपकी मिनिस्ट्री दे रही है। इज रिकमेंडेड फॉर यूज बियॉन्ड 20 वीक्स ऑफ जेस्टेशन।
मतलब नहीं देना है।
तो फर्स्ट है, मतलब ये तो साफ साफ ये कह रहे हैं 20 वीक्स के बाद तो बहुत हुआ है, उसके पहले कि जितनी गाइडलाइंस है सबने दी है, यूज़ की है, लेकिन अभी मेटफॉर्मिन अभी भी रिकमेंडेशन वाली स्टेज पे डर है, क्योंकि प्रेगनेंसी में बहुत ज़्यादा एथिकली ट्रायल्स नहीं किए जा सकते, कंपैरेटिव ट्रायल्स नहीं किए जा सकते उसके कारण से। और पीसीओडी में जब देते हैं तो डायबिटीज़ में क्यों नहीं दे सकते, मेरी समझ से परे है, ये कानूनी भाषा है।
सर एक क्वेश्चन था, एक वन लेडी हुज कंसीव्ड हैड दिस जेस्टेशनल डायबिटीज़, डिलीवरी हो गई, नेक्स्ट प्रेगनेंसी प्लान करिए, व्हाट आर द प्रिकॉशंस वी शुड टेल हर टू टेक एंड व्हाट काइंड ऑफ मॉनिटरिंग डू वी नीड टू डू?
बहुत बढ़िया। और ये मैं तो हमेशा प्रेगनेंसी में दो चीज़ें होती हैं जो मैं कहता हूँ। एक तो मैं कहता हूँ कि देखो पेशेंट को मैं पहले समझा देता हूँ, देखो यहाँ पे मेरी और गायनी के बीच में कुछ बातें मेरी चलेंगी, कुछ गायनी की चलेंगी और बीच में फंसोगी तुम। तो इसलिए ये बातें मेरी सुननी है, ये वाली बातें गायनी की सुननी है, नंबर 1 है। लेकिन वेन एवर इन डाउट गायनी, कंसीडर गायनी, क्योंकि काम उनको कराना है। डिलीवरी के बाद मैं यहाँ पे कहता हूँ, अब यहाँ पे जो मेरा कंट्राडिक्शन किससे होता है, मैं कुछ कहूँगा और तुम्हारी माता जी और तुम्हारी सास जी कुछ कहेंगी। वो कहेंगी तुम खूब खाओ, और डॉक्टर तो पागल होते हैं, वो तुम्हें खूब मावा, लड्डू, देसी घी और खूब बढ़िया बढ़िया माल खिलाएंगे, तुम वेट गेन करोगे। उसके बाद प्रेगनेंसी के बाद जो हमारी जीडीएम नॉर्मली सप्रेस हो जाती है, 1/3 केसेस में वो नॉर्मल हो जाते हैं, 1/3 में नेक्स्ट प्रेगनेंसी में जीडीएम होते हैं, और 1/3 में यूजुअली नेक्स्ट प्रेगनेंसी में वो डायबिटिक फ्रॉम बिगनिंग होने की संभावना बढ़ती जाती है। तो वास्तव में अगर किसी महिला को जीडीएम रहा है तो ये हमारे लिए बहुत अच्छी अपॉर्चुनिटी है कि हम उसको बता सकते हैं कि तुम्हें जीडीएम रहा है, तुम्हें आगे चांसेस ज़्यादा हैं। तो जब डिलीवरी हो गई 15 दिन निपट लो, 15 दिन के बाद अपने फ्यूचर वेट को ध्यान में रखो। तुम्हें वेट गेन नहीं करना, बल्कि जो एब्डोमिनल फैट है वो लूज करना ही करना है। हमें लो फैट डाइट, फिजिकल एक्टिविटी पे रहना ही रखना है। बहुत क्लोजली मॉनिटर, कम से कम महीने में एक बार जरूर अपने टेस्ट करते रहो, क्योंकि नेक्स्ट प्रेगनेंसी जब हमें प्लान करनी है उस वक्त हमें ठोक बजा के ये देख लेना है कि हमारा ग्लाइसेमिक स्टेटस ठीक है कि नहीं है। जब सब ठीक हो तभी प्रेगनेंसी प्लान की जाए, अदरवाइज पहले से ही हम कुछ मेडिकेशन लेके उसको परफेक्ट यूग्लाइसेमिक स्टेट में तब कंसेप्शन कराएं, क्योंकि जो इनिशियली 1-1.5 महीना निकल जाता है, आप मुझसे अच्छी तरह से जानती हैं कि उसके कॉन्सिक्वेंसेस कितने खराब होते हैं। क्योंकि हमारे पास तो सारे हरे हरे केस आते हैं, बिगड़े हुए आप ही के पास रह जाते हैं। जी
जी डॉक्टर संदीप, कुछ आप प्रकाश डालेंगे?
सर मैं तो सिर्फ एक लाइन कहूँगा, लाजवाब।
धन्यवाद।
थैंक यू वेरी मच, एंड थैंक यू वेरी मच डॉक्टर पंकज फॉर मेकिंग इट। मुझे मालूम है आपको जो है रास्ते में भी बहुत कष्ट हुआ, मैंने भी बहुत उसमें वहाँ कहा, लेकिन आपके बगैर हमारी कॉन्फ्रेंस भी अधूरी रहती। आपका पहुँचना इसलिए बहुत अहम था। थैंक यू वेरी मच।
मैंने आप लोगों को प्रतीक्षा कराई, इसके लिए मैं शर्मिंदा हूँ, लेकिन जुबानी साहब ने बचा लिया मुझे।
मैं अब रिक्वेस्ट करूँगा हमारे यंग COO डॉक्टर सुनील से कि वो आके सबको सम्मानित करें। लाओ भाई, आइए जरा स्टेज पे सामने की तरफ आइए।
very much. Thank you very much, Pankaj, for making it and for enlightening us on GDM, a tricky issue. अब इतना सब कुछ सुनने के बाद आइसिंग ऑन द केक, भाई अब हमारा बम्बई से आया मेरा यार दोस्त को सलाम करो, तो वह ये है none other than Dr. Deepak Jumani. Dr. Deepak Jumani, he will be speaking on chemistry and physics of love. For this session, I would like to invite the chairpersons, Dr. Mohib Hamidi. Dr. Mohib Hamidi to please come to chair the session. Dr. Pradeep Sethi to please come to chair this session. And for this, I would like to request that you should introduce the speaker and call the speaker for his deliberations. और मुझे मालूम है तुम भी आओगे, तुम भी आ जाओ, लेकिन इस बार हनी नहीं मिलेगा। और मुझे मालूम है कि इसमें क्यों इनका जो है लेक्चर सबसे बाद में रखा गया है। मैडम, वजह ये रहती है कि ये बहुत ज़्यादा टाइम देते हैं, तो दूसरे स्पीकर का टाइम खा जाते हैं। तो इसीलिए जब भी कभी हम कॉन्फ्रेंस में साथ साथ बोलते हैं तो मैं हमेशा ये कहता हूँ दीपक जुमानी से पहले मेरी टॉक कर दो, क्योंकि बाद में रखेंगे तो मेरा टाइम जो है खा जाएंगे। दूसरा, जब ये बोल के ख़त्म करते हैं तो लोग 15 मिनट तक तो हैंगओवर में रहते हैं, तो दूसरे की टॉक ही नहीं समझ में आती उन्हें कि दूसरा अगला वाला क्या बोल गया। सो वेलकम डॉक्टर जुमानी, एंड आई विल रिक्वेस्ट ऑल द chairpersons to please introduce the speaker and invite him for the talk.
डॉक्टर दीपक जुमानी को इंट्रोड्यूस करना एक बहुत खुशी होती है मुझे। बहुत अच्छा, इनसे पहले भी हमारा इंटरेक्शन रहा है, पहले यथार्थ में, और सब कोई इनको सुनने के लिए बेताब होते हैं, तो मैं बीच में नहीं आता, सबसे पहले इनका शुरुआत सुनूंगा मैं।
शुक्रिया। Around the world, people love. They sing for love, they dance for love. There are poems, there are ballets. They kill for love, they die for love. In fact, we all sitting here are victims of love. We are all born out of love. But he's told, don't talk about it. I thank Dr. Soni and his team. And I'm really delighted while making this talk. We should understand that the most powerful energy on this earth is love. It's a very sweet emotion. The neurosciences, neurobiology, neuropharmacology and neuroimaging have opened up so much that today every emotion can be studied. It is not abstract. They found out that with neuroimaging and functional MRIs, you can identify certain areas of our brain which get activated in various emotions. In this next half an hour to 40 minutes, I'm going to give you some nuggets of wisdom as to how we understand this concept, this sweet emotion, whether it is physics of love or whether it is chemistry of love. With pranams to God and thanks to my teachers who made me what I am today, Dr. O.P. Kapoor, Prakash Kothari and Shashank Joshi, I beseech them to bless me always. I have certain disclosures. I am not from Congress, BJP, Shiv Sena or Aam Aadmi Party. I am not a follower of Asharam Bapu, Radhema or Ramdev Baba. I am not married to Indrani Mukherjee.
I'm a staunch APIite and have a mission to educate the masses on ethical sexual science and medicine. What is love? It's a force in nature that excites our bodies, expresses our identities and touches our souls. It's always been within us. To acknowledge it or not is a defining question. How we manage it determines the value it can have to enrich our life. It connects our deepest self to the world outside. Love is a matter of chemistry, and sex is a matter of physics. And science of love is both chemistry and physics. Unless we love and are loved, each one of us is alone. Each one of us is deeply lonely. In every religion, there is love, yet love has no religion. I have found out what is love. It's not just a single entity. It's not just one thing, one name, or one word. It has 9 ideas. I call it 9 nouns of love. It's an idealized ambition which we are on. It's a deal which people make consciously or unconsciously. It's a bond that gets created. It's a moral commitment. It also is a great intra-psychic day-to-day management work to maintain that commitment which you took. It's a force in nature. It's a transient emotion. It's an illusion and a stop sign. It's a label we give to a range of transient emotional experiences which we have, which gives us pleasure and happiness. These are the 9 nouns of love. But the most illuminating thing in life is the verbs of love. Falling in love is easy. Staying in love, being in love is also okay. But the most exhilarating thing in life is staying in love. So what is the chemistry of love? Where is love situated? Can anyone tell me? Is it in the brain or is it in the heart? Dr. Helen Fisher said, she is a very big scientist and a psychology professor, that love and desire activate specific but related areas in the brain. She put more than 1,000 couples in the MRI machine who were in love, who left with love, who were devoid of loves. So, what is heart? It's a place where you have feelings, emotions, beliefs and values. What is brain? It's a place where you think. It's logic, understanding. It requires proof and evidence. It's a domain of cognition, reason, science and proof. When we are in love, there is at times a conflict between heart and the brain. The process thinks differently. The head thinks after analyzing the pros and cons, but the heart just flows regardless of the evidence. But it's been proven that heart also is a little brain. There are 40,000 sensory neurons relaying to the heart, to the brain from heart. There are hormones produced in the heart itself. Biomechanical information is sent via blood pressure waves. Neurons within heart enable heart to learn, remember and make decisions independent of brain. Electromagnetic field of the heart is incredibly strong. It can excite synchronous rhythm. And that which divides us is simply the mind. Harry Furlow, in 1958, when he was addressing the American Psychological Association's annual conference, he said, love is a wondrous state, deep, tender and rewarding. Because of its intimate and personal nature, it's regarded by some as an improper topic for experimental research. But after that, scientists have not looked back. They have now identified why we love, why we have extramarital affairs, why we hate, why we are jealous, why we get angry. Well, let's study love in humans. It's nothing but attachment system. There are 3 types of loves: maternal love, romantic love, and filial love between the friends. And all these have evolutionary purposes of perpetuation of species, care of offsprings, and bonding for mutual good. Well, monogamy, or at least serial monogamy, ensures partners stay together for sufficient time to take care of the offsprings. Let's understand the chemistry. At the first stage, when you are in love, it's a stage of lust. It is driven by the sex hormones. You are hijacked by testosterone or estrogen. A man's physical features indicate higher androgen levels. A female physical features indicate higher estrogen levels. This is the first stage. Hormones and neurotransmitters hijack you in every stage of life. At the first stage, it is testosterone and estrogen. The stage 2 is attraction. This is an amazing time when you are truly love struck and can think of nothing else. Scientists think that there are 3 main neurotransmitters involved in this stage: adrenaline, rush, dopamine, and serotonin. Dopamine gives you reward feeling. Serotonin makes your mood to meet again. And the third stage is attachment, is the bond that keeps couples together long enough for them to have and raise children. Scientists think that might be 2 major hormones involved in this feeling of attachment are oxytocin and vasopressin. Let's talk about romantic love. Our mammalian brain system for mate choices, the components are the sex drive, which motivates individual to seek a range of mating partners. Attraction motivates individual to prefer and pursue a specific partner. Attachment motivates individuals to remain together long enough to complete species-specific parenting duties. When somebody is in romantic love, he has increased energy. दुबला पतला लड़का भी लड़की को भगा के लेके जाता है. Focused attention, thinks of nothing else. Obsessive following. He doesn't care about his work, nothing. पीछे भागता. Affiliative gestures for her or him. Possessive mate guarding. If anybody tells anything to the girl, man gets hurt. It's motivation to win a preferred mating partner. And all these have neuroendocrine roots. One more important thing which acts as far as chemistry is concerned is smell and sight. In humans, the main odor producing is the skin through its apocrine sebaceous glands, which develop only during puberty and are associated with sweat glands and tuft of hairs. These glands are located everywhere in the body but concentrated at certain areas. 6 areas: the axilla, the nipple, the pubic, genital, circumoinal, circumoral, lips, eyelids, and the outer ear. 1 gram of axillary hair, so many hormones involved. Whereas DHEAs, androstenone sulfate, are 1,000 times more in amounts in these specific areas. These are steroids, also known as pheromones. They are attractogenic. In human, pheromone that attracts a woman is androstenone, exerting a positive effect on her mood, cognition, heightened sympathetic nervous system. Beer et al. Suggested a possible link between steroid hormone action and the induction of pheromone production by investigating the localization of androgen receptor and estrogen receptor in this area. And what's more important, the motivations involved in predominantly testosterone and estrogen. The nuclei in the brain is amygdala. Dopamine, norepinephrine, and serotonergic systems in ventral tegmental area and nucleus accumbens. Vasopressin and oxytocin in ventral pallium and raphe nucleus. So the neurobiology of how did we learn about it? This is a secret which I am going to enclose to you all. Knowledge gained by this chemistry of love was studied in voles. These were rats. And this scientific study of brain in human emotions was done by fMRI, functional magnetic resonance imaging, and PET scan. So these are prairie voles known as Microtus orcagaster. The peculiarity of these prairie voles that they are monogamous. They will never look at any other partner whom they are with other than that. The others are montane voles and meadow voles. Pair bonding and partner preference in these, the prairie voles are monogamous and non-monogamous uniparental are montane and meadow voles. So these innocent rats have taught us what is love. Majority of prairie wolves are so committed to their partners that they never take on another side losing them after losing their mate. Let me give you a deeper understanding. There is a brain-body dialogue which keeps on happening. Love ignites through a powerful dance between the brain and body, the ventral tegmental area of our brain's reward center, and the hypothalamus release hormones that fuel passion. Meanwhile, the physical responses like racing heart, dilated pupils reveal deep attraction, pheromones also. This intimate brain-body dialogue weaves the excitement, attachment and bonding that make romantic love so exciting. And all these things are involved. There are certain areas. Now what is more important for us to understand as humans is oxytocin and vasopressin. These two hormones are emotionally and genetically very closely linked to their genes, and they are present on the short arm of chromosome 20. And both are nanopeptides with 2 amino acid different, even though they have significantly different functions. Conventionally, we know the actions are on the supraoptic and paraventricular nuclei. Oxytocin is also known to contract a myometrium during labor and milk letdown. Vasopressin is for water balance, blood pressure regulation. But now new thing which have been identified is that there are something called as oxytocin receptors and vasopressin receptors. This is the brain of the prairie vole. When they mate, mating activates the ventral tegmental area, okay, resulting in increased dopamine activity in the prefrontal cortex and nuclear accumbens. They start liking it. Olfactory signals from the olfactory lobes transmitted via the olfact to the medial nucleus again attract them. Oxytocin acts on accumbens and vasopressin acts on the lateral septum to facilitate olfactory learning and memory. They try to, that's for partner preference. Mating also stimulates increased extracellular concentration of oxytocin in the prefrontal cortex and nuclear accumbens of females. Glutaminergic projections from the prefrontal cortex and nuclear are thought to be important in reinforcement and therefore potentially in pair bonding. A beautiful study done on while doing MRI. These are the sections of brains of prairie voles. Remember, prairie voles are monogamous, and these are the brain sections of the montane voles which are polygamous or non-monogamous. And the oxytocin receptors in the prairie voles are seen in various areas, and vasopressin receptors are seen in this. But in montane voles, you don't find any of these receptors, or very few receptors are there. What scientists did is, they did block these prairie voles by giving them oxytocin antagonist to the monogamous voles. When they blocked oxytocin receptors, these prairie voles became polygamous. They also blocked the vasopressin receptors. So these prairie voles became polygamous. They were monogamous, but these receptors which were blocked, they became polygamous. So what is the thing we learn from here? That oxytocin is for fidelity. Oxytocin gives a man to bond with one particular person. Same was with transgenic modes. When they blocked those receptors, they were polygamous, became monogamous. And of course also with pair bonding. Similar thing was seen in dopamine, was more released in these monogamous voles. So oxytocin and vasopressin role in pair bonding is very important. Differential expression of oxytocin and vasopressin in monogamous versus non-monogamous roles were learned. Strong association with dopamine reward system, responsible for partner preference and bonding after mating. Blocking oxytocin and vasopressin in prairie voles makes them promiscuous. Expressing prairie voles vasopressin in montane and meadow voles makes them monogamous. And of course dopamine mediated reward system. These are the implications. What are the implications of all these in humans? This is about rats. So when we look at the love areas of brain in the voles, our brain also have a similar areas. There are certain areas which get activated when you are in love. Our medial insula, anterior cingulate cortex, hippocampus, striatum, nuclear hypothalamus. And these areas which get deactivated are amygdala, frontal cortex, prefrontal cortex, temporal poles and parieto or temporal chunks. And the important components of brain reward system. And here what we see when these areas get deactivated in human brains, there is amelioration of fear, there is decrease in negative emotions, mentalizing, evaluating other intentions are not there at all. And these are the studies done for the various brain activities which have been seen by Helen Fisher and many other scientists showing that. But what is more important for us to understand, that dopamine, which is present during love, is a euphoria creator. It is known as a pleasure hormone. Dopamine surges through your brain during the early stages of love, creating an almost addictive feeling of euphoria and joy. It then goes to intense focusing and craving. This powerful neurotransmitter triggers intense focus on your beloved, making you crave their presence constantly. Everything else fades into the background. And lastly, when they injected cocaine, they started getting this feeling, and similarly dopamine also produced the same thing. So love is like a drug, it's like an addiction. That's what has been proven. Oxytocin enhances brain reward system, studied beautifully by the activation of several centers in the brain which are also seen in the rats. Now serotonin and adrenaline, serotonin increases your mood. It's an obsession chemical. Serotonin regulates mood and emotional balance. Interestingly, falling in love actually lowers serotonin levels, which can trigger obsessive thoughts about your partner, explaining why you simply can't get them out of your mind. Adrenaline, we all know, is a thrush. So when this gets rushed out, this doesn't remain forever. Chemical rush phase is initial 12 to 24 months, love driven by intense neurochemical reactions. Everything feels magical, effortless and destined to happen. Then there's a transition period. Hormonal intensity actually decreases after some time. Relationship face their first real test as the biochemical fog lifts into them. And the last is conscious love. Lasting relationship require deliberate choice, emotional maturity and commitment beyond biological. The truth about lasting love is that love initially is driven by chemistry, is compulsive and temporary. While these powerful hormones kickstart attraction, awareness and emotional maturity helps sustain love after the chemical rush fades. Real love becomes a daily choice. There are of course gender differences, romantic love is different. And what is the stimuli for oxytocin? In women, when we think maternal love, antepartum thoughts about the unborn child produces oxytocin in her. Visual cues about the child face produce oxytocin in her. Breastfeeding, touch, hug of the child. Whereas in romantic love, the smell, the auditory visual cues, the partner hugs, massage, breast and nipple stimulation and orgasms are stimulants of oxytocin. Oxytocin during the initial stage of romantic attachment has been studied beautifully. Like if you are single, you have less oxytocin. If you are new lovers, of course you have more. If you again continue to love for a longer time, it's more. Whereas if you are staying together, it's more. Where you are staying separate, it's again. So oxytocin, friends, has been now understood to be a bonding hormone. It is released during physical intimacy, hugging, kissing, cuddling and sexual activity. This remarkable hormone builds trust, emotional closeness and long-term attachment between partners. Often called today as love hormone, oxytocin influence extends beyond romantic relationships. It plays a crucial role in maternal bonds between mother and babies and strengthens all forms of social connection. The more time couples spend in physical closeness, the stronger their oxytocin mediated bond becomes, creating a virtuous cycle of affection and attachment. So today beautifully we call oxytocin. In new lovers it is higher in plasma as compared to non-attached singles. Vasopressin has been understood to be a loyalty and long-term, it's called a monogamy molecule. Vasopressin works hand in hand with oxytocin to promote monogamy, faithfulness and overall relationship. Whereas fidelity factor, scientific studies reveal that higher vasopressin levels correlate with reduced infidelity and stronger partner preferences. The more vasopressin, the more devoted you feel. So this hormone encourages feeling of loyalty, protective behavior and mutual support. The foundation of lasting partnership that weathers life storms together. Oxytocin, friends, is a versatile. At birth you need it, at parturition you need it, in adolescence and everywhere. So today we call oxytocin is a love hormone, trust hormone, cuddle hormone, fidelity hormone, healing hormone, feel good hormone. And positive effects are, it is an anxiolytic. Once you have sex, you don't have anxiety. Increases partner attractiveness, improves fidelity by making men keep a greater distance from other women, improves eye contact, empathy, improves trust, improves social attention, recognition and appraisals. So intranasal oxytocin now is available. It reduces the conflict between partners. It increases cooperativeness. It increases the mutual understandings and perspective taking. Positive relationship reflect autism, it has been clear, given very rampantly, depression, anxiety and schizophrenia. So healing power of love is because of the pleiotropic effect of oxytocin, long-term lasting love. It down-regulates the HPA axis, ameliorating chronic stress. Oxytocin receptors in heart, precursors of oxytocin, crucial in fetal heart development, differentiation of stem cells into cardiomyocytes, facilitation of adult neurogenesis and repair, anti-inflammatory and antioxidant properties have also been studied. So it can explain. So love is nothing but an orchestra or an endocrine soup of all these hormones and neurotransmitters. In love, physics meets chemistry. While biology explains what hormones do, love exists at an intersection of chemical reaction and the energetic reactions. Let us understand what is the physics behind it. We know in physics forces cause motion and connection. Similarly, love can be viewed as an attraction force between two individuals, a vector pulling them together mediated by energy exchange and emotional resonance. Energy and frequencies. Every object in universe vibrates with a certain frequency. In relationship, emotional energy resonates. When two people vibrate at compatible frequencies, harmony exists. Love then can be understood as a resonance between two energy systems. Charged particles attract or repel each other depending on the polarity. So the electromagnetic analogy of physics and love is likewise human experience attraction based on emotional polarity, biochemical compatibility and shared charge, physical, intellectual and emotional. Quantum energy, we all know about GPS. Quantum entanglement describes two particles connected such that the state of one instantly affects the other regardless of distance. So in love, partners often experience a similar emotional and intuition, empathy and synchronicity across space. Then there are thermodynamics also. Relationship require energy input to sustain order and connection. It's not that once I love, everything is over. No. If emotional energy is not replenished, entropy increases, leading to disconnections. Love thrives when energy exchange remains balanced and sustainable. The gravitational pull, just as the gravity draws an object together, love exerts a kind of emotional gravity. The greater the emotional depth, shared experiences, the stronger the generation. And time dilation, Einstein explained the time that when you are together, you feel there is no time, it's fast. But when you are away, you feel abhi waqt guzarta nahi hai aapke bagair. And conservation of energy. Energy cannot be created or destroyed, only transferred. Similarly, love transforms passion to companionship, attraction to empathy, desire to devotion. Love ensures our every thought, feeling and deed will glow with this vibrant energy. The physics of heart, when two lovers' hearts synchronize, studies show coherent rhythm patterns. This biological entrainment mirrors the synchronized oscillating system in physics. The unified effect of love we all know. In human life, love is a unifying force connecting mind, body and consciousness, the energy that binds all existence. So the physics of love is that love obeys the same universal laws that govern matter and energy. It is both measurable and mysterious, physical and metaphysical. Understanding the physics of love helps us appreciate it's not a magic alone. but as the most beautiful expression of universal order. Friends, a life without love is not a life fully lived. Although research into mechanisms through which love protects us against stress and disease is in its infancy, this knowledge will ultimately increase our understanding of the way that our emotions have an impact on health. But we have much to learn about love and much to learn from love. This is the chemistry, as I've already explained, what are the hormonal changes. Now, this is the world of artificial intelligence. So what are the future trends of emerging research in this science of love chemistry? In 2023, advances were seen, and we have seen what has happened. In 2024, studies explore microbes' powerful influence. In 2025, some more research has come. 2026, something else will come.
Love. Golden, do you love me?
Do I what?
Do you love me?
Do I love you?
Well?
With our daughters getting married and there's trouble in the town, you're upset, you're worn out, go inside, go lie down. Maybe it's indigestion.
No, Golden, I'm asking you a question. Do you love me?
You're a fool.
I know. But do you love me?
Do I love you?
Well.
For 25 years I've washed your clothes, cooked your meals, cleaned your house, given you children, milked your cow. After 25 years, why talk about love right now?
Golden, the first time I met you was on our wedding day. I was scared.
I was shy.
I was nervous.
So was I.
But my father and my mother said we'd learn to love each other. And now I'm asking, Golden, do you love me?
I'm your wife.
I know. But do you love me?
Do I love him?
Well?
For 25 years I've lived with him, fought with him, starved with him. 25 years my bed is his. If that's not love, what is?
And you love me.
I suppose I do.
And I suppose I love you too. It doesn't change a thing, but even so, after 25 years, it's nice to love.
So love has no expiry date. It's a noun and a verb. All those who are in love will understand this beautifully. It's about connection, sometimes disconnection, sometimes reconnection, disconnection, reconnections, etc., etc. Indian perspective of love, physics, chemistry and consciousness. Ancient wisdom meets a modern science. Our Rig Vedas have written all these things. Yajur Veda, Rig Veda, you have all these. Traditional Indian wisdom beautifully aligns the neurosciences. Love is described as the sweetness of emotion, an emotional state that transcends not only mere physical attraction. Indian philosophy, prem, pure love, is distinguished from kama, which is desire. Whilst chemistry initiates attraction through a biological impulses, conscious love rooted in bhakti and karuna nurtures lifelong partnership. Balancing nature's powerful impulse and mindful conscious connection is the key to lasting love. This integration of heart, mind and spirit creates a relationship that flourishes across decades. So if you want to cultivate healthy love, chemistry, physics together, you have to build trust, manage stress and keep excitement alive. So I conclude that love is the chemistry but also Biology begins it, consciousness sustains it, and wisdom perfects it. Choose sweetness, trust, commitment to keep love alive beyond the chemistry. Embrace both the magic of nature's design and the beauty of conscious devotion. True love is where science meets the soul. This is the physics and chemistry of love. Friends, my take home for all: with love, ignite the chemistry and elicit physics of love in you. We all are great doctors, pandits, healers, but we should remember what Sant Kabir said.
पोथी पढ़ पढ़ जगमुआ पंडित भया न कोई, पोथी पढ़ पढ़ जगमुआ पंडित भया न कोई, ढाई अक्षर प्रेम का पढ़े सो पंडित हो.
So, communication, courtesy, commitment, embrace the beauty of change. If you are 60, 70, enjoy the wrinkles. You are lucky you reached that stage. Don't feel bad about it. Nothing wrong. Embrace the beauty. Enjoy everything you do together. Rediscover pleasure, new positions, massage, tools, toys, etc. Only love can be divided endlessly and still not diminish. It never expires. It's an everlasting force in life within us. You don't have to buy love from outside. Friends, this is my book, Sex Has No Expiry Date. My last slide is, love is like physics. Its rules govern the cosmic matter, energy and everything between. Love is the chemistry which intersects the force and energy within us. Oxytocin, once a labor hormone, today is a love hormone. Love is an orchestra and endocrine soup of all these hormones and neurotransmitters. A beautiful symphony or a delicious soup to create is our choice. Love is also the sweetest poetry of emotion, and it has no expiry date. Thank you all for your love.
Thank you.
I think.
Do you think that there is any questions? Should I open the house for the question answers about it?
Few lines.
Yes, Dr. Meena.
It was a beautiful scientific and at the same time poetic presentation. Right?
Thank you.
It was beautiful. I would just like to add few lines.
Oh.
Love is life, and all you need is love. All you need is love to stay happy and keep the people around you happy.
Exactly.
Dr. Jumani, you have got a competitor. Well, thank you so very much. Yeah, sure. Oh, why not? First Dr. Gulati, then you. Okay.
Thank you very much. Thank you, sir.
Thank you.
Dr. Jumani.
Thank you.
It's been an exciting lecture. Lecture is a bad one. I think it's a poem of love you have created, but I'm also a student of sexology now. I'm coming to a very controversial issue.
Okay.
For the sake of God. In the various civilizations, for example, Christianity, sex started as a sin. Now, whereas in our Indian Hindu Sanatana Dharma, we have got a temples raised to love.
Yes, Khajuraho, Cambodia, so many, Konark.
No, just comment on this clash. Right from the beginning of the Bible, this is there, the general Bible. Please, I want your honest comment on this. I know it's a controversial one.
Okay.
The French priests were scared that when people start loving each other, no one will come to them. Whereas Indians, see, India is the one which has started sex education in the form of writing Kama Sutra, which are the aphorisms of love, which taught us it's not a sex guide, it's a guide to how to love each other. So, Indian philosophy is to share love and be happy. It's a normal, sex is normal and natural function of our life. Like passing stools, passing urine, eating food, heartbeats, breathing. These are all normal and natural functions. Sex also is our body's normal and natural function of our life. If it was not normal or natural, you and I would not have been here. We are not fallen from the tree or stars. So it's normal and natural. But these Christians felt scared, and that's how the taboo, and that continued. And that's the reason why it's still a taboo. We talk freely about piles, fissures to the doctors, to everybody. But when it comes to erectile dysfunction or ejaculatory issues, we don't talk about it. We feel he will judge me as an impotent. Nothing wrong. Today, every medical sciences have advanced so much, friends, that whatever is more in your body, say your sugars are more, cholesterol is more, your pressures are more, you can bring it down. And whatever is less, your vitamin D, uric acid, whatever is less, you can bring it up. So every cause of every sexual dysfunction a patient has can be managed. I boldly say that erectile dysfunction is a correctile dysfunction, and sex has no expiry date at all. From 9 years to 90 years you can have. And this is what our predecessors also said. That's why in the temples which were visited by children, male, female, adults, everybody, they depicted the normal life of those individuals. We were not ashamed of it. But Christians after that felt so, and the taboo continued. And it's still there. Though things are improving now.
Your question, sir.
Sir, you mentioned intranasal oxytocin.
Yes.
I'm an ENT specialist. I have no experience of any time using intranasal oxytocin. I just wanted to know from your experience whether it can help in nasal allergies.
Yes, it is. My 16 patients, 16 couples who had extramarital affairs, their wives came and cried. So I gave them intranasal oxytocin. And she gave their husbands this intranasal oxytocin as a perfume. And they changed. We have studies to prove. Autism it is given, anxiety it has been given, schizophrenia it has been given, depression it has been given. And this is a new science and new thing. If you want to make extramarital affair husbands or wives be monogamous, try intranasal oxytocin.
Wow. My question was for nasal allergy also we can get, because it will improve general
everything
well-being.
will improve. It's an antioxidant, anti-inflammatory. And nothing wrong, no side effects at all.
Wow. A good news to the society.
It's available today. It's available today in Mumbai and in, of course, many other places also. It's in Delhi, it's available.
Thank you very much. Please give a big hand to Dr. Jumani. And now I would like to request Dr. Gunjan Sharma, again a senior physician in our department here in Greater Noida, to please honor the speaker as well as the chairpersons of.
Thank you very much.
And dear friends, as is the law, that every good thing has to come to an end. I would like to know that how do you enjoy this evening? Whether you enjoyed, you learned something good, was it serious or not, or was it just a fluke? Please raise your hands if you have enjoyed the evening and the scientific session also. Yes, let me know. Wow, the majority they enjoyed. Thank you so very much for coming. And एक हमारा ज़रूर रिचुअल रह गई है जो कि बहुत ज़रूरी है किसी भी साइंटिफिक प्रोग्राम में, किसी भी एजुकेशनल फोरम पे। ये एक एजुकेशन को परकुलेट करने के लिए और एक आशीर्वाद लेने के लिए सरस्वती जी से कि हमें हमारा ज्ञान, हमारा जो सम्मान, ये सब सोसाइटी में भी बढ़े और हम अपने मरीजों की ज़्यादा बेहतर देखभाल कर सकें इस CME प्रोग्राम के बाद। तो इसके लिए मैं सबसे पहले इनवाइट करना चाहूँगा कुछ डिग्निटरीज को कि वो लैंप लाइटिंग के लिए आगे आए। सबसे पहले डॉक्टर मंजू मैडम, प्लीज़ आप आइए। डॉक्टर हमीदी, डॉक्टर सेठी, डॉक्टर सहाय, डॉक्टर सुनील, डॉक्टर कुंजन और हमारी फैकल्टी डॉक्टर पंकज, डॉक्टर जुमानी, प्लीज़ आप लोग आगे आइए ये लैंप लाइटिंग के लिए और हमारी स्मृति बंद। डॉक्टर राहुल, आप भी आइए प्लीज़। हाँ भैया, सरस्वती वंदना तो चालू कर दो हमारी। अब मैं रिक्वेस्ट करूंगा डॉक्टर मंजू मैडम से कि यहाँ आके कुछ दो शब्द कहें और हमारे इस प्रोग्राम में थोड़ा वर्ड ऑफ थैंक्स भी देंगी और उसके बाद डॉक्टर संदीप साहब।
गुड इवनिंग एवरीवन। जैसे डॉक्टर सोनी ने पहले ही कहा था, डॉक्टर जुमानी जी के लेक्चर के बाद ना तो कोई बोल पाएगा और ना ही कोई कुछ समझने के होश में रहेगा। तो शायद अब हम उसी मोड पे हैं, ना मैं कुछ ज़्यादा बोल पाऊंगी ना आप कुछ ज़्यादा समझ पाएंगे, इसीलिए मुझे लास्ट में बुलाया गया है। तो मेरी बातों में ज़्यादा ध्यान देने की ज़रूरत नहीं होगी आपको। आप सब यहाँ पर आए, अपना प्रीशियस टाइम दिया, उसके लिए आप सबको बहुत बहुत धन्यवाद। इस पूरे प्रोग्राम को एक सक्सेसफुल इवेंट बनाने के लिए मैं डॉक्टर मंजू त्यागी, डायरेक्टर ऑफ यथार्थ हॉस्पिटल्स, आप सबका यहाँ बहुत बहुत स्वागत करती हूँ। आपने जो आज टाइम दिया संडे के दिन अपने फैमिली टाइम में से निकाल के, और स्पेशली डॉक्टर सोनी ने जो हमारे डायरेक्टर हैं एकेडमिक्स के, इस प्रोग्राम को डॉक्टर सहाय और डॉक्टर सुनील के हेल्प से, सारे सीनियर फैकल्टी मेंबर्स के हेल्प से जो ये प्रोग्राम आज किया है, मैं सच बोल रही हूँ, मैं आई थी सोच के 1-2 लेक्चर सुनूंगी, लेकिन उसके बाद मैं यहाँ से उठ ही नहीं पाई। आपने स्टार्टिंग की बहुत छोटे छोटे टॉपिक से लेके, कुछ डिजीजेस से लेके, देन डाइट से लेके, देन हेल्दी फूड, एक्सरसाइज, बट लास्ट में लव नाम का भी कोई टॉपिक होगा वो मैंने नहीं सोचा था। और जब मैंने सुना कि लव टॉपिक होगा, मुझे समझ नहीं आया इसमें क्या पढ़ाएगा कोई, लेकिन सर ने बिल्कुल हमारी एक फिलॉसफी चेंज कर दी। अब तक लगता था ये टॉपिक जो है सिर्फ एटलीस्ट साइंस स्टूडेंट्स का नहीं था, लगता था कॉमर्स और आर्ट्स वालों का ज़्यादा था। आपने प्रूव कर दिया कि ये साइंस का टॉपिक किस तरह से है। एंड मैं खुद क्लियर कहती हूँ, आज तक ऐसा लेक्चर कभी नहीं सुना अपनी ज़िंदगी में। इट इज़ फर्स्ट फॉर मी, आई विल से, एंड थैंक्स सर इतना अच्छा लेक्चर हमें सुनवाने के लिए। एंड स्पेशली जो बाई चांस सर ने टॉपिक में क्वेश्चन तो कुछ और पूछा था नेजल ऑक्सीटोसिन के लिए, लेकिन आंसर हमें कुछ और मिल गया। मुझे लगता है कल से तो सबसे ज़्यादा इसी की परचेज होने वाली है। हमें फार्मेसी में कल से रखवाना पड़ेगा सबको मोनोगैमस बनाने के लिए। अगर कोई मोनोगैमस है भी तो शायद हर एक वाइफ चाहेगी कि नहीं 1-2 डोज देने में क्या बिगड़ रहा है, कोई साइड इफेक्ट तो है नहीं। एंड मैं आपको, यहाँ बहुत दूर दूर से लोग आए हैं, कुछ डॉक्टर्स तो हमारे से बहुत पहले से जुड़े हैं, शायद जब से हमने अपनी एक छोटी सी जर्नी शुरू की थी 2003 से, लेकिन कुछ लोग यहाँ बहुत दूर से आए हैं। उन्हें मैं एक छोटी सी अपनी जर्नी बताऊंगी। लाइक इट इज सेड, रोम इज़ नॉट बिल्ट इन अ डे। ऐसे ही ये जो इतनी बड़ी चेन है यथार्थ हॉस्पिटल की, जो आज हमारे पास 1000+ डॉक्टर्स हैं, हमारे पास मोर देन 2300 बेड्स हैं, 8 हॉस्पिटल्स हैं, ये जर्नी भी शायद एक बहुत छोटे लेवल से कहीं शुरू हुई थी। 2003 में बाय चांस मैं उन मेंबर्स में से हूँ जिन्होंने फर्स्ट वो शुरुआत की थी एक छोटे से क्लिनिक से 2003 में भंगेल से। अब कहेंगे यहीं से क्यों शुरुआत की? यहीं से शुरुआत इसलिए की क्योंकि ये हमारा होम टाउन है, यहीं हम पैदा हुए, यहीं के एक गाँव में। जो नोएडा तो अब बना है, हमारे लिए तो एक गाँव था, एक छोटा सा, जहाँ पर मेडिकल फैसिलिटी थी ही नहीं। मैंने 2003 में वो फेज़ देखा है जब हर ट्रीटमेंट के लिए हमें एम्स जाना पड़ता था, और एम्स जाने के लिए भी यहाँ पे बहुत फैसिलिटी नहीं थी। गांव के लोग तो उस टाइम में भी ट्रैक्टर से चले जाया करते थे बुग्गी में बैठ बैठ के। तो तब मैंने देखा जब मैं यहाँ पढ़ती थी कि कितनी प्रॉब्लम्स है मेडिकल फैसिलिटी के लिए। तो ये शुरुआत, जैसे सर ने कहा, शुरुआत तो लव से ही हुई थी। ये दुख होता था कि अपने लोग जो हैं परेशान हो रहे हैं, तो हमने शुरुआत की एक क्लिनिक से 2003 में, जो हमारा एक ही एम था कि जो लोग परेशान हैं, हमारे अपने हैं, जिनके लिए हमें अफेक्शन है, वो दुखी हैं, परेशान हैं, उनको हम मेडिकल फैसिलिटी दे सकें अपनी सोसाइटी में, अपने लोगों को। लेकिन कहीं ना कहीं ये चेन इंक्रीज हुई और फर्स्ट हमारा यथार्थ हॉस्पिटल 2010 में आया, जो प्रॉपर एक हॉस्पिटल था, और वो इस ग्रेटर नोएडा से ही शुरू हुआ था। यहीं के डॉक्टर्स ने उसको शुरू किया। देन 2013 में हमने नोएडा 110 का हॉस्पिटल स्टार्ट किया। 2018 में ग्रेटर नोएडा का 400 बेडेड हॉस्पिटल हो गया, जो पहले थोड़ा छोटा हॉस्पिटल था। 2019 में हमने एक्सटेंशन हॉस्पिटल स्टार्ट किया। ऐसे ही करते करते यंग जनरेशन्स आई, डॉक्टर्स से डिफरेंट लोग आए, हमारे सेकेंड जनरेशन स्टार्ट हुई, जिनका आइडिया था कि 3 हॉस्पिटल से तो हम सिर्फ नोएडा में ही ट्रीटमेंट दे पा रहे हैं, फैसिलिटी दे पा रहे हैं, पर तब भी हमारा हमेशा एम था, तब तक भी हमें गांव के लोगों को ये फैसिलिटी देनी है, गांव में कैंप्स करने हैं, गांव के लोगों के लिए हमें कुछ करना है, क्योंकि हम गांव से ही पैदा हुए लोग हैं। हमेशा हमारा एम जो है दूर सुदूर गांव में, लाइक बद्रीनाथ, केदारनाथ, गंगोत्री, यमुनोत्री से हमेशा डॉक्टर कपिल त्यागी जो हमारे एमडी हैं वो जुड़े रहे कि किस तरह हम वहाँ पर फैसिलिटी दे पाए। और हमारे बहुत सारे सीनियर डॉक्टर्स जो उस टाइम से हमसे जुड़े हुए हैं, उन्होंने हमेशा वहाँ जाके कैंप्स किए, और हमने ट्राई किया कि हम जितना हो सके सोसाइटी के लिए कुछ कर सके। 2023 में हमें लगा हमें अपनी ब्रांच, अपनी चेन को कहीं एक्सटेंड करना होगा, इसलिए हमने लॉन्च किया हमारा आईपीओ के बाद में हमने 4 हॉस्पिटल्स और ऐड किए। वो हॉस्पिटल्स हमने 2 फरीदाबाद में, देन झांसी में, मॉडल टाउन में, और अभी लेटेस्ट हमने आगरा में स्टार्ट किया। अब हम 8 बेडेड हॉस्पिटल्स हैं। इस जगह पे पहुंचने के लिए हमारे सारे डॉक्टर्स जो हमसे जुड़े रहे, उनका जो लव रहा, जो सर ने कहा कि घूम फिर के हर एक चीज़ की जड़ तो लव है, उनका लव, उनका अफेक्शन हम एक दूसरे के साथ और पेशेंट्स के प्रति जो था, उसकी वजह से यथार्थ चेन आज यहाँ तक पहुँची है। आज हम बहुत गर्व से कह सकते हैं कि हमारे पास मोस्ट ऑफ द फैसिलिटी, क्योंकि मेडिकल फील्ड धीरे धीरे इवॉल्व हो रही है, ऐसे ही यथार्थ हॉस्पिटल को भी इवॉल्व होना पड़ा। आज हमारे पास मोस्टली सारा ट्रीटमेंट्स अवेलेबल है, लाइक लीवर ट्रांसप्लांट, किडनी ट्रांसप्लांट, बोन मैरो ट्रांसप्लांट, कैंसर, रेडिएशन एंड लेटेस्ट द डा विंसी रॉबर्ट्स, क्योंकि जो भी लेटेस्ट आता है आपको उसमें आजकल अपग्रेड होते रहना पड़ता है। अभी हमारे पास मेन था कि चलिए 1000+ डॉक्टर्स हैं, 2300+ बेड्स हैं, लेकिन कहीं ना कहीं लगता था अभी भी हम शायद सोसाइटी में कोई चीज़ है जो हम नहीं कर पा रहे हैं। उसके लिए हमने स्टार्ट की DNB सीट्स। हमें लगा हमें सबसे ज़्यादा एम इस टाइम एकेडमिक्स पे करना चाहिए। हम जिस लेवल पर हैं हमें सोसाइटी में एकेडमिक्स पे भी फोकस करना पड़ेगा, और हमारे पास उसके लिए बेस्ट पर्सन थे डॉक्टर सोनी, जो पहले ही API में इतना कुछ कर चुके हैं कि सब लोग जानते हैं। तो इन्होंने हमारे स्टार्ट किया एकेडमिक प्रोग्राम, इस तरह से कॉन्फ्रेंसेस करना, प्लस DNB हमने स्टार्ट किया, नॉट ओनली इन स्पेशलिस्ट ब्रांचेस बट सुपर स्पेशलिटी में भी हमारे पास DNB है अभी, लाइक हमारे पास प्लास्टिक है, यूरो है और बहुत सारी ब्रांचेस में है। इस टाइम हम DNB के अंदर हमारे पास 70+ सीट्स हैं और हम सेकेंड हाईएस्ट हैं, सेकेंड लार्जेस्ट हैं DNB में नॉर्थ इंडिया में, लाइक वी आर द 3rd हाईएस्ट इन नॉर्थ इंडिया हॉस्पिटल चेन्स के उसमें। तो हम इस लेवल तक पहुँचे हैं, हम सबकी ये रिस्पॉन्सिबिलिटी है, हम सोसाइटी को नॉट ओनली एज पेशेंट्स बल्कि विलेजेस में जो लोग हैं या जो हमारे मेडिकल स्टूडेंट्स हैं, हम उनको क्या दे सकते हैं। हम सब अपने अपने फील्ड्स में एक उस मुकाम पर पहुँचे हैं कि अब हमारा सबका एम सिर्फ पेशेंट के ट्रीटमेंट के अलावा जो अपकमिंग डॉक्टर्स है, यंग जनरेशन है, उनको हम अपनी एजुकेशन से क्या दे सकते हैं। और यहाँ डॉक्टर सोनी ने, डॉक्टर सहाय ने, हमारे जो मेडिकल डायरेक्टर हैं, सब ने मिलके इतने टॉप शॉट, शायद मैं भी जिनसे आज तक नहीं मिली हूँ, मैंने सिर्फ उन्हें टीवी में देखा है, उनके बड़े बड़े नाम सुने हैं, उन लोगों को आज हमने खुद देखा, सुना, और हमें बहुत अच्छा लगा कि वो इस एज में, आई विल नॉट से कि सर ने पहले ही कहा कि किसी भी चीज़ की कोई एक्सपायरी डेट नहीं है, तो जस्ट आई डोंट वांट टू मेंशन द एज, बट मुझे लगा ये लोग इस एज में भी कितने अपने आप में परफेक्ट हैं, एकेडमिक्स में भी, अपनी हेल्थ वाइज भी। तो ये सब हम सबके लिए एक मोटिवेशन है, यंग डॉक्टर्स के लिए, मिडिल एज डॉक्टर्स के लिए, कि किसी भी चीज़ की एक्सपायरी डेट नहीं है, हमने जितना भी किया हमें अभी और आगे कुछ करना है। और सर से मैं बहुत ज़्यादा मोटिवेटेड हूँ। सर ने जो हिंदी में शुरुआत की, जो हिंदी में बोला, उन्होंने एक कॉन्फिडेंस दिया। हम चाहे हिंदी बोलें, चाहे हम इंग्लिश बोलें, चाहे हम कोई साउथ इंडियन कोई भी लैंग्वेज बोलें, लैंग्वेज से फ़र्क नहीं पड़ता। लास्ट में हम सबका एम एक ही है, सोसाइटी को ट्रीटमेंट देना, अपने यंग डॉक्टर्स को वो कॉन्फिडेंस देना कि कोई फ़र्क नहीं पड़ता आप क्या बोल रहे हैं, कितना आप में कॉन्फिडेंस है या कौन सी लैंग्वेज में आप बोल रहे हैं, आपका एम एक ही होना चाहिए, सोसाइटी के लिए कुछ करना, एंड विद लव। थैंक यू एवरीवन।
थैंक यू वेरी मच मैडम, थैंक यू। और मैं एक बात इस रेफरेंस में आपको बता दूं कि यथार्थ हॉस्पिटल की जो सबसे पहले क्लिनिक शुरू हुई थी बंघेल में, तो उसका नाम पब्लिक जो है इसी नाम से जानती थी कि डॉक्टर मंजू त्यागी का अस्पताल। वो यथार्थ तो बाद में बना, जो यथार्थ हॉस्पिटल बना, लेकिन शुरुआत में इतना पॉपुलर था वो हॉस्पिटल कि डॉक्टर मंजू त्यागी के अस्पताल के नाम से, कहाँ जा रहे हो, डॉक्टर मंजू त्यागी के अस्पताल में जा रहे हैं। तो इस तरह से शुरुआत हुई, दैट इज क्रेडिटेबल। वेल, थैंक यू वेरी मच। और आखिर में डॉक्टर संदीप साहब कुछ आके जो है वो हम सबको एक क्या सुनाएंगे, ओथ दिलवाएंगे, और उसके बाद हम लोग वाइंड अप करेंगे। डॉक्टर संदीप साहब प्लीज।
Thank you, sir, and thank you, madam, and thank you, a big thank you to all the delegates who have come here for Yatharth Medicon 2.0. Ladies and gentlemen, I couldn't believe that this could have been better than what I had imagined. It was marvelous. The speakers were excellent. Special thanks to all our senior faculty members who came here. Special thanks to one special gentleman, Dr. Pankaj, for his talk in the national language, in the Hindi deliberations that you carried out. I think it gives us a new insight as to how we can express sometimes even better in our own mother tongue. And ladies and gentlemen, it gives me immense pleasure to thank the associate staff, our nurses, our doctors, our support staff who helped us make this conference very, very successful. And last but not the least, I would like to pay special thanks to Dr. N.K. Soni, our academic head and director of the hospital and the Department of Internal Medicine. Sir, you have been a guiding force. You have been inspiration for all of us to continue this and maintain this legacy in times to come. A very, very special thanks to our director, Dr. Manju Tyagi ma'am, who took out her special time to be here amidst us. And last but not the least, to all our postgraduate residents who made it possible to come and listen to the talk and enlighten themselves in time to come so that you can become better specialists in everyone. So thank you all once again. Thank you, thank you, thank you. Ladies and gentlemen, before we proceed for the drinks and dinners and the evening entertainment which Guruji has made possible today, I would like to request you to please rise for a prayer. Please repeat these lines after me. Sarve bhavantu sukhinam, sarve santu niramaya, सर्वे भद्राणि पश्यन्तु मा कश्चिद् दुख भाग भवेत् न त्वं काम्ये राज्यं न स्वर्ग न पुनर्भवम् काम्ये दुख तप्ताना प्राणिना आति नाशम् वंदे मातरम् वंदे मातरम सुजलाम सुफलाम मलयज शीतलाम शस्य श्यामलाम मातरम वंदे मातरम शुभ्र ज्योत्स्ना पुलकितयामिनी फुल्ल कुसुमित द्रुमदल शोभिनी सुहासिनी सुमधुर भाषिनी सुखदां वरदां मातरम वंदे मातरम वंदे मातरम. Thank you. Please join us for drinks and dinner.
Thank you very much. And अब मैं म्यूजिकल टीम को बुलाना चाहूँगा, टोनी एंड हिज टीम, कि आप आएँ स्टेज पे और अपना सेटअप लगाएं और हमें म्यूजिक से थोड़ा सा रिलैक्सेशन दें. टोनी एंड हिज टीम.